cyclone Gulab having passed over. It's a beautiful Sunday morning today. It's clear blue skies, but dry bumpy roads, I understand. To make this Sunday even better, I, Dr. K. Sai Kiran, on behalf of the Department of Critical Care Medicine at Yashoda Hospital, Malakpet, welcome all the delegates and the faculty members today for this conference. Today's conference is titled Curves and Graphs in ICU. Over the next 4 to 6 hours, we are going to have about 7 talks focusing on some of the graphs and curves that we routinely see in ICU day in and day out of very important clinical relevance. At the end of the 7 talks, we are also going to have an exciting finish with a quiz, just to make sure that the speakers did a decent job during the day. To start the proceedings, I would like to invite the brain behind today's theme, our HOD, Dr. B.S.K. Krushi sir, to give a welcome note to the audience. Krushi sir, please.
Thank you, Dr. Sai. Good morning, you one and all. So, respected faculties, respected delegates and residents, welcome to today's program, our Curves and ICU. We thought it will start with a workshop actually, but there were some difficulties for making workshop. So for that reason we made into a type of skill station. So whatever the presentations are there, it's different case scenario based programs. So it will be easy to understand. If you look at all the topics, so each topic will be around, each topic will take at least 1 day to discuss. But it is concise to a limited time. So it may be, we presume that you have read something and you have some practical knowledge and some fundamentals we have added, so that for easy understanding. So let us, and this type of academic activities, we are very much interested to continue the program in the future also. And there is some, because of this situation, in unavoidable situation, last 1.5 years, we had a lag behind regarding the academic programs. So we thought we will carry forward the further programs in the future also. So thank you all for presenting here today. So yeah, please welcome Dr. Shah.
We will kickstart the day with our first talk. To chair the first talk, I would like to invite 2 of our chairpersons, Dr. Pawan Poddar, Senior Interventional Cardiologist at Yashoda Hospital, Malakpet, and Dr. K.C. Mishra, Head of Department Critical Care Medicine at Yashoda Hospital, Somajiguda. Welcome, sir. I would like you to invite the speaker and chair the session as well. Thank you.
Good morning, everyone. I welcome all of you to today's CME. For a young budding intensivist, interpreting the curves and the graphs in ICU is always a big challenge. I remember when I just entered my post-graduation, on the first day of my posting in ICU, the whole night I had lot of goosebumps. I had lot of appreciation about how I am going to interpret the curves and the graphs, mainly with regard to the ventilator. So I congratulate Dr. Krushi and his team for conceptualizing such a event. And I think we have a very amazing feast of lectures today, and they are certainly going to help the young budding intensivists to master the skill of interpreting these curves and graphs. So without wasting much time, I invite Dr. Shankar, who is a Senior Consultant Critical Care Medicine, Yashoda Hospital, Malakpet, for the first talk, and he is going to talk about CBC, IABP waveforms, CBC, arterial waveform and IABP waveforms.
So good morning all. I'm Dr. Shankar. I'm intensivist here. Without wasting too much time, so let's directly start the session, because already we thought of starting at 9 o'clock, but it is 10 minutes late. No problem, we'll catch it up. So
today's topic starts with CVP, arterial blood pressure and IRBP waveforms. So let's start with a question. So it's an interactive program, so try to answer quickly because without wasting time we have to catch it up. So this is a 66-year male patient in ICU following cardiac surgery, suddenly complained of lightheadedness, palpitations followed by shortness of breath, and the screenshot of the monitor at that moment shown in the next slide. So this is the screenshot of the monitor. Anyone identify what are the different waveforms? Just name the waveforms. What are the waveforms there? It is ECG, arterial blood pressure and CVT. Anyone identify what is abnormality over there? So I will give some clues. So there is absent A wave in the ECG, there is hypotension here and rise CVT. This is normal rhythm, this is abnormal rhythm. Can anyone identify what is abnormality here? So what is the rhythm? So P wave is not followed by QRS complex and the P wave is hidden here. So this is a junctional rhythm. What is junctional rhythm? The origin of rhythm is not from the AV node, it is from somewhere else, like AV node and Purkinje fibers. That's why the P wave is not followed by QRS complex. P wave is hidden in the ECG. So what is the abnormality you note here in the CVP? Anyone? So you can notice this rise CVP and this is A and C waveforms are fused. What is A and what is B form we will see. So this is fused A and C waves. So this is junctional rhythm, this sinus rhythm. So this segment of CVP which shows fused A and C waves. It happens in junctional rhythm because of atria and ventricle beat together. Because the origin of rhythm is AV node or distant to the left. So this is called canine waves. So what are different conditions which shows canine waves? One is complete heart block and ventricular pacing at junctional rhythm. So with this insight, we'll go into further details into CVP. So anyone name just what are different waves in CVP? Please be interactive. Yes, it is A wave, C wave, X descent, V wave and Y descent. So what is the cause of this A wave? Yes, what is the cause of C wave? It is bulge of tricuspid during the initiation of ventricular contraction. That's isovalvular contraction. What is the cause of this X descent? Atrial relaxes and at the time of ventricular contraction. Because there is a downward movement of ventricle during ventricular isolated contraction which causes atrial relaxation, because of which the pressure decreases in the atria. What is the cause of C wave? Venous filling and backward flow. Backward wave from the emptying of the tricuspid valve. So any abnormality in the tricuspid valve will hamper the C wave and V wave. What is the cause of Y descent? Opening of tricuspid valve will lead to emptying of atria. So this is atrial contraction, tricuspid valve to right atrium, downward of contracted right ventricle and back pressure wave and opening of tricuspid valve. So the A wave usually happens after P wave. P wave is absent in conditions like atrial fibrillation which causes the absence of A wave. The C wave happens after QRS complex. X descent happens before T wave. V wave happens after T wave. Y descent just before the next P wave. So you have to relate with the ECG to find out where to measure this CVP. So where do I measure CVP in cardiac cycle? You have to take a segment of ECG correlating with this CVP. You have to relate the waves, then you measure the CVP. Usually measure at A wave. So when do I measure CVP in respiratory cycle? In respiration, usually you have to measure CVP at the end of expiration. In spontaneous breathing, expiration causes high CVP. In ventilator patients, inspiration causes high CVP and expiration causes low CVP. So you have to look at where is the expiration point, there you have to measure the CVP. So we measure CVP at A wave during end expiration. So you have to look at end expiration during spontaneous and ventilator patients. So coming to next question, a 75-year male admitted with acute exhaustive COPD in ICU. 2 days ago with severe PH with right atrial dilatation. Patient had sudden hypertension associated with irregular heart rate. What does the monitor show? So what does the monitor show here? Anyone? AF. So what do you expect in AF? What is the abnormality here? Loss of airways. So next question. 30-year male presented to hospital with dyspnea, repeated hospitalization of heart failure with childhood history of rheumatic fever. He diagnosed with a valvular lesion which posted for corrective surgery. So this is a rheumatic fever with valvular lesion posted for corrective surgery with the following monitor. This is the monitor picture. Any abnormality you can notice here? CP is large. This is absent X descent and accentuated C wave which fuses with the V wave. So this is graphical representation. You can see C wave is accentuated fusing with V wave. These are called CV waves, regurgitated CV waves. Where does it happen? Regurgitated CV waves. We thought no, there are CV and V waves because of tricuspid valve. When there is abnormality of the valve, it causes this picture. Where do you see this picture? Tricuspid regurgitation. So the same patient, the next patient, detect the abnormality of the following with few bit rates. Anything you can detect here? Accentuated A wave and attenuated Y wave. So atria is contracting against some resistance. And Y wave is because of opening of tricuspid valve. So there is difficulty in opening of tricuspid valve, which is causing accentuated A wave and attenuated Y wave. Where does it happen? Tricuspidrosis. So other condition which condition causes this prominent A waves. So the atria beats against a resistance in conditions like tricuspid stenosis, pulmonary stenosis and pulmonary hypertension. What is the pathological condition which shows bifid CVP waveforms? You can observe here steep and abrupt X and Y descent. Where does it happen? So these are basically these all are exam questions, basics, and everyone should know it. By somebody if they ask something like steep, abrupt X and Y, then you should answer without thinking much. You see it in cardiac tamponade or pericardial constriction. Which one? This pericardial constriction. Okay. So attenuated Y descent or absent Y descent, the same picture. Where do you see? Tamponade. So a patient may be blood from a chest. What does the CVP show here? This is normal CVP, this is abnormal CVP. What do you think the abnormality there? We already discussed it. Prominent X descent and absent Y descent. Blood from a chest. Cardiac tamponade. So this is list of all the waveforms we discussed here. Coming to next waveforms. This finishes a CVP. The same patient with cardiac tamponade admitted in the ICU showed picture on the monitor. What is the waveform? This is a arterial waveform. So what do you see there? Already given a clue here. What did you see there? There is a difference between systolic pressures during inspiration. There is an inspiration variation in systolic pressure. Respiratory variation in systolic pressure. There is an increase in fall in systolic pressure during inspiration. This is inspiration waveform. That's called pulsus paradoxus. In pulsus paradox, there is exerted fall in systolic blood pressure during inspiration. That happens in tricuspid regurgitation. The same patient put on ventilator. Previous patient was on spontaneous breathing. The same patient put on ventilator. So what is the abnormality you notice here? Previously during inspiration the PT is falling. Here you can see during inspiration there is a increased BP. During expiration there is a fall in BP. These are the same condition. This pulsus paradoxus, but reverse pulsus paradoxus. So pulse products is complex patient, reverse pulse products in ventilated patient. So what is the system indicates? What is the system? Arterial transfer system. So just name the components of arterial waveform. Systolic of stroke, peak systolic pressure, systolic decline, diaphragmatic notch, diastolic runoff, and end diastolic BP here. Diastolic BP here. The ECG indicates electrical systole. The pulse this pulse indicates mechanical systole. It takes some time to reach from electrical systole to mechanical systole. That is time delay. So ECG, there is a difference between ECG. There is time difference between ECG and pulse. And from the heart, where do you place catheter also important. If it is close to the heart, less delay. If away from the heart, more delay. So this is electrical systole. This is mechanical system. This time delay. So what does it indicate? This indicates after contraction of the heart, there is a forward wave created the heart force and a reflected wave from the peripheral artery system. This combinedly makes a common pulse, which is what you see here. So the shape of the pulse depends upon both. So this augmentation after forward wave is because of the peripheral resistance of the artery system. If the resistance is more, this is more augmented. If the resistance is less, there is less component from this. And once you move from heart to the periphery, the systolic upstroke will be increasing. Slope of the upstroke will be increasing, and there is a high systolic. The peak of systole will be increased, and diastolic beat will be decreased. The diaphragmatic notch will move away from the peak. So these are the changes once you move from the heart to the periphery. So that's called distal amplification of the arterial pulse, which includes a time delay. So as we discussed, close to the heart will show early, away from the heart will show delayed pulse. And you can notice the slope of the waveform is increased, peak is increased, diaphragmatic notch will be far away from the peak, and definitely prominent diastolic waveform. And there is increased pulse pressure once you move from the heart to the periphery. The same thing you can notice here, distant waveform and peak is increasing once you move from the heart to the periphery. So this we discussed already. Normotensive patient will have less reflected wave, hypertensive patient elderly and diabetes patient will have more reflected wave. This combined pulse, the black one shows the combined waveforms. So what does the test indicate? What is this? To know what is the response of transfer system. What is dampening actually? Any system oscillates with some certain frequency. If you don't dampen the system, it will oscillate more and will decrease the fineness of the waveform. If it dampens more, also we will lose the fine details of the arterial transfer system. So normal dampening, normal non-distant waveform you can see. You can see it's proper diaphragmatic notch. Here it is a adequate dynamic response of pressure transfer system. Actually dampening means you have some force on the transfer system. If you remove the force, it will oscillate more. If you apply more force, over dampening, the waveform will be decreased. You have to remember like that. Dampening means have some force on the system. So over dampening. Over dampening means more force on the system, which causes decreased systolic blood pressure, increased diastolic blood pressure, and overestimation of the. It will cause increased pulse pressure. Okay, decreased. Whereas under damping cause less pressure on the system, it will oscillate more, and you may lose the fineness of this diaphragmatic notch. This happens. The cause. What are the cause of under damping, over damping? It is like thinking some air bubble, blood clot, or stiff tubing, or stiff pressure tubing. These are all the cause for underdamping, overdamping. So to say it is underdamped, the number of pulses is more than 2. To say it is overdamped, it is number of pulses less than 2. Or there will not be any oscillations. Got it? So this is the normalic waveform and hyperbolic waveform. You can see systolic pressure is decreased and there is separate effective wave, small wave because of less pressure by the peripheral system. So you can see different waveforms here. This is normal arterial blood pressure waveform. What does this indicate? Any abnormality you notice here? Diacritic notch is not there. And slope of the beat is increasing here. And the delayed systolic peak. There is time delay in the systolic peak. Where do you see this? Aortic stenosis. This picture you see in aortic stenosis. This is what does this graph indicates? This is experience like pulse. You see in aortic regurgitation where because of backward flow there is sudden systolic dip here and diaphragm notch will be delayed and there is less decreased diastolic blood pressure. So there is DVP is less in aortic regurgitation. So this picture we see in aortic regurgitation. Where do you see this picture? This spike and hump pattern. This we see in HOCM, where this mid-systolic collapse in blood pressure, causing the spike and hump pattern. So this is after correction of surgery of HOCM, the almost real normal waveform. So what is this SPE? Systolic pressure variation. It will be helpful in dynamic assessment of fluid resistation. That will be discussed later. You can notice that there is variation in systolic blood pressure. We have to take higher systolic pressure and lower systolic pressure difference. So coming to different types of pulses. So pulses biasedness. You will see this in arrhythmias and PVCs where each beat, every alternate beat will show difference in different rhythm and amplitude. There is less amplitude, rhythm also different. In pulses biasedness, it's abnormal. Where you can see it in PVCs and some arrhythmias. Pulses coherence, where it is strong and bounding pulse. Where do you see? In high overload status, like anemia, aortic regurgitation. Where do you see fast upstroke? In mitral regurgitation, aortic regurgitation. You can see fast upstroke. The sharp peak here. Slow upstroke, we discussed aortic stenosis. Decreased diaphragmatic notch and where do you see this one? When there is decreased cardiac output. Pulses alternates. Here also every alternate beat is different, varies. But it depends only in amplitude, but not the rhythm. The rhythm will be normal, sinus rhythm, but the amplitude varies. Where do you see? In left ventricular failure. One beat is stronger and the other beat is weaker, which producing smaller amplitude waveform. The rhythm is normal here. Pulses experience we have discussed in aortic regurgitation, where we can see two systolic peaks. Pulses paradoxes. This was we discussed. Where do you see? This is exaggerated fall in systolic blood pressure during inspiration. Where do you see this? Cardiac tampering. Reverse pulses paradoxes. In hypovolemia and some conditions like cardiac tampering also we can see this picture. Pulses powers in conditions like shock state, where you can see small complexes, small waveforms. This is called pulses powers. So we have discussed already what is this waveform. What do you see here? Rhythm is sinus and every alternate beat is smaller. The rhythm is regular. Where do you see this? What is this? Pulses alternates. In pulses experience, what will happen? This rhythm is abnormal. Any intervention you suggested to improve the shock state. Anyone? Yes, IABP is one option. So what is waveform indicates? IABP waveform. What is the ratio of here? What is the ratio here? 1:1. Why it is 1:1? Every beat there is an inflation of the IABP. What is 1:2? Every alternate beat is supported by the IABP. So, what is the ideal location of IABP? What are the indications for IABP? refractory hypertension, MI, post-myocardial, post-CABG myocardial dysfunction, and there are several other indications. So, what is the ideal location for IABP? It should be after the left subclavian and above the renal artery. Preferred route is femoral. During systole and diastole, the mechanism is different. During systole, the IABP cuff is deflated, which causes decreased afterload and increased cardiac output. In diastole, the IABP cuff is inflated, which promotes forward flow and backward flow of blood. Backward flow causes coronary perfusion, better coronary flow. The forward flow causes better diastolic blood pressure. So there is increased diastolic blood pressure and increased coronary perfusion. So this thing. So anyone name what are the different components of IABP normal waveform? This is normal. This is 1:2 ratio. Every second bit is augmented. Where it is unassisted systole, unassisted diastole, augmented diastolic augmentation of blood pressure. This is end diastolic blood pressure. Aortic end diastolic blood pressure. This is unassisted or assisted systole blood pressure. Okay. So these are different components of the waveform. So what are the features which indicate optimal timing and function of the IABP? Anyone? The same picture here. So the IABP curve should be inflated at the onset of this diaphragmatic notch. First point. The augmented diastolic blood pressure should be higher than the previous systolic pressure. The slope of the augmented diastolic blood pressure should be parallel to the systolic blood pressure. And assisted end diastolic blood pressure should be less than the previous unassisted end diastolic blood pressure. And assisted systolic pressure should be less than the previous unassisted systolic pressure. So these are 5-6 components to tell whether it is optimal or not. So you always you have to see all this, whether it is inflated diaphragmatic notch, how is the augmentation, how is the end assisted these things. So this is all we have to see to tell whether it is optimally inflated or not. So let's come to some scenarios. So IABP with 1:2 ratio. So what does this scenario indicate? This is inflation of IABP, late inflation, where you can see a prominent diaphragmatic notch. It should be inflated diaphragmatic notch. Okay? There is less augmentation here. This is late inflation of the diaphragmatic notch. Same thing we have talked. These are abnormalities. We can see prominent diaphragmatic notch and less augmentation of DBP, and sometimes this may be equal or higher than the previous diastolic blood pressure. And so, what is the problem with this late inflation? It causes suboptimal augmentation of diastolic blood pressure. That means coronary perfusion may be inadequate. The purpose of the IABP is to have proper coronary perfusion. Here it is inadequate perfusion, coronary perfusion, because of suboptimal augmentation of diastolic blood pressure. How to correct it? Just inflate early at the onset of diaphragmatic notch. So what does the scenario indicate? Any abnormality you see here? This is early deflation. Okay. It occurred well before the start of next systole. So what are abnormalities here? You can see sudden fall in augmented diastolic blood pressure, and this pressure is higher than the previous pressure. It should be lower than the previous unassisted systole. It's almost equal or higher than the previous. This is abnormal. And you can see this U-shaped curve. Okay, these are all abnormalities in this early deflation. What is the problem with this? It causes retrograde flow. So during the belly inflation, the flow will be towards the coronaries. If it is early deflated, what will happen? This will come back. It may cause angina. And suboptimal afterload. The purpose of IABP is to have proper IABP afterload reduction. So you can notice suboptimal afterload reduction, which causes increased myocardial oxygen demand. So you should just prolong the inflation time. So what does this indicate? It is very early inflation. You can notice here. There is no V shape here. And two peaks are almost closer. Okay. And this is end diastolic blood pressure also almost equal or higher than the previous one. It occurred prior to the aortic valve closure. So what happens? It causes backflow. It may cause aortic regurgitation. So it may cause aortic regurgitation. It may impede the ventricular emptying also, which causes left ventricular increase in left ventricular end diastolic volume, end diastolic pressure, and pulmonary capillary wedge pressure. It also causes increased myocardial oxygen demand. So we have delayed the onset of inflation just at the time of diacritic notch. So what does this scenario indicate? Anyone? Delayed deflation, because there is an increased widened peak here. The peak looks widened. So deflation of IVP is occurring too late. What is the problem if it occurs too late? The heart should force against the wall, balloon to contract. So it increases the afterload, because there is a balloon in the artery during contraction. During systole, the balloon should be deflated. But because of late deflation, the balloon is there in the vessel, which obstructs the flow, which causes increased afterload, which causes increased myocardial oxygen demand. How do you correct it? So optimize the timing so it deflates early. So this patient was having trigger with ECG. So every second bit it's triggering with ECG. Usually it detects R wave and triggers in the middle of T wave. If they develop arrhythmia, what is the problem there? Patient on ECG trigger in IABP, they develop some arrhythmias. What is the problem there? So how do you correct it? What will you do? The IAB trigger will be impaired, no? Because it cannot detect T wave. I mean the R waves. Trigger will be impaired. What will you do? You have to change the trigger. So what are the different types of triggers we can use? So you can use pacing spikes or arterial blood pressure waveform as a trigger, or you can set some intrinsic rate to the IABP, or you can, if the patient is stable, just think about removing IABP and treat arrhythmia. So these are the solutions. Usually in unstable patient we start with 1:1 ratio of IABP. Depending upon the stability we will wean off to 1:2, 1:3, 1:4 like that. Okay. So this is our take home message. All of us should try to identify the abnormality and treat it. They will help in identifying early recognition of abnormalities. If you have proper idea about this, we can directly note on the monitor and detect the problem, and we can give proper treatment. Thank you.
Thank you, Dr. Sankar. Good morning, everyone. It was a precise and enlightening talk. You have tried to touch each and every important points here in a very practical way. Most of the things are self-explanatory because we didn't try to touch upon most of the theory part, because only the practical things what we see in and out when you are posted in ICU basically. Coming to few of the things very important for the student before coming to you for your questions or whatever. So first CVP, I think CVP was mostly self-explanatory. There is nothing much to discuss on that. Coming to the IABP, arterial blood pressure monitoring, dampening. What is the meaning of dampening? Anyone? If you know the precise meaning of the dampening, everything else will become simple. Dampening, the English meaning is suppressing. Okay. So over dampening means over suppressing, under dampening is under suppressing. So whenever you are suppress something, you see there will be always there will be a frequency, natural frequency of everything. Whatever you see, there will be a natural frequency. To have a proper waveform, that need to be properly damped. That is called optimally damped. If it is over damped, means over suppressed, where your waveform will become smaller. Okay. Under damped, the waveform will become bigger. So whenever the waveform is become bigger, your systolic pressure will be higher, your diastolic pressure will be low, your pulse pressure variation will be high or pulse pressure will be more. Under dampening, your systolic pressure will be low, your diastolic pressure will be high. How you will know? By doing a square wave test. Okay, how many oscillations will come after your square wave will decide it is overdamped or underdamped. There is a dampening coefficient of those things that we have not discussed. Maybe you can go through in theory part. One more important part when it comes to arterial waveform is the area under the curve. Okay. So the area under the curve decides about your stroke volume. See, somebody's arterial waveform is like bigger one. That means your stroke volume is good. In a normal arterial waveform, you see the stroke volume. Let's see in this septic patient how it will be. So vasoconstriction or vasodilatation, pulse pressure difference, basically the arterial systolic blood pressure and diastolic blood pressure. If it is the difference is more, what we believe? There is a wide pulse pressure. That means vasoconstricted state. Okay, your diastolic knock will be low. So same thing happens when you start, let's say from the bigger vessel to the periphery. Because your peripheral vascular resistance, as it increases, the waveform will become bigger. Understood? The height of the waveform will increase. There are few basic things. Regarding IABP, I think the most important thing what you should know was one slide, which are the normal things about IABP. If you know the normal things about IABP, then only you will know what are the abnormal things. So where it should inflate, how will be the assisted diastole, then unassisted systole, everything. This normal waveform will guide you when there is an abnormal. Anything?
I think we will take the questions now. One by one, if you have any questions, we will take the questions. IABP exposure generally you will get only if you work in the ICU setup, because nowadays very few patients require IABP and most of them they are in the ICU. We rarely keep IABP patients in the medical ICU. So IABP exposure you need to work in the ICU. And nowadays with most of the patients going early intervention and all, we see very few patients who land up with such refractory cardiogenic shock where we have to put IABP. There was a time when there was always one IABP patient in the ICU. But nowadays in a month, maybe 2 or 3 days only, sometimes some patients will be on IABP. Otherwise, because of early intervention and very excellent medical therapy for heart failure, there are very few patients who land up with IABP. So even our use of IABP has come down drastically in last few years. Any questions? If there are no questions, then we will wind up this session. And I request Dr. Sai to take over.
Thank you so much, sir. Before you finish, I would like you to felicitate our speaker, Dr. Shankar, with a green token. Please come onto the stage, sir. I will now request Dr. Venkatraman Kola to felicitate our chairperson, Dr. Pawan Poddar. I would like to request Dr. Kishan Rao, our Vice President, to felicitate Dr. Mishra on the stage. Please come on, sir. It's okay, sir. It's not a problem. I would request Dr. Subbareddy, sir, to please felicitate Dr. K.C. Mishra. We will move on to our second talk now. To chair the second session, I would like to invite the chairpersons, Dr. Subbareddy. He is the head of department and director of critical care at Apollo Hospitals, and also the president of IACCM Hyderabad chapter. And I would also like to invite Dr. Ramakrishna, our anesthesia HOD at Yashoda Hospitals, Malakpet. Welcome, sir. I would like you to invite the speaker and chair the session, please.
Good morning all. We all know that cardiac output is important determinant in tissue oxygen delivery. So measuring cardiac output gives the complete picture of the hemodynamic status and helps the clinician to take therapeutic decisions. There are many specialized cardiac output monitors ranging from invasive to less invasive to non-invasive monitors, which gives the complete picture of various variables of cardiac output like preload, afterload and contractility. So as a clinician, it is essential for all of us to familiarize with these monitors, and we should know how to read and interpret them. So in this session, we are going to discuss various waveforms and curves of pulmonary artery catheter and cardiac output monitor, and the speaker of this session is Dr. Yogesh. Dr. Yogesh is a senior intensivist working in Yashoda Malakpet. He has got more than 12 years of experience in cardiac critical care medicine. So please welcome Dr. Yogesh.
Thank you, sir. Thank you, all of you. In next half an hour, we are going to discuss about the various waveforms which we come across while we are using the pulmonary artery catheter and different modes of cardiac output monitor. So we'll start with the case scenario. Here, a cardiac anesthesiologist is performing a procedure in the operation theatre and following up a different waveform. So can any one of you tell what procedure he is doing? Sorry? Yeah, so he's putting a pulmonary artery catheter. So as a clinician, it's important for us to know the different waveforms when someone is putting the pulmonary artery catheter. So what are the different waveforms? So when we are performing this procedure, once the catheter is at the junction of the superior vena cava and the right atrium, so once the catheter is at the junction of the superior vena cava and the right atrium, then we have to inflate the balloon with the 1.5 cc of air, and then we have to progress it further. So what are the different waveforms which we come across? Once the catheter is in the right atrium, we will get this kind of waveform that is almost similar to what we have seen in the central venous pressure waveform. So it's having the positive wave of A, C, V and negative deflection of X and Y. Then once we push this catheter further, as it enters into the right ventricle, then we will see there is a sudden rise in the systolic pressure. So this is the systolic pressure, and diastolic pressure is almost 0 to 5. So these graphs suggest that our catheter is in the right ventricle. As we push further, then we will see there is a systolic pressure, dicrotic notch and a diastolic pressure. So this suggests that our catheter is in the pulmonary artery. So this is how we differentiate the catheter from the right ventricle to the pulmonary artery. And whenever we want to see a pulmonary waist pressure, then again we have to inflate the balloon for maybe 5 seconds, and then we will get this kind of waveform. So if you see, this waveform is almost similar to what we have seen in the central venous pressure waveform. but the values here will be little higher as compared to the central venous pressure waveform. So if we see sequentially, here our catheter is in the right atrium, then it is in the right ventricle, here it is in the pulmonary artery, and once we are wedging, then we will get this kind of waveform. So we should know all these different waveforms when we are putting the pulmonary artery catheter. So it's again the same thing. Our catheter is in the right atrium. This is right atrial pressure. Once it has entered into the right ventricle, these are the right ventricular pressure. The difference between the right atrial and pulmonary artery, there is a rise in the diastolic pressure that we should identify. And this is the pulmonary capillary wedge pressure. So once we transduce both the central venous and pulmonary artery, then we will get this kind of values on our screen. So this is the central venous pressure and this is the pulmonary artery pressure. This will be continuously coming on our monitor. Then one important thing, as Dr. Shankar has already discussed, when we should measure the pressure in this waveform. So ideally this pressure should be measured at the onset of A wave. Now the important thing is identifying the A wave. So this A wave in right atrial pressure, if you see, when we compare with the ECG, this A wave, it comes just before the onset of QRS complex. So we should draw a line from the QRS complex and the wave which is coming before the QRS complex, that is A wave when we are doing in the right atrial pressure or central venous pressure. In case of pulmonary artery wedge pressure, this A wave, it will follow after the QRS complex. So these differences we should know. Then another important thing is when we should measure this pressure in relation to the ventilation. So ideally all this pressure, they are measured at the end of expiration. Why at the end of expiration? Because at the end of expiration, our intrathoracic pressure will be equal to that of the atmospheric pressure. So there will not be any change. So important thing is finding the end of expiration. Now end of expiration will be different when the patient is on the spontaneous breathing and when the patient is on the mechanical ventilator. As the spontaneous breathing is a negative pressure ventilation, the curve, the graph, it will go down during the inspiration in case of the spontaneous ventilation. And at expiration, the graph will go up. While in case of mechanical ventilation, the reverse thing will happen because it's a positive pressure ventilation. So during inspiration, this graph will go up and the graph will come down during the expiration. So we have to identify the end expiration in both the phases. That is important. Now coming to some pathological waveforms when we are using the pulmonary capillary wedge pressure. So first thing is an altered A wave, that is a large A wave. So as we have seen in the central venous pressure, the large wave is there when some pathologies are there with the tricuspid valve. So here everything will be related to the mitral valve pathology. So large A wave will get when there is a stenotic mitral valve, or the giant A wave will get when there is a AV dissociation, that both the atria and ventricle, they are contracting at the same time. Or the canon A waves we will see when there is a premature ventricular contraction or the reentrant tachycardia. So here we will see this is a large A waves. Then coming to the large V waves. As in the central venous pressure, we are seeing the large V wave when there is a tricuspid regurgitation. So here when there is a mitral regurgitation, we will get the large V waves. So these are the large V waves in relation with the ECG. The other causes that includes ventricular failure, increased pulmonary or systemic resistance, and ventricular septal defect. Now there are certain abnormal wedge tracing. Sometimes it will happen that catheter is too much distal. So there will be the over dampening of the tracing. Sometimes it will happen that even without the inflation of the balloon, the catheter it gets spontaneously wedged. Then that time we will get this kind of pressure. This is our normal pressure when we inflate it with the 1.5 cc of air. And sometimes it will happen that there is an overinflation of the balloon. So when the overinflation of the balloon will be there, the graph will be, there will be a continuous rise of the graph on the screen. So it will seem like something like this. So it is very important to identify this thing because this is very dangerous thing. It can cause a pulmonary artery rupture if it keep on rising like that. So after identification, we have to immediately deflect the balloon and withdraw a catheter little bit. So these are all about the pulmonary artery catheter. Now we'll come to next kind of waveform. So we'll start with this case. This is a 78-year-old man, diabetic. He is admitted with the complaints of cough fever since last 3 days. On examination, patient was lethargic, dehydrated, admitted to the ICU where he got intubated and the invasive hemodynamic monitoring is initiated. So what abnormality in the arterial waveform you are able to identify here? What do you think, what is the abnormality here? So if you see, there is a too much of swing is there in this arterial waveform. Okay. So this swing will measure as a pulse pressure variation, and that in this case it is a pulse pressure variation is more than 13%. So what is the importance of pulse pressure variation? So first we will see what is the pulse pressure variation. Whenever patient is on mechanical ventilation, so in mechanical ventilation during the inspiration there will be a positive intrathoracic pressure. It will have its effect on the right ventricle and left ventricle. So because of increased intrathoracic pressure, the right ventricular preload will decrease. At the same time, there is an increase in the afterload of the right ventricle. So both of these things is causing right ventricular stroke volume to decrease. That is happening at the right ventricle. Now at the same time, there is an increase in the transpulmonary pressure, and it is causing the decrease in the left ventricular afterload and increase in the left ventricular preload. So these two things ultimately causing increase in the left ventricular stroke volume. So at the inspiration, what is happening at the left ventricle is there is an increase in the left ventricular stroke volume. So it will be maximum at the inspiration, and that will be like pulse pressure max. Now this decrease in the right ventricular stroke volume, it will reflect into the left ventricle after a transit time of 2 to 3 seconds. So there will be decrease in the left ventricular, and that will happen at the end of expiration. So this pressure difference will be there at the inspiration and expiration. That is measured as pulse pressure variation. So what is the formula for it? It is a pulse pressure max minus pulse pressure minimum divided by the average of pulse pressure. So if you see when the patient, this is the Frank-Starling curve. When the patient is preload responsive stage, then you see there is a large pulse pressure variation. When the patient is not in a responsive stage, then this pulse pressure is not much. There is a low pulse pressure variation. So this patient, when you give the fluid, they will respond to our fluid management. So how we use this pulse pressure variation? So as I said, for measuring the pulse pressure variation, there are certain prerequisites. Patient should be on mechanical ventilator, there should not be any spontaneous breathing, there should not be any cardiac arrhythmias. And then we consider the pulse pressure variation. If it is more than 13%, then patient is definitely a fluid responsive state. If it is less than 9%, then we have to see whether the patient is getting the adequate tidal volume ventilation or not. Because many patients, then ARDS, they will get a low tidal volume ventilation. So if it is a low tidal ventilation, like less than 8 ml per kg, then we have to do something called as a VT challenge. If it is more than 8 ml per kg and our pulse pressure variation is less than 9, then it's very unlikely that the patient will respond to our fluid management. And when it is in between 9 to 13%, in both these two cases, we do something called as a VT challenge. So what is the VT challenge? If patient is getting a tidal volume ventilation of 6 ml, then we have to change it for transient time for about 1 minute to 8 ml per kg. And during that 8 ml per kg ventilation, we have to again check the pulse pressure variation. So those findings what we are getting with the ventilation with 8 ml per kg, that will correlate more with our hemodynamic response. If that is showing the positive response, if it is increasing more than like 13%, then it will be a positive. So that is the VT challenge. Similar to the pulse pressure variation, there is something called as a stroke volume variation, and this is given by the formula the stroke volume max minus stroke volume minimum divided by the average of the stroke volume. But when they compared the pulse pressure variation with the stroke volume variation, they found that the stroke volume variation was significantly less accurate as compared to the pulse pressure variation. Now there are the different monitors which are coming with direct values like Vigilio or the flow track system. It will show direct values. Unfortunately, there are no curves related to that, so I am just showing the direct values that will help us in management of the patient. It will give us direct cardiac output, stroke volume, SVR, SPB, all these things, and these are the normal range for that. Even the more advanced cardiac output monitor like EV1000, they will have a visual presentation will be there. Directly it will offer a unique and clear visual depiction of the patient physiological state. It will directly show like these are the different 5 grades of extravascular lung water. This is the extravascular lung water. It will go on increasing. Then there is a stroke volume variation will be seen on the Frank-Starling curve. That will be continuously, it will be shown, will be coming on the our monitor. Then many advanced things like PVV, PY, like pulmonary vascular permeability index, extravascular lung water, global end diastolic volume, or global ejection fraction. Those all values will be seen directly on our monitor. And with that, we can help for the patient management. So here we can see the heart shape will change depending upon what is the volume status, like it is a vasodilated or vasoconstricted state, and the flow of the blood cell, it will represent the actual cardiac output. Then the vasculature, whether it is a vasoconstricted or vasodilated state, it's all like we are seeing the exact physiology or different water level in the lung and this Frank-Starling curve. These all things will be visible directly on the monitor. Now coming to the next type of cardiac output monitor, we'll start with this case. This is a 58-year-old female. She is undergoing an emergency laparotomy, and this patient is put on the minimally invasive cardiac output monitor. The monitor is showing the following data. So can anyone tell what is this monitor and how can you interpret this data? Where we see such kind of graph, which kind of cardiac output monitor? Ramya? Correct. So this is the esophageal Doppler. So esophageal Doppler cardiac output monitor. For this, again the prerequisite is that patient should be mechanically ventilated. Then we put this esophageal Doppler probe, that is around 4 MHz probe, into the esophagus, and this measures the blood flow velocity in the descending aorta. Then there is a Doppler principle which helps in calculating the cardiac output. This Doppler principle is there is a Doppler shift in the frequency. It occurs when the ultrasound wave is reflected back from the moving RBCs with the shift in the frequency which is proportional to the velocity of the blood flow. So for any cardiac output measurement, there are two things are required. One is the cross-sectional area of that vessel, and another is a VTI. So this cross-sectional area of the descending aorta, it can be calculated either by the this normogram, which is based on the age, weight, and the height of the patient, or we can use a aortic root diameter by using the transesophageal echocardiography. And these values, they are put into this Doppler equation. Another thing which I told that we require to calculate the VTI, that is the velocity time integral. It is calculated from the area under the velocity time curve, and it is used as a stroke distance. So if you multiply this cross-sectional area with the VTI, we will get the stroke volume, and if we multiply stroke volume with the heart rate, we will get the cardiac output. Now since this descending aorta, it receives only the 70% of the blood flow, so we have to add the correction factor into that. So this is our esophageal Doppler. These are the waves which are coming and hitting the RBCs and coming back, and then we will get this kind of VTI curve. So it is calculated from the area under this curve, and then the formula is VTI multiplied by cross-sectional area multiplied by heart rate. That will give us the cardiac output. So this esophageal Doppler, it do not tell about the stroke volume and cardiac output. It is something tell about the measure of preload, that is the corrected flow time or FTC. This FTC is the base of the waveform, and this normal value is around 330 to 360 milliseconds. Then there is another thing called as a peak velocity. This peak velocity will tell us about the measure of the contractility. This peak velocity will vary depending upon the age of the patient. So in this graph, this is the peak velocity. It is a measure of cardiac contractility. Okay, and this is the stroke distance, that is the marker of the stroke volume, and this is the base of the waveform that will tell us about the preload status of the patient, that is FTC. So when there is a normovalemia, all these values are within the normal range. Then coming to the different waveform when the different clinical conditions are there. So when there is an increase in the afterload, as I said, the peak velocity is a marker of myocardial contractility. Hence there is an increase in the afterload, this height of this graph, it will decrease. When there is a decrease in the afterload, the height of the graph will increase. This is the normovolemia. And when there is a hypovolemia, this base of this graph, it will become narrower. When there is a ventricular failure, we will get this half semicircular kind of waveform. Now coming back to our case, in our case there is a low peak velocity, there is a low stroke volume, and there is a low FTC. These all are suggestive of that patient is in a hypovolemic state. So patient should receive the fluid. So how you interpret this data which we get from the esophageal Doppler? So whenever there is a low stroke volume or low FTC, we should give the fluid to the patient. When there is a low peak velocity, then we have to start inotropes. When there is a low peak velocity and the low FTC, then we should take the measures to decrease the afterload. Now coming to the various waveform which we come across when we are using our transthoracic echocardiography. We are regularly using our transthoracic echocardiography for measurement of the IVC diameter. Like how do we measure the IVC diameter? We keep our echo probe in the epigastrium, and if we turn slightly towards the right side, then we get this kind of picture. This is the inferior vena cava. This is hepatic vein opening into the inferior vena cava. Then if we put the M mode on that, then we'll get this kind of graph. So there is a difference in the diameter during the inspiration and the expiration. So this difference we take into account for the patient's fluid responsive state. So when patient is in the spontaneously breathing, we take as a IVC collapsibility as a marker. This is given by the formula maximum minus minimum diameter divided by the maximum diameter multiplied by 100. So if this is more than 50%, then we presume that the patient is a fluid responsive. This is done when the patient is in spontaneous breathing. When patient is on the mechanical ventilator, we take something called as the distensibility index. That is given by the formula IVC max minus IVC minimum divided by the IVC mean or the minimum. And if it is more than 18%, then it is considered to be the significant. Now coming to the measurement of cardiac output while using the transthoracic echocardiography. So for that we require again a velocity time integral and the cross-sectional area. So this velocity time integral, that is, it is referred to as a stroke distance, and the normal values for these are 20 plus minus 3. As a rule of thumb, whenever there is an increase in the VTI of more than 15% with either inotropes or fluid, then we consider it as a positive VTI. So measuring the cardiac output by using the transthoracic echocardiography, we require two things. One is the measurement of this diameter, this LVOT diameter. So for measurement of this LVOT diameter, we have to use a parasternal long axis view. If we put our probe into parasternal long axis view, we'll get this view. Then we have to measure this diameter, and that diameter we have to put into this formula, which will give us a cross-sectional area. That is one part. Then second thing is we have to see the VTI. For VTI, we have to use apical 5-chamber view, and this in apical 5-chamber view, we have to put a pulse Doppler in the aortic root opening. If we put the pulse Doppler, we'll get this kind of waveform, that is the VTI. If you get both these two things, again multiplication of this will give us the stroke volume, and multiplied by heart rate will get the cardiac output. So here this cross-sectional area is 3.3 centimeter and the VTI is 19.2. If we multiply this thing, the stroke volume is 63, and multiplied by heart rate will give us the cardiac output. Now coming to the patient scenario. Patient with the sepsis in whom the fluid responsiveness is assessed. So these are his baseline characteristics. This LVOT diameter is 3.14, VTI is 13 cm, stroke volume is 41, and heart rate is 80. So after a fluid challenge of 200 ml of crystalloid, these are the values. The cross-sectional area is remaining the same. LVOT VTI, it has increased to 20, which is almost 54%. And stroke volume has increased to 63, which is almost 54%. So there is an increase more than 15%. So we consider it as a positive VTI response. So here this VTI, it has increased from 13 to almost 17, 18. So that is a positive VTI response. Coming to the second case, this patient is in the cardiogenic shock. This LVOT diameter, because of the inadequate quality, we don't know. But the VTI is 12.1 centimeter. And after starting a dobutamine, this VTI, it has increased from 12.1 to 17.8 centimeter. So it is again increased by 47%. So that is again a positive VTI response. So here it has increased from 12.8 to almost 17 this thing. So that is a positive VTI response. So these are the three different diagrams showing this is a normal stroke volume with the normal VTI. There is increase in the stroke volume with the increased VTI, and this is decrease in the stroke volume with the decrease in the VTI. Now we also use this transthoracic echocardiography for measurement of the ejection fraction. So what is ejection fraction? It is a end diastolic left ventricular end diastolic volume minus left ventricular end systolic volume divided by the left ventricular end diastolic volume. So that will give us the ejection fraction. It will almost similar to the stroke volume. So for this calculation of ejection fraction, we use again a parasternal long axis view, and we put the M mode into this left ventricular cavity. After putting this M mode, we will get this kind of picture. So this is a right ventricle. Here it is a right ventricle. Here it is. This one is septum. This is the septum, and this is the left ventricular cavity. So in this left ventricular cavity, there is a phasic variation. During the diastole, this cavity is bigger, and this cavity is small during the systole. So if you put this diameter, left ventricular end diastolic diameter and left ventricular end systolic diameter into the machine, it will automatically calculate the ejection fraction, and it will get the report. So here we are measuring the left ventricular end diastolic diameter and left ventricular end systolic diameter. If you put these values, we will get the ejection fraction. So in patient with a dilated cardiomyopathy, you will see there is hardly any change in the left ventricular cavity. So ejection fraction is very low, that is only 26%. Now there is something called as a E-point septal separation. So what is the E-point? This E-point in the early stages of the diastolic filling, the anterior mitral wall leaflet, it reaches to a point of maximum excursion, and as such it comes closest to the IVS. This is called as the E-point. So this is the E-point, which is almost close to the IVS. And there is something called as A point. The A point, it represents the atrial kick that occurs at the left atrium as the left atrium contracts. So this is the A point. The distance in space separating the anterior mitral wall leaflet from the septal wall, it is referred as a E-point septal separation. So this distance, this E wave distance from the septum, this distance is called as a EPSS, E-point septal separation. So what is the importance of this E-point septal separation? If this E-point septal separation is less than 8 mm, if this distance is less than 8 mm, then it is presumed that the ejection fraction is more than 50%. And if it is more than 8 mm, then the ejection fraction is said to be less than the 50%. So this is the importance of E-point septal separation. So these are all about the different waves which we come across while using the pulmonary artery catheter and different modes of cardiac output monitor. Thank you.
Thank you, Dr. Yogesh, for an excellent talk. Congratulations to Yashoda team for conducting such a wonderful conference on pulse and graphs in ICU, which is very, very important. And when we are giving these IDCCM exam or EDIC exam, so these definitely you will get 1 or 2 questions, and then definitely and you will have only 1 minute time to answer. And this is very, very important conference. And you nicely presented these PA waveforms. We have very limited use of PA catheters and cardiac output monitoring when you are working in the medical intensive care unit. Unless you are in a cardiothoracic unit, you see PA waveform. PA usage of PA catheter is very common. But because of this COVID second wave, we are seeing a lot of patients on ECMO for 40 days, 50 days, and then they develop right ventricular dysfunction, pulmonary arterial hypertension. We have to, we are using again PA catheters. It's not that they are completely out of ICU, and initially when we were not because we were not using this, so we do, our nurses and doctors had limited experience. But now again it is coming back into the intensive care unit, and advanced cardiac output monitoring is present in many medical intensive care units. And he nicely discussed a few cases of septic shock and then the cardiogenic shock, how to use this monitor and how to get the best use of this cardiac output monitor. And then we have 2D echo also in our intensive care unit, so we can use the IVC for the hemodynamic monitoring. Thank you, Dr. Yogesh. And then
good to see, like when I thought, okay, we have to go to Yashoda Malakpet, it's like coming back home. So I worked here 10 years ago with Prusty sir, and good to see GKM sir and Kishan Rao sir, and once again, congratulations to Dr. Venkatram and team for doing such wonderful work. Any questions?
Differences between BPI of TE and TTE.
Sorry?
Differences between BTI of TE and TTEs.
No difference actually. We are VTI we can see of any vessels. Like we in this one transthoracic echocardiography we are seeing at the ventricle, and there we are seeing at the descending aorta. It is a VTI. What is the VTI? It is the flow of the blood that we have to see. That the flow we have to measure, and the cross sectional area. So there is not any difference. Even it's not necessary. We can see in the right ventricle. You can see in the left ventricle. There is nothing like that. It's the same.
Actually, one gives positive deflection and one gives negative deflection. In TE, it gives positive deflection. In TTE, it gives negative deflection. So, is there any significance where we measure VT? Means location of the probe where the signal actually catches.
Because of blood flow, the direction of your blood flow, because when you are actually measuring the blood flow in the aortic outlet in a transthoracic echo, the blood flow direction is in the upper direction when you are doing. But when you are measuring it in descending aorta in esophageal echocardiography, the direction will be different. So that's why your waveform comes either negative deflection or a positive deflection. What it means is, when we are trying to measure a cardiac output, so you wanted a cross-sectional area, you wanted a point where there is a velocity and a cross-sectional area where you can indirectly get some information. So there you have an aortic outlet or aortic valve outlet. Here it is a descending aorta. So as he's saying, you can have a different points there or here, but at the end of the day, when you are talking about a cardiac output, that should reflect the same way.
VTI is about velocity. Whenever we are calculating the stroke volume, it is the surface area into the velocity. So VTI is nothing but velocity that indicates the stroke distance. If you imagine like a cylinder, the distance is the VTI and the area is the surface area. If you multiply both of them, it gives the stroke volume. Whether in TTE we measure at the left ventricular outflow tract because the area is constant. It won't change with the inspiration or expiration. The area is fixed. That's why we choose left ventricular outflow tract in TTE. In esophageal echo, mid esophagus, we take as a point for VTI. Any questions from audience? If you have no questions, we conclude this session and we will move on to the next session. Thank you.
Thank you so much, sir. I would request the chairperson to felicitate the speaker, Dr. Yogesh. So if you could kindly come on to the dais. I now request Dr. Krishnamohan Reddy to felicitate our chairperson, Dr. Subba Reddy. Thanks so much for chairing the session, sir. I request Dr. Yugandhar Bhatt to felicitate another chairperson, Dr. Ramakrishna. Next, we move on to our third talk of the day. To chair this session, I would like to invite our chairpersons, Dr. V. Srinivas and Dr. G.K.M. Reddy, Senior Consultant Physicians at Yashoda Hospital, Malakpet. Welcome, sir. I would like you to invite the speaker and chair the session as well. Thank you.
Hello. F5.
Hello. Good morning, everyone. It's a pleasure to invite Dr. Shishikina Reddy. Hello. Hello. Good morning. It's a pleasure to invite Dr. Shishikina Reddy, who is a senior doctor with us, medical specialist, ladies and anesthesia, FNB, and more than 8 years of experience in all critical specialty. And our topic for today is, so we'll be seeing in ICU is what happens with the coagulation parameters. As all of us know, the parameters like platelets, INRs, PT, with other parameters of coagulations. And now we'll see how to assess the coagulation abnormalities, whether they are significant, non-significant, how to interpret those abnormalities to make a clinical decision in the management. And over to Dr. Shishikina.
Good morning, everyone. And this topic, we don't use it, this kind of viscoelastic testing like rotor and tech, we don't use it routinely in our ICUs. It might sound like a Greek and Latin to most of you, but I'll try to make you understand a few things, and further we'll go on to the interpretation. Yeah. What is viscoelastic testing? And okay, to start with, what is viscoelasticity? Viscoelasticity is a property of a substance which it exhibits when it is deformed. Like our blood exhibits viscosity and elasticity when you deform it. That we are going to measure in our viscoelastic testing. And what is wet? Viscoelastic testing gives an in vitro picture of the growth of the cloth, measure of its stability until it lyses physiologically or pathologically. And why do we need it? We have a lot of parameters like PT, ABT, INR, thrombin time, and a lot of other tests. Why do we need it? And what do we measure in our routine testing? We do measure, these are all static tests. We send a sample at some point of time and measure after 2 hours. That's a static test. These are all PT, INR, ABTT, thrombin time, these are all static tests. These are all not dynamic tests. But we need viscoelastic testing because it gives a real-time holistic view of X-Y clotting. And we don't usually, while measuring PT, ABT, and we look at the only coagulation parameters. We don't look at contribution of cellular and plasma components. And we are going to assess in viscoelastic testing. We are going to assess the blood clotting when it transforms from the liquid state to a gel state. And types of viscoelastic testing is TEG and ROTEM. And most of you might have know about TEG and ROTEM. The science behind this is shear modulus and harmonic resonance. I'm not going to talk about this harmonic resonance because it is far more advanced. We are going to talk about shear modulus. What is the shear modulus? When a clot forms, and tries to contract, it has some resistance. It induces some resistance to shear force. This is known as shear modulus. We are going to measure the shear modulus while we do this testing, viscoelastic testing. What kind of shear modulus you are going to measure, I will discuss. And these are the two diagrams which describe the basic with TEG and ROTEM. What is TEG? What we do in TEG? In a TEG, we take a small curette, we add 0.36 ml of blood, and we heat it to 37 degrees, and we put a torsion band and we attach a disposable pin to it, and we rotate it gently at 4.45 degrees every 6 seconds, and then we use a electromechanical transducer to transduce it from a mechanical wave to electric graph. This is the principle of TEG, and this is a basic TEG. There are a lot of parameters which we can measure from the TEG. I'm not going to discuss about. There are a lot of 60-70 parameters which you can take from the TEG and ROTEM. I am going to discuss only 4 or 5 basic parameters which we need to know and which are commonly used to interpret thromboelastography. And to start with is R wave, K wave, alpha angle, MA, and clot lysis at 30 minutes. And what is R wave? We have discussed about shear modulus, and we have also discussed about what kind of shear modulus are we going to use. There are 2 types of shear modulus. One is measuring the torque and measuring the oscillation. Okay, in TEG we use a principle called torque. When a clot starts forming and the clot starts showing some torque. That is, torque is nothing but resistance to your deformation. That we are going to measure on TEG. R time is nothing but the time. It's nothing but a basically your initiation of clotting. R time is nothing but initiation of clotting, and it corresponds to 2 mm of clot on your TEG graph. It also corresponds to initial appearance of torque in a thromboelastography. The time is 48 minutes generally, and it varies with different settings and different machines. And K time, what is a K time? Next comes is a K time. It is nothing but amplification of your clot. You have started the clot, clotting factors have started acting, and you have an R time. And then comes your K time. What is the K time? K time is nothing but from the start of 2 mm and progression to 20 mm of clot. That is known as K time. We take it as a K time. And we also have an alpha angle at this point. What is this alpha angle? Alpha angle is nothing but when you form 2 points, that 2 mm point and 20 mm point, and we put a tangent to it. That is known as alpha angle. What it denotes? It denotes speed of clot formation. And then comes your maximum amplitude. Maximum amplitude is nothing but maximum amount of clot that is formed. That is known as maximum amplitude. And what are the various factor contributions to all these values? Going from R value is mostly contributed by your clotting factors. All your clotting factors, whether intrinsic or extrinsic. K time, mostly clot initiation, amplification is mostly happens with the help of fibrinogen and with the help of your platelets to some extent. Alpha angle is also same, fibrinogen and to some extent platelets. But maximum amplitude most of the time is contributed by your platelets. Have everyone understood this up to this part? Then we'll go to these are the basic values. R time, what I have told you. R time, normal value is 48 minutes. K time is 1 to 4 minutes. Alpha angle is 47 to 74 minutes. and maximum amplitude is 55 to 73 mm. And then clot lysis at 30 minutes, this value usually is 0 to 8. That means at the 30 minutes, the percentage of clot that is remaining at 30 minutes. Okay? Percentage of reduction in clot at 30 minutes. Okay? How much it reduced from the maximum amplitude? The usual values at 30 minutes, it has to reduce by only by 0 to 8. If it reduces more than that, that means that it's something abnormality is there, which we'll discuss. And clot lysis at 60 minutes, we can measure n number of values, but there are only 5 values for your understanding. This is a basic graph. The R value and is a K value, alpha angle, maximum amplitude, and lysis is 60. What is this graph? Is there any abnormality? Start from R value. R value is nothing but reaction time. Initiation of your clot. Is there an abnormality? Is it normal or abnormal? What is happening to the K value? K values also looks like to be normal. Alpha angle also looks like to be normal. And maximum amplitude also looks like to be normal. And lysis is not happening even after 30 minutes. That means this is probably a normal graph, normal trace. Let's go to this trace. Is there any abnormality here? From explanations, R value, initiation of the clot, is there an abnormality? What is happening to R value here? R value is prolonged. What is happening to your K value? What is happening to your K value? Point this value to this value. What is happening? It is prolonged. What is happening to alpha angle? Alpha angle is decreased. What is happening to the maximum amplitude? Is it? It is normal, pretty normal. Okay. This is what R, you are right, most of you are right, RK is increased, angle is decreased. This is probably, what is your diagnosis here from this tracing? What do you interpret? What does R value say? Clotting factor deficiencies. How do you treat this patient? When you have this kind of graph, what will be your treatment? Give FFPs. The next one. What is happening to the R value? R value is normal. What is happening to your K value? This is your K value. What is happening to your K value? K value is slightly decreased. What is happening to your alpha angle? It looks normal. What is happening to the maximum amplitude? Okay. How do you interpret? Initiation is okay. Initiation is okay. There is some problem with amplification and propagation. Note, amplification and propagation, fibrinogen plays a part, and also your platelets plays a part. And you are seeing the maximum amplitude. Maximum amplitude is solely by your platelets. What is happening? What is your interpretation here? What is your interpretation? Sorry? Thrombocytopenia or platelet dysfunction. You can't say thrombocytopenia alone using this. You can say, you have to say it is platelet dysfunction or thrombocytopenia. Yeah. What do you interpret here? What is happening to the R value? Decrease. What is happening to your K value? Increased or decreased? It is decreased. What is happening to the alpha angle? Increased. What is happening to the maximum amplitude? Increased. What is the state? Hypercoagulable state. What do you do? You would like to anticoagulate this patient. You are right, most of you are right. Okay, next, we'll go to the next graph. What is happening to the R value? R value is decreased. K value, what is happening to the K value? Decreased. What is happening to the alpha angle? Increased. What is happening to the maximum amplitude? Increased. What abnormality you are observing here? Clot lysis. LY time is increased. That means at 30 minutes the percentage of clot which is lysing is more. That means some kind of clot lysis is happening. Okay, hyperfibrinolysis. What do you do here? Suppose you have a trauma patient with this kind of picture, or sepsis patient with this kind of picture. What do you do? Tranexamic acid. This is early DIC. This is not a late DIC. This is very early DIC. What is this? What is happening here? R value is, what is happening to the R value? R value is prolonged, K value is prolonged, alpha angle is decreased. What is happening to mean amplitude? Decreased. What is this? Everything is, there is a deficiency in coagulation factors, there is a deficiency in platelets. What is this? What is this state? Late DIC. That was early DIC. This is late DIC. Okay? Okay. Can somebody tell what is this? Your R value is, clot initiation is normal. K value is normal. Clot amplification is normal. Alpha angle is almost normal. Maximum amplitude is normal. What is happening here? What is happening here? Clot lysis. Clot lysis. What do you do here? This part, clot formation part is okay. But what is happening here? Fibrinolytic part. This is fibrinolytic part. Hyperfibrinolysis. What you will do? Tranexamic acid. This is some kind of analogy. You have some interesting analogy which I took it from somewhere. You have a shape of a brandy tumbler, do nothing. Red wine glass, give FFPs, test tube, give platelets. Champagne flute, give cryo, and inverted martini glass, give tranexamic acid. This was some analogy. Then now going to rotem. Rotem is nothing but the same principle which is there, and with a different brand and different. Yeah. The R value here is labeled as clotting time. Nothing much difference. And the K value is labeled as clot formation time. And alpha angle is alpha angle. Mean amplitude is maximum clot firmness. You are assessing the clot firmness. Hello. And clot lysis is LY30, and CL60 is LY60. That's the only difference. Going to TEG, the principle is same, but there the pipette keeps on moving. Here you put a pin, and the pin keeps on moving. And the principle here is the stress modulus principle here is decrease in oscillation. Decrease in amplitude of oscillation is detected by your detector and transformed to the graph. Yeah. What are the components of this rotem? There are 5 to 6 components: intem, extem, heptem, aptem, fibtem, and natem. Intem, it is nothing but measuring your intrinsic coagulation pathway. You add some phospholipids and allergic acid as a reagents, and extem is nothing. The reagent here is tissue factor and activates extensive coagulation pathway. Heptem is nothing but to see the effect of heparin. It is same as heptem, but you add heparinase to it to nullify the effect of heparin. Naptem, it is same as extem, and you have a tissue factor here as a reagent, and aproteinin. Aproteinin inhibits plasmin. By doing so, it takes the effect of plasmin, fibrinolytic pathway. It eliminates fibrinolytic pathway. And fiftem, you add a cytochalcin D, and what it does is it inhibits platelets, and you can assess only the function of your fibrinogen. These are the normal values: intem, extem, haptem, and fiftem. Intem values are somewhere around clotting time is around 100 to 240 seconds. Clot formation time is 300 to 110, and alpha angle is 70 to 83, and maximum clot formation firmness is 50 to 72. Intem is same as extem, heptem, and extem is slightly, your clotting time is slightly decreased because we add a tissue factor and coagulation happens fast. It is 38 to 79 seconds. And clot formation time is slightly more, and alpha angle is almost the same, and rest of the values are the same. And fiftem, the significant value, what you have to consider is maximum clot firmness. Below 9 is abnormal. That's all. And to talk about various, this is a normal graph. This is your clotting time. This is a clot. This pink one is our clot formation time, and this maximum clot firmness. These are the various values: clotting time, clot formation time, alpha angle, amplitude at 10 minutes, and maximum clot firmness, and maximum lysis. What is maximum lysis? The amount of clot that is present at 60 minutes of TEG graph. Amount of yeah. Here let's go to the scenario. A patient with major trauma is admitted into ICU. Patient was resuscitated as per massive transfusion protocol, and appropriate surgical hemostasis is achieved. Noted to have increased drain output, ROTEM was done, and this is your value. What is happening here? Clot formation time is increasing in both in extem and intem. Clotting time is, alpha angle is more, and A10 value is more decreased. Amplitude at 10 minutes is decreased. Maximum clot firmness is decreased, and your What do you interpret from this graph? Clotting time is normal. Clot formation time is abnormal. Amplitude at 10 minutes is decreased, and maximum clot firmness is decreased. What do you interpret? Clotting time is normal. Is there any deficiency in? What do you interpret? Okay. Here we go with the fiftem and aptem. What does the fiftem say? In fiftem, maximum clot formation is 16, and here maximum clot formation is 35. What is fiftem? What do we do? What do we do in fiftem part of ROTEM? We are eliminating the contribution of platelets, and this is solely this clot. MCS is maximum clot firmness is solely because of your fibrinogen. Understood? Anything above 9 is normal. Here it is 16. Is your fibrinogen normal? Simple. Clotting time is nothing but your R value. Clot formation time is nothing but your K value. What is happening to clot formation time? In all these aptem, extem, intem, it is more. What does that mean? deficiency of clotting factors, deficiency of fibrinogen or platelets. Deficiency of fibrinogen might be secondary to hyperfibrinolysis or deficiency in fibrinogen. Or platelets might be decreased platelets or dysfunctional platelets. There are only 4 scenarios. Okay. Is hyperfibrinolysis happening? No. Is the patient is on low on fibrinogen? No. What is happening here? Low platelets. Maximum clot formness is decreased. It is either secondary to low platelets or dysfunctional platelets. Understood? What is the conclusion? What do you conclude? FIPTEM is normal, maximum clot firmness is decreased, clotting time is normal, CFT is increased. There is some thrombocytopenia or dysfunctional platelets. We have to either administer desmopressin if dysfunctional platelets or administer platelets if platelets are low. Look at this graph. What does this show? Clotting time on XTEM 1089 is increased. Clotting time on INTEM 236 is increased. What is happening to maximum clot firmness? Okay, I will go. Clot forming time is increased. CFT is increased. That means that there is dysfunctional platelets or fibrinogen. Okay. Amplitude at 10 minutes is decreased. Maximum clot firmness is decreased. I am telling you there are only two problems here, either fibrinogen problem or platelet problem. Okay, now we have gone to the later part. What is happening? You are done FIPTEM, you are done APTEM. What do you see in FIPTEM? Maximum clot firmness is 3. That means there is low fibrinogen. What do you do? What do you do in low fibrinogen? You give cryo. Okay, look at this. What is happening? This is XTEM, this is INTEM. Clotting time in XTEM is it's normal. What's the clotting time in INTEM? Prolonged. Okay. Clot formation time in it's in the normal range. What happened to clot formation time? Here. It's prolonged. Amplitude at 10 minutes. 50. That is good. That means there is no dysfunctional platelets. And fibrinogen. Maximum clot firmness is 57. That is normal. Maximum clot firmness is 48. That is also normal. What do you do now? These are the abnormalities you find. And you do a FIPTEM. What abnormality you find in FIPTEM? It's normal. This is HEPTEM. What do you do in HEPTEM? You add some heparinase to nullify the effect of heparin. What is happening to INTEM graph? This was INTEM before. I told you INTEM is same as HEPTEM. This was INTEM graph previously. After adding heparin, after doing HEPTEM, it has normalized. What does that mean? There is some heparin. Mostly you see in CTVS patients, post cardiothoracic surgery. What do you do here? Patient is high on heparin. You administer protamine. What is this? This is the next graph. Clotting time is almost normal. In clotting time in INTEM, up to 240 is a normal range. Clotting time is normal. Clot formation time is almost normal. Alpha angle is within normal limits. 830 is decreased. Amplitude at 10 minutes is decreased. Maximum clot formness is decreased. What is happening here? Maximum lysis is 100%. This value, normal value is 15% is normal. Maximum lysis is 100% here. What is happening? Fibrinolysis. Okay, you have done an aptem. What is aptem? What do you do in aptem? You add an aproteinin. What is aproteinin? It is same as tranexamic acid. Okay, it prevents fibrinolysis. After adding aptem, the graph has normalized. MCSF is better, and amplitude at 10 minutes is better, and CFT is better. What do you do here? What intervention is done here? You give tranexamic. The conclusion is hyperfibrinolysis. And what do you do? Tranexamic acid. Okay. Okay. Did anyone understand any doubts in this up to this part? Okay. What are the strengths and limitations? Strengths is it is dynamic. It's a dynamic testing, and mostly it is used in cardiac and trauma care units. And it is a real time information of the clot formation, clot propagation to lysis. Okay, and limitations are it's a quantitative, not a qualitative. Platelet function disorders cannot be assessed, and you can't assess the contribution of what you call endothelium to this. And the values might vary in patients with your who are on aspirin and clopidogrel, and you are heating the pipette to 37 degrees, so you can't assess the effect of temperature. And next, going to the spirometry. And spirometry is a term given to basic lung function testing that measure the air that is inspired and expired. You measure volume, time, and flow. What are the basic measurements you see in spirometry? FEV1, FEC, FEV1, FEV1 by FEC, FE loops, and peak flow rates. What is this graph? Okay, I'll explain you this. We start with FEC. We start with FEC, residual volume. There are different components: residual volume, total lung volume, and FEC. Where do we start your spirometry? We start our spirometry with at residual volume. We inspire. This is my forced inspiratory flow, maximum inspiratory flow, and then we go back to total lung volume. And from total lung volume, we'll start expirating to again to residual volume. And at and various points of time, we'll be assessing various parameters. This is peak inspiratory flow. This is peak expiratory flow, and this is FE1. Okay. Now let's start interpreting values. This is your flow volume loops. What happens in different groups of patients? In the restrictive lung disease, your total lung volume decreases and residual volume also decreases. In your obstructive lung diseases, total lung volume increases and residual volume also increases. And what is this graph? This is a normal graph of normal spirometric graph. And what is this? What do you interpret from this? What is your interpretation? You have a normal inspiration, but during expiration there is decreased peak expiratory flow, and there is a coving. And there is a coving at 25 to 75% of the peak expiratory flow. That means it's a kind of CO obstructive lung disease. What is this? What do you see? Inspiration, there is a increase in total lung volumes, increase in residual volume, and also There is also a increased coving. There is increased coving, decreased peak expiratory flows, increased coving. That means it is severe obstruction. What is the cause of obstruction in COPDs? What is this graph? This graph is restrictive lung disease. Okay, there's a decrease in lung volumes. Total lung volume is decreased. Residual volume is decreased. There is a decrease in inspiratory flow. There is also a decrease in expiratory flow. What can anyone tell what is this? Variable or fixed? There are two components. Your inspiration is impeded. That means it is variable extrathoracic obstruction. What is this? Your inspiration is normal and expiration is obstructed. Variable intrathoracic obstruction. What is this? Your inspiration and expiration both are impeded. Variable, is it fixed? Is it variable or fixed? Fixed. Yeah. This graph is from a patient who comes with a Guillain-Barré syndrome, who has a reduced inspiratory flows, reduced expiratory flows, and reduced peak flows. What is 20, 30, 40 rule? What is the significance of 20, 30, 40 rule? Puddle capacity less than 20 ml per minute, P max of peak inspiratory pressure less than 30 centimeters of water, peak expiratory pressure less than 40 centimeters of water. What intervention you like to do in this patient? If it is less than 20, 30, 40, you'd like to electively intubate and ventilate the patient. Yeah. Any doubts? Yes, sir.
Hello.
Yeah.
Thank you, Seshi. See, probably one thing which we all understood, hopefully, the one things are there in ICUs, and we see so many abnormalities. We see, especially in ICUs, parameters which we usually monitor in clotting mechanisms, or bleeding tendencies. So we need to understand very clearly is what exactly we need to treat with, whether with the platelets, whether the cryopress plates, or with the factors, or with whole blood. So what is that we have learned from Dr. Seshi's talk is clearly it's a lucid talk which is explaining us from that graphs. It is clearly telling us that what is the basic abnormality with what we have to replenish in that particular clinical scenario. But only one thing which needs to understand is to know more about all those graphs. We need to practice more. One thing which I would like to ask Shashi, probably which place we are doing all these graphs? Are we doing in our hospital?
We usually don't do, sir, in most of the places. This is evolving technology, and this is not. This is at present we are using experimental places, and lot of most of the time it is used in liver units and trauma units in big centers, and I think we are not using it anywhere. I think so. Like especially in liver units, Secunderabad they have. I think so. It's a very useful regarding titration of products, blood products, unnecessary products inducing trolley, taco. This is very useful technology, but you need to practice it. You need to regularly use it to come into. And it also has a lot of pitfalls. And you need to, it fails to identify hypothermic induced coagulopathy because you are heating the sample at 37 degrees. And there is a lot of technical issues. The sample has to be fresh, whole blood, and the person has to be trained. 0.36 ml of blood has to be added to that, to the curate to get accurate trace. There's a lot of technical issues regarding TEG and ROTEM, especially TEG, not with the ROTEM, the TEG. There are a lot of technical issues.
So in our ICUs now, probably now we are not using here.
Yeah.
What are the other practical considerations we are following in our hospitals to manage in the patients where we are trying to give FFPs, where we are trying
Yeah.
to give respirates or platelets, and how to decide any other parameters we are following if we are not having those parameters in our hospital?
We are using basic static coagulation test. We are not using this. This is a dynamic one. This tells you what is happening with the patient inside at this point of time. The tag tells you that is nothing but starting from initiation, clot formation to clot lysis. It gives a complete picture. That's what static function test does it. Yes, you send a sample and interpret after 1 hour. Your tech tells you at this point of time what is happening to the patient. Is he having defective in platelet initiation, propagation, or is having more fibrinolysis? This fibrinolysis we see most commonly in trauma cases. That is the reason why we added tranexamic acid, because of the trauma-induced hyperfibrinolysis. That's the reason why people are giving tranexamic acid in trauma patients within 3 hours. Any doubts? Yeah.
Sir, without the values given, can we differentiate the ROTEM graph and a TEG graph?
You can't mix both. This is a different technology. This is a different technology. When your manufacturer gives you the machine, he will give you the reference values also. There are a lot of companies coming with TEG and ROTEM. They have different reference values. I just try to make you understand basic scenarios and basic values which you need to interpret. These are the basic things. In ROTEM, there are around 99 values to 100 values which the manufacturer gives. But we don't use all of them. We use only basics. Basics are your like CT, CFT, maximum amplitude, alpha angle, and CL30, CL60. These are the basic values which you need to understand. Yeah. Any other?
Basically, I just want to add a few things. Once, like we have exposure to tech, but I don't have much of exposure with ROTEM. Tech is a very good thing in one way, right? It's a point of care testing. You can do it within a 20-30 minutes, you can get a report. And where the problem is exactly, you can localize. We have some pitfalls in that because you need to have a fresh blood flow and it has to be done immediately and all those things. But still you can pinpoint where the problem is, but it's very difficult sometimes. For a case scenario, we had a case where post LSS, I still remember that lady, post LSS, she was continuously having oozing and the drains was continuously persisting only. It was not decreasing. We gave a lot of FFP as per the PTN and all those things. Then we have done a TEG. It was a primary fibrinolysis. We gave Tranaxa, everything settled. So most of the time it is difficult, like primary fibrinolysis and all those things, we will never know by any test. So even if the fibrinogen is normal, you give cryo, you give FFP, you give platelets, but still it will never get corrected without giving tranexamic acid. This is a typical case. Sometimes it will be helpful when it comes to TEG. I believe because it is a point of care testing and cost wise also it is not very high, you can do and get a report within half an hour. You send a PTN or repetitive platelet, it takes a longer time.
You send a sample,
So
after
that way,
2 hours the
I
dynamics
believe
must have changed.
That way it is, you can have ROTEM. I think it is more complicated. I have not much used, actually we have not used much of ROTEM, so can't give an idea. But TEG, yes, it is helpful if we can use.
Especially this TEG has replaced most of the, what do you call, for primary fibrinolysis, it has replaced the clot lysis time testing in most of the institute, I think so. But basically they still say it is on an experimental basis, but most of the centers are using it actually in liver and trauma centers. Yeah, thank you.
Thank you, Seshi. Thank you, Seshi, for your wonderful talk. See, probably one thing which you have agreed with other co-speakers also, like the role of tranexamic is much more there, and we're thinking that bleeding was there, as sir has clearly told, when we're not being replenished with FFP suppressants. So, but all those things will be clearly as shown as by dynamic testing only, and probably once in ICUs and all, we need to do more testings, and we need to get more acquaintance with all these testings, and will be more useful for the patient management. Thank you, Seshi, once again. Yes. And if nothing is there, we'll move on to the next talk.
I now request our chairpersons to felicitate our speaker, Dr. Shashikiran Reddy. I request Dr. K.C. Mishra to felicitate our chairperson, Dr. G.K.M. Reddy. I request Dr. Kiran Kumar Verma to felicitate our chairperson, Dr. V. Srinivas. I think all of you are eager for a cup of chai. You'll have to just hold on for another 5-10 minutes for that.
Yeah, I think we all wanted some interactive session. So we believe we'll have some mics on the front row so that we can all ask questions and interact. So regarding tech, how many of you have used tech? Can I have hands up, please? How many of you used tech? One, two, all consultants and senior HODs from the student side. How many of you have at least seen a tech report? 3, 4. Okay. On textbooks or on the lab reports? From the lab. So, any guess where it is commonly available in which part of your hospital? So, most of the times when you have a transplant program going on, and most commonly in the liver intensive care and liver ICU, it's commonly been used. Okay. So, in intensive care areas other than liver ICUs, where do you think the clinical scenarios where you can use it? Where is a mic? That's what I said. Be louder and be interactive. Some take that mic and be louder. We see we do understand there is a heterogeneity in the crowd. So we want all your juniors to also learn from you.
DIC patients in ICU to know the cause of bleeding. Bleeding patients, continuous bleeding patients.
So she says DIC. Okay, which kind of DIC you come across in your ICUs commonly? Which patients land up into DIC?
Post multi
Multi-organ
mul-
multi-organ failure patients into DIC.
or massive blood transfusion, post massive blood transfusion, patient is continuously bleeding. Post surgery, massive blood transfusion.
Okay. So post-operative massive transfusion, ongoing bleed
Ongoing
with
bleeding.
maybe some coagulopathy or some surgical causes, and those are the patient where she says there is a DIC and they are one. Any other patients, ma'am, where we come across in any ICU? Obstetric category.
Traumatic patients.
So traumatic hypovolemic shock with a massive hemorrhage. Any other surgical, particularly which surgical patient have a postpartum bleeding tendencies higher than other normal categories? Mahesh, which other common post-operative cases bleed? Cardiac and any other? Yes? Post obstetrics. So these are the few patients which if I have already a help or a DIC in PIH, these patients do bleed. And some of these ECMO patient, have you seen any of these cases which are already onto anticoagulation? They go into a transplant and they come back to the ICUs, they bleed. So see, many of the times now we have also seen a spectrum of COVID cases. We speak about thromboinflammation, we speak about endothelitis, we take endothelopathy. Other than the other common ARDS and pneumonia, are you all aware that these are all common words in the last a decade, the last year or so, a year and a half? So these also induce a lot of thrombotic phenomenon, and these patients sometimes bleed. Have you seen a patient bleeding and having thrombosis? In many of your intensive cares, you have a pulmonary vessels which got clogged and there is a DVT in some of those vessels, and the same patient start oozing from some of the sites. Is it been a common phenomenon? So many of the times in these scenarios, your APTT, PT platelets may look
relatively normal, somewhere platelet of 80,000, APTT somewhere in the same range, but the patient is oozing, having a clogging episodes. So some of these times you do not know how to get guided. Are you able to get what I'm saying? Whether I need an anticoagulation, whether I need a antithrombotic agent, or as I need an antifibrinolytic agent, some of the times we get confused. In this situation, there may be a guide. There may be a guide from the tech. Tech may not answer all your questions. After tech also, we have to break our head in some of the situation. But tech may have added advantage of giving some clues in this situation. As Dr. Misra said, these are all practical experiences. What we did, we asked a tech in these patients where a sample will be sent to a liver ICU or a sample will be sent to a transplant ICU where they will get test this and get a report, and the report comes onto your system or a printed paper where you interpret and treat it. Are you getting my point? It may not be available on your regular lab. Raise it, send it to your transplant ICU and get the report and treat it. That's how actually we try to utilize this tech in many of the situations. There are changed guidelines. For example, in obstetrics critical care, you said the patients are oozing. There is a shift of guidelines saying the target fibrinogen. What is the normal target fibrinogen of any our DIC patient?
150.
100 or 150, somewhere above that we just ignore the bleeding and we don't believe that is related to our fibrinogen. But in obstetrics critical care we jack up to 270. The newer guideline says it may be 270 or more. So that's how actually these all tag into come into play. Okay, thank you.
Thank you so much, Venkat sir, for the clinical pearls. At this point, I would like to say welcome to our chief guest today, Dr. Pavan Gorukanti, our group director. Hearty welcome to you, sir. And it's a pleasure to have you here today. I'll give you 2 minutes. So, knowledge is the light that drives away the darkness caused by ignorance, and we symbolize this by lighting a lamp. To do this honors here today, I would like to invite our chief guest, Dr. Pavan, to light the lamp, and to accompany him, I would like to request our clinical director Dr. Venkatraman Kola, and all the other faculty members and speakers to join in lighting the lamp, please. I request all the speakers as well to join, Dr. Yogesh, Dr. Prasad, Dr. Ramakrishna. I think there's too much of light on the stage, I guess. Thank you all for doing the honors. I would invite our course director for today and our HOD, Dr. BSK Pushri, to say a couple of lines, please.
Good, good morning, everyone. Okay. Good morning, everyone. So, uh, respected our director, Dr. Pawan, and my dear faculties and my all the teachers here and my delegates and our students, residents, all the hospital. So welcome you to all this program for today's program because there are uh, some innovative thought it was going for this program today, whatever we are conducting today. So initially we thought that this program, because at bedside what we are monitoring for the patient, whether you look at ECG, whether you look at IVC, whether by ultrasound, or you look at echocardiography, or you look at any of the investigations or EEG or even nerve conduction studies or even you central venous pressure or carbon dioxide, EtCO2, whatever the bedside monitorings we are doing, why not to do practically as a skill station for the students and for everyone it will get benefited. So with that thought process, the things were being started and we thought of it and how to implement it with help of Dr. Venkat Ramana. Actually, we how to implement it. So we started workup. So we had a plan of doing a workstation for that. But because of some difficulties, we could not do it. Actually, we did, this is like a case scenario based. So for that reason, it will be helpful to all. So this type of, in the future, what we are targeting is the bedside things which are helpful to the day-to-day activities for a diagnosis and treatment. So for that reason, which is helpful for the all the clinicians, all the students, and all the which are those people who are working in the critical care department. So, first of all, I want to thank Dr. Pawan, our director. So, because he has given us the platform here, platform and given us the opportunity. So, and he has a lot of interest for academic activities besides the our management. So, we are grateful to him for giving us opportunity here. And I want to thank Dr. Venkat for his constant encouragement for doing the programs here. And I want to thank all our faculties, our colleagues, and our department, and our residents, and everyone for kind cooperation for conducting the program. Thank you all. So I want to invite Dr. Pawan to say a few words regarding that. Fancy.
Just fancy stuff for 2 mics. Yeah. Thanks, Dr. Pushti. And wow, this hall is full on October 2nd, long weekend too. Yeah, great. Looks like critical care and anesthesia. First of all, thanks all for coming, mainly the students and younger and future generation. So, I mean, critical care and anesthesia is backbone of all medicine, as all of us know here. Like, the real heart of any hospital, like daytime, nighttime, anytime, COVID, non-COVID, like maybe I think second wave of COVID. After that, maybe now influenza will be a bad season. So whatever the kind of complications, dengue, anything, finally it will end up in critical care. And this yes, this is the real core of medicine. And gradually with specializations and all, like in US too, like critical care was initially managed by anesthesia, like doing part-time jobs, many people, and finally it went to its own specialty. And like rest of the things, like now, like not only critical care, each part of critical care now is also specializing, I think. So each one, like we realized ECMOs also, like suddenly it became popular. And ECMO care, transplant care, neuro care is so much different from other care, I think. So if you give D half NS or DNS or something, neurosurgeon may scream at you. So again, like each specialty is, but future is for critical care, because the most acute things are done here. And we thank all of you for taking your time and yeah, coming for this event, this wonderfully done event. Dr. Pushti here in Malakpet, and entire critical care team of all three hospitals taken a lot of pains and efforts in the background to organize this session. So all the topics are really good, like one of a kind. To like these things, everybody may not do this all the time, but still better to know all of these things. Neurocritical care, like tech studies, not general bleeding time, clotting times and all. Like what exactly is a tech study, when do you do this? PA catheter, PA catheter monitoring, yes, some people may say it's out of fashion, but no, it's always required in selected circumstances. So these things are important and good. And yeah, Dr. Subbareddy is here. He started Malakpet. Were you there 15 years ago or so, Subbareddy? 10 years ago. Like things have changed, but I'll tell it's changing even more. Outside renovation is done, but we have a new OP block, state-of-the-art OP block, just outside the hospital main block here. We are modifying. Once that shifted to the O block, OPD shifted, we'll start modification from top down. So it will look state of art here too. This part of the city, Malakpet was doing human service from a long time, and we'll keep ahead of the curve here. So thanks all for the chief guests from other specialties too, Palmari Vishweshwaran, Dr. Yugandhar, but who else? Krishna Mohan Reddy from General Physicians. Is he there or no? Okay. So now I can say that from physicians, it will pass on to critical care, future admissions and all of the, yes, it will gradually get there, I think. But it's cooperative approach for now, and I think we'll keep it that way. So, but all these are interesting topics, and we hope we'll serve you lunch and everything, but keep updated with these academic activities. We appreciate really on coming on this long weekend too. It will serve you good in the career, because nowadays there are so many doctors and all. You need to distinguish yourself with academics, publications, attending academics, and not only that. Like Venkat Ramana was not in Facebook till recently, but but now he is very active on there, because you need to be on social media, and everybody should know what exactly is happening. Any interesting personal reasons, yes, I have no comments. If you want, it's optional, but for professional things, you need to be on social media. And Subbarendi here leads full-fledged tele ICU thing in Apollo, and also you need to have a technology. You need to be at least know what exactly is there, and then pick your specialty and differentiate yourself, and it will serve you well. Thank you.
Um, I will just take 1 minute. I think we all here, the students, the faculty, the Department of Critical Care Medicine from Yasoda Group of Hospital. So we thank from our bottom of our heart. We have all gratitude to the management, including Dr. Pawan, for all these arrangements. Just we can't actually express our gratitude and thankfulness the way it has been arranged. Believe me, it's not an easy task. This has all been 1 month exercise to streaming, to actually create these all slides from the faculty to the moderators, from the hospital staff, because it's a COVID time and many things happened. And believe us, it was a cakewalk with the all support of the admin behind, the digital team behind, and the whole support of Dr. Pawan Guruganti. So we thank from all of us. A good applaud to Dr. Pawan Guruganti for this.
I would also request our special guest for today, Dr. Subba Reddy, President ISCCM Hyderabad chapter, to please address the gathering.
Good morning. Nice to see all of you here. Even like we thought we'll do a lot of ICCM activities when we took up the office, and we have been doing a lot of ICCM activities. And Yashoda Hospitals is supporting all the academic activities after the pandemic. Yashoda Hospital, Dr. Pawan, Dr. Venkatramana came forward to start like these milestones in critical care. We did in Yashoda, Somajigoda, and it was a huge success. Nearly 2,000 people viewed across the country that conference. And then again, very important topic, that is graphs and curves in intensive care unit. Again, always Yashoda Hospitals, whenever we want to do any academic program, Dr. Pawan is there with us. And IACCM, I can say Dr. Pawan and Yashoda Hospitals, with the help of Dr. Venkatramana, whenever we approach them for any good academic activity, so they are supporting. Thank you so much. Thank you, sir.
At this point, we'll break for tea. We'll reassemble in 10 minutes for the much awaited talk on ventilator waveforms. I request Dr. Venkatraman Kola to felicitate our chief guest. Thank you, sir. Let's break for tea and come back in 10 minutes, please. Thank you.
offline CME and critical care team, Venkatramana sir and Pushti sir and his team for a wonderful lectures, genuinely interested and most useful for ICU intensivist. So now next session is not Greek and Latin. It is your day-to-day practice in terms of intensivist. What ventilator will speaks with intensivist through waveforms. So now we are dealing with curves and graphs in mechanical ventilation after second wave of COVID. And for that, here we have a senior most intensivist, Dr. Ramakrishna sir. He worked from Yashodham, Secunderabad first and moved to here. And we'll see what he is going to explain and enlighten us. So please welcome, sir.
Thank you. Thank you, sir, for that introduction. Myself, Dr. Ramakrishna, respected seniors, my colleagues, and my juniors, and aspiring future intensivists. Good morning, everyone. Today I was told to discuss about ventilatory graphics. Before going to the class, why we need ventilatory graphics? That is the first important thing we have to assess. We need ventilatory graphics because there's a lot of patient and machine interface. In intensive care units, there's a lot of patient and machine interface because if you don't know about patient and machine, a lot of things will occur and the machine will go over the patient and may kill the patient. That's why these patient and machine interactions we need to be aware. A clinician can be called skilled only when he is completely aware of what is happening to the patient. So hence the ventilatory graphics, the display of ventilatory graphics is very, very crucial and very critical in diagnosing critical illness as well as in initiating therapy as well as giving the response to therapy, assessing the response to therapy. These are very important. So response to therapy is also assessed by ventilator. So with this small introduction, I will go into the topic. Very simple example, just to understand, is a 45-year-old diabetic hypertensive man intubated in casualty in view of severe respiratory distress. And he was shifted to ICU with ambu ventilation. And in our intensive care unit, he was initiated on mechanical ventilation. He was sedated and paralyzed. This is the real-time picture which was taken in our intensive care unit of a patient on mechanical ventilation. I have taken this picture just to keep you aware of what is happening here. These are the graphs. These side are scalars. This is our loops. For any patient who is on mechanical ventilation, if you stick on the graphs, we will get this picture. This is a volume control ventilation. How can you assess by saying this is a volume control ventilation? There are some features which we will deal and we will understand. These are the scalars. This side all time followed by pressure, flow and volume. The scalars are pressure, flow, volume and time. So wherever we will be seeing a mix and match of all these four only: pressure, flow, volume and time. In all these graphs, there is a mix and match. We should understand. So pressure versus time, flow versus time, and volume versus time. These are the scalars. These are measurable quantities. These are called loops. What do you define by loop? Loop means when it starts, it should end at the same point. That is called a loop. So here, this is a pressure volume loop. This side x-axis is pressure and y-axis is volume. This is a loop. So the loop is connecting. Here is a flow volume loop. Compared to contrary to spirometry, as already discussed by Dr. Shashi, this is completely reverse. This is completely opposite. It is inspiration and this is expiration. But in contrast to spirometry, this is opposite. And that you should understand. Otherwise, you will get confused. This is a volume control ventilation. This is a pressure control ventilation. The difference between pressure control and volume control ventilation are mainly two things. If you see in this graph, the pressure is already preset. So the basic difference is the pressure is preset. So when the pressure is preset, there is a difference in the flow and the volume. Basing on the lung compliance and patient characteristics or the tubings or circuits or lung volume characteristics, these change. But this is already preset and this doesn't change. So you should be aware of that. Flow, pressure, volume and time, these are the measured parameters. And why we need to know about ventilator graphics? To confirm the mode, directly by seeing the ventilator itself, graph itself, we can say whether it is a volume control mode or pressure control mode or a CPAP mode or pressure support mode or any mode. By seeing the graph itself, we can assess. That we will learn slowly. And detecting the auto beep and to determine where there is a patient ventilator interaction, whether the patient fighting with ventilator or is posing danger to the patient. The ventilator is posing any danger to the patient. Asynchrony. And if there is asynchrony, to adjust the trigger levels, measure the work of breathing, and adjust tidal volume and minimize over distension. Assess the effect of bronchodilator administration and detect any equipment malfunctions. And also to determine the appropriate PEEP levels. These are some of the things where we use in graphics. You see the breath delivery, the basic thing of a breath delivery is a ventilator cycle. This is a trigger, flow, cycle, and expiratory phase. This is the trigger. Trigger is anything, it is a signal which causes inspiration. It can be pressure signal, pressure trigger, it can be flow trigger, or it can be volume trigger. So anything that signals inspiration is a trigger, pressure, flow, or volume. And as soon as the trigger occurs, the inspiratory valve opens, followed by flow delivery. As soon as the inspiratory valve opens, flow delivery comes, followed by cycle. And after the cycling, expiratory valve opens. The inspiratory valve closes and the expiratory valve opens. Go to the expiratory phase. So any ventilatory cycle, trigger, followed by flow delivery, cycle, and expiratory phase. So these breaths are described by what determines the above phases. These are the most common used waveforms. This is a type of a scalar and loop. The scalars are waveform representations of pressure, flow, and volume on the x-axis versus time on the y-axis, as I have already told you. Can anybody identify this graph? Is a volume control or pressure control? Is a volume control graph with descending ramp. Flow versus scalar. Inspiratory. This is the inspiratory arm and this is the expiratory arm. Pressure versus scalar. I think I already discussed. These are the loops. Though this is the pressure volume loop. This is the flow volume loop. This is the inspiration followed by expiration. Inspiration followed by expiration. These loops are very important because these are the problems with flow and volume. Any problems occurring with flow and volume we can identify with these loops. This is the square wave flow pattern. This is commonly it occurs we see in volume control ventilation. Now we have got this latest microprocessor based ventilators where it is already all the microprocessors built inside and we can easily assess what is happening. These ventilators are mainly flow dependent. No need to adjust volume also. If you are able to set the flow, then the ventilator delivers. So these, if you see this type of graph, flow time graph, this is the upper arm is the inspiration and the lower arm is the expiration. Inspiration is active process done by the ventilator and expiration is a passive process. Basing on the lung characteristics, expiration is present. So we can assess the lung characters. So that's why this expiratory arm is whenever any graph is there, the expiratory arm is very helpful because it is a passive process and depends on the lung characteristics. That you should understand. And this is a constant flow pattern. Constant means the flow is delivered directly throughout the inspiratory phase. Throughout the inspiration, flow is directed. Suppose if you see a graph like this, sloping graph, decelerating graph, flow is in the first half flow is more and the later half flow slowly comes down. So that means inspiratory time is more, allowing for more breathing for the patient so that the terminal alveolar are filled. So this is a typical square wave flow pattern. Square wave flow pattern mainly in volume control ventilation. This is the decelerating ramp. The inspiratory flow rate decelerates as a function of time to reach the zero flow at end inspiration. But whereas in constant flow, it is complete. For a given tidal volume, the inspirator time is higher in this type of flow pattern as compared to the square wave pattern, as we have already discussed. This is a without seeing this, I think you should be able to tell what is this type of ventilation. This is a volume control ventilation. How you are assessing is a volume control ventilation because square wave pattern. And you see the volume graph, it is very sharp. When you see a sharp volume graph, you can say that it is a volume control ventilation. Volume is sharp because the volume is flow is preset and followed by volume. So volume, the amount of gas the ventilator gives, the amount completely goes. So that's why volume graph in volume it is a sharp. Contrary we use in pressure control ventilation. In pressure control ventilation, the graph doesn't look like this. It is different. So here we see the pressure. In pressure control ventilation, pressure is straight. I think you have observed. But here, the pressure volume is like a slow slope. Basing on the lung characteristics, this differs. That is the thing we have to understand. This is the pressure control ventilation. The pressure is constant. The preset level pressure is constant. And you see the volume. If the lung compliance is good, volume will be good. And see the slow gradual rise in volume. So that difference you have to understand. What is the pressure control ventilation and what is a volume control ventilation. Even if it is not there also, you should be able to tell. And the same thing, the descending ramp flow pattern. This is a descending ramp flow pattern. Prior to that, we have seen square wave pattern, and other patterns are also there. The ascending pattern is also there, and the sine wave pattern is there, and the convex pattern is also there. But all those patterns are absolute, and we are not using nowadays. Only the patterns we are using are square pattern and descending pattern. Okay, that you should understand. So in the pressure control ventilation, this is the inspiratory arm followed by the expiratory arm. I hope you understood about the differences between pressure control and volume control. You see the pressure, now we will go to the first pressure time curve, the first curve. We see the spontaneous breath, the mechanical breath, the control versus assisted breath, and the components of the inflation pressure. As well as in pressure time curve, we can identify increased airway resistance, effect of high inspiratory flow, decreased lung compliance, and inadequate inspiratory flow. By using this pressure time curve, we can identify all these abnormalities. I repeat once again, increased airway resistance, effect of high inspiratory flow, decreased lung compliance, and inadequate inspiratory flow. You see the spontaneous versus mechanical breath. The first breath is a spontaneous breath, inspiration followed by expiration. It's a spontaneous breath completely. You see this is a mandatory breath given by the ventilator. The mandatory breath means there is no triggering. That means the patient should be paralyzed. So when the patient is paralyzed, you see this type of breath. There is no triggering. Triggering will not be there. If there is any triggering, then we can say it is an assisted breath. The ventilator delivers the less amount of volume. Only the thing the patient should do is to trigger. So this is a mandatory mechanical breath. This is a spontaneous breath. See this triggering. The patient is triggering, then the ventilator is delivering the rest of the breath. This is a pressure time curve. This is a pressure time curve. Patient is triggering a breath, and the ventilator is delivering the rest of the amount of breath. So this pressure is starting from 0 or this one. So what is this difference? Can anybody say? It is a PEEP. If you adjust PEEP here, the breath starts from here. If you adjust here, if there is no PEEP, the breath starts from here. Okay, that is a thing whereby This pressure time curve, we can observe all these things. This is adequate flow during volume control ventilation. How can you say it is an adequate flow? We can say that this is an adequate flow because you see the steep rise in pressure curve, rapid rise in the pressure curve. When there is a rapid rise in the pressure curve, soon after when the breath is delivered, there is a rapid rise in the pressure curve. When there is a rapid rise in the pressure curve, then you can get that flow is adequate. Okay. Now we go to the components of inflation pressure. It's a very important thing. This is a pressure time curve, and we see the components. Steep rise is there, followed by peak inspiratory pressure, plateau, followed by expiration. This rise mostly because when a volume is delivered, there is a fast rise into the lungs. So this shape, when the flow is going through the airways and circuit, upper airways, when the flow is going through the upper airways and the circuit, we get this graph. And once the breath has been delivered, it should go into the alveoli. So the amount of air, this grows into the alveoli. So when the air goes into the alveoli, pressure is decreased. So this is all the plateau pressure. So when plateau pressure, air goes into the alveoli. Thereby pressure is decreased. Okay, I think you are understanding. So soon after the complete air goes into the alveoli, cycles into expiration. So this plateau pressure means that alveoli are filled. Okay, this is the peak pressure. So this peak inspiratory pressure and the plateau pressure. This tells us about the compliance of the lung, alveolar opening. If the alveolar compliance is good, this will be with low pressure, they expands. This informs us about the ventilatory circuits, ET tubes, and the upper airway pressures. That you should understand. This is the same example. Alveolar distending pressure and airway resistance. Suppose this is normal and this rises, we should think that ventilatory circuit or ET tube cuff or upper airways are blocked. This is the PEEP, positive and expiratory pressure. When the breath starts from the PEEP level. Now let's look at some of the things. What I have already told you will be there in these graphs. This is a normal pressure time waveform with normal peak pressures and plateau pressures and airway resistance. You can see this graph. Plateau is normal, peak is raised. Hence we can say that it is a ET tube block. Square wave flow pattern is what kind of ventilation? Volume control ventilation, square wave from is here. We can see the increased pressure, peak pressures. One minute. So this is the waveform which is showing a decreased compliance, decreased lung compliance. You see this has risen. This is a normal graph. The normal graph, you see the plateau pressure. The plateau pressure is raised. The peak pressure is also raised. So there is a transmission to the airways also. So plateau is raised and peak is raised. You can diagnose, most commonly routine diagnosis is ARDS, heart failure with severe pulmonary edema, pneumothorax. All these things we can identify. Pleural effusions, abdominal compartment syndrome, and so on and so forth. The increased airway resistance, this is normal, this is increased airway resistance. Decreased compliance, the compliance is decreased, the difference, high plateau pressures. The waveform showing decreased compliance, you see the graph, almost very small difference between peak inspiratory pressure and plateau pressure. Now we go to the flow time curve. I hope that this pressure time curve you are able to learn some points. Now we go to the flow time curve. The flow time curve, we can see the spontaneous beds, the mechanical beds, the typical flow patterns, the inspiratory flow, the expiratory flow, and recognition of some common abnormalities like obstruction, active expiration, response to bronchodilator therapy, air trapping, and autopeep. So we can, by flow time curve, we can assess these problems. You see the mechanical breath and the spontaneous breath, the flow time curve, this is inspiratory arm, this is expiratory arm. The inspiratory flow pattern. Now we can see this is an inspiratory flow pattern, this is a curve, flow time curve, this is inspiratory arm, this is the expiratory arm. Generally inspiration arm and expiratory arm area should be equal. Whatever is going in should come out. Then only it's normal. If anything is not coming out, if anything is not going in, then there is a problem. So this upper arm should be equal to lower arm. When any difference is there, then there is an abnormality. The critical abnormality is there. That you have to find out from these curves. So this is the peak inspiratory flow rate, peak expiratory flow rate. So peak inspiratory flow rate and peak expiratory flow rate. The problems we can identify. Then expiratory time also we have to see the time. Peak expiratory flow rate and the time also we have to see. By seeing these things we can understand. So peak inspiratory flow rate, peak expiratory flow rate, and the area. This is the flow time curve, normal curve. This is a volume control ventilation curve, we can say. This is a pressure control ventilation. This is a inspiratory pause here. And now we can see the use of a flow time curve, air trapping. Air is going inside, but it's not reaching the baseline. This flow time curve. Air is not reaching the baseline, but suddenly another shoot up is coming. Okay? This is an air trapping. Autopeep. Solely for each and every breath, some amount of volume will stay in the lung. Gradually, autopeep rises, and at one point of time, patient will not breathe. He is unable to trigger a breath, he will not breathe, and patient will die. This obstruction versus active expiration. This obstruction, active expiration. You can see in this obstruction, what we can see here, the decreased peak expiratory flow rate is there. Decreased peak expiratory flow rate, and as well as the time. Expiratory time is prolonged. So in an obstruction, expiratory time is prolonged and a decrease in peak expiratory flow rate. These two things you have to understand. Active expiration, you can see peak inspiratory flow rate is increased. So increased peak inspiratory flow rate and the time. Time is short. Short E time with decreased peak expiratory flow rate, there is active expiration. The response to bronchodilator, before giving bronchodilator, it was like this, but soon after administration of bronchodilator, we can see the expiratory flow rate is increasing and the time is also less. So air is moving in freely outside. So this is the response to bronchodilator therapy. That's why graphs are very important. If you are able to assess these graphs, you can easily identify and treat the patient. This is a lung over distension. When you suspect this, when there is increased peak inspiratory pressure as well as high expiratory flow rates. Peak inspiratory pressure is increased, peak expiratory pressure and higher expiratory, and this is both are increased. They are going against each other. Then you can say this is a lung over distension. The pressure time waveform shows an abrupt increase in pressure. So think of, and especially in this case, you can think of a right stem intubation, low lung compliance, and excessive tidal volume. So again, we go to the flow time curve. Then air leak. This is a flow trigger. So air leak is coming. So this is an inspiratory problem. This is an inspiratory problem. Okay. Autopeep. Recognize autopeep. When expiratory flow continues and fails to return to the baseline, as we have already seen in the previous slide, it fails to return to the baseline. Okay. You also notice how expiratory flow fails to return to the baseline, causing progressive air trapping. So when there is progressive air trapping, the peak pressures also rise. Progressive air trapping is there. So gradually over a time of period, if you don't address it, if you are not able to address it, diagnose and address autopeep, the gradually peak pressures also rise slowly. So that you should keep in mind. This is an important slide where how the flow rates affect the IE ratios and the development of autopeep. Previously, I have told you on graph, increased flow rate, increased peak expiratory pressures. When the flow rate is increased, the I time also decreases. When the flow rate is decreased, the I time increases. That you have to understand. Suppose the patient, some person going at within first second, if he is going on a motorbike 60 kilometers per hour, and if the patient going on a motorbike at 20 kilometers per hour, who goes fast? The person who is going 60 goes fast, and the person who is going 20 will go slow. So that is important. If the flow rate is high, the TI will be low. That you should keep in mind. If the flow rate is high, TI will be low. Okay. So here, this is not a liters per minute. This is a liters per second graph. Just for your understanding, I have kept this. So you see this graph. This flow rate is high. The I time is low. You should be able to appreciate this well. The flow time is high, flow rate is high, and as you see this last one, it is low and the time in seconds is low. So the I time is increased. When the I time increases, naturally the E time comes down. When the E time comes down, amount of air to come out doesn't. So there is a progressive air trapping. So when there is progressive air trapping, patient will go into autopeep and the complications of autopeep. This is an example, just a ventilator setting, just for your understanding. If you see in the first slide and you see in the second slide. Anyway, inspiration is an active process, normal spontaneous breath, and expiration is passive. Suppose a patient is breathing 15 times per minute. Then one breath is 4 seconds. Generally, inspiration is an active process. It takes 1 second, and the expiration is passive process. Almost, for example, you say 3 seconds. So I used to use 1:3. Okay. So I used to use 1:3. So whatever the air left will come in those 3 seconds. But if you reverse that, the final setting, suppose I used to have kept 1.5, that means inspiration half and expiration half. There is a less time for expiration. So there is high chance of developing autopeep. Like recognizing flow starvation. Look at the pressure time waveform. If you see this kind of scooping, is a pressure time waveform, there is a scooping. It is not a steep rise or rapid rise or uniform rise is not there in a pressure time waveform. Whenever you see this pressure time waveform, you have to find out that we can say that flow starvation is there. Now we have completed pressure time and flow time. Okay. Next we will go into the volume time. This is the third scalar. Now we will go to the volume time. This is, as I have already previously told you, whatever goes in should come out. So inspiration, expiration. This volume time is volume to the sharp curve. It is very sharp. This is an active escalation. The patient is breathing and in active escalation, the whatever the reserve volume, it comes out. That you should identify. Active escalation. Peak inspiratory flow rate is increased in active expiration. At the same time, pressure is raised. This is an air leak. Air leak is a volume problem. It's not a flow problem. Okay? It doesn't return to the baseline. So, whenever you want to diagnose a condition, don't depend on a single graph. Okay? You can take a match, a mixed of all graphs. Then you can 100% confirm that, okay, this is a diagnosis and it requires this type of management. So don't rely on one single graph. This is an air leak. In flow time also I will show you air leak, how it looks like. Other graphs also I will show you. Okay. So now we have completed pressure time, flow time and volume time. These 3 graphs we have completed. And what we have learned from these 3 graphs? Airway resistance, detecting compliance, detecting air leak, lung over distension. So all these things basically we have to identify, and you will learn this when you go home and read your books on mechanical ventilation, you will have a further understanding and interpretation. Now we will come to the loops. Flow volume loop. So recognition of common abnormalities like air leak, auto peep, increased airway resistance, airway secretions, and accumulation of condensates. The flow volume loop, we can apply this knowledge of these loops and recognize these things: air leak, auto peep, air trapping, increased airway resistance, airway secretions, and accumulation of any condensate. This is a typical flow volume loop. Inspiration is on the upward, expiration in the downward arm. You should not, once again I am telling you, don't confuse with spirometry loops. This is the volume. This is the flow. You remember this because in the next slide we have to understand where this loop ends. If the loop ends here, this is a volume problem. Suppose if the loop ends here, this is a flow problem. So you should identify what is a volume problem and what is a flow problem. So any problem, if the loop is ending here, volume. If the loop is coming out and ending here, it is a flow problem. So volume problem and flow problem, you should understand. So airway secretions, water in the circuit, the inspiratory arm will be good, but expiratory arm there is a disturbance, oscillations are there. Because during inspiration is a forced process on the ventilator. So air goes in, even though there is some problem, air goes, but expiration is a passive process, and the secretions are condensate, anything, the loop appears like this. This is a water, airway secretions or water in the circuit. If you see this type of graph, better do some suctioning of those things. Air trapping. Air trapping is a volume problem or flow problem? It's a flow problem. See in the flow curve. So air is trapped. So is not meeting. The loop is not connecting. Loop is not getting closed. Whenever you see the loop is not getting closed, means there is a problem. And it can be a volume problem or a pressure problem. Okay. So the loop is not getting closed. So this is air trapping. So now you compare the flow time and the flow volume loops. Air trapping. You see the air trapping, auto peep. I hope you know the difference. Air leak. Now this is a pressure problem, a flow problem, or a volume problem? It is a volume problem. It is not a flow problem. That you should understand. Okay. This is a flow problem, volume problem. So leak, air leak is there. How the air leak appears in volume control ventilation? Volume time graph. The expiratory arm doesn't reach the baseline. You just remember my previous slide. So here it's applying like this. So when you mix and match of these, you should be able to identify these things. Increase airway resistance. Decrease in peak expiratory flow rate. And because of resistance, it fastly comes to the scooped out. The expiratory curve is scooped out and its area is also less. Decrease in peak expiratory flow rate and it is scooped out. You see. So we mix with the other graphs, high airway resistance. You see the same thing, high airway resistance. Now we come to the pressure volume loop. This is also very important. Pressure volume loop. This is inspiratory arm. And this is the expiratory arm. Whenever you find any abnormality in this arm, problem with inspiration. Problem with expiration. Okay? This is the type of breath. This is a controlled breath, this is assisted breath, this is the spontaneous breath. See the controlled breath, no triggering. And it is rising from here. This is a controlled breath, inspiration, expiration. See the second breath, it is a triggered breath. See, it is like a triangle. It is starting from the opposite quadrant. That means patient is triggering. Only patient is triggering only, the breath will deliver. So this is opposite quadrant. So means it is an assisted control breath. Assist control breath triggering a breath. This is spontaneous. This is inspiration, complete expiration. So type of breaths. Next is the PEEP and the P volume. If it is coming from here, there is no PEEP. So the graph has shifted to side. So this is the PEEP level. So PEEP means it may be around 5 or 10 like this. So the ventilator is starting from here. The inspiratory breath is starting from here. This is the application of PEEP. Inadequate inspiratory flow. See, there is a active inspiration, inadequate inspiratory flow is there. In the pressure time curve, there is a uniform rise is not there. I think you have seen the pressure time curve. There is a scooping. Air leak, you have to identify what is this problem. Is a volume problem or pressure problem? Is a volume problem. Okay, air leak is a volume problem, not a pressure, not a flow problem. So it's not coming to the baseline. If you see this type of graph, it's a volume problem. Sometimes it can stop here also. It can stop here also. So anywhere it doesn't reach the loop. It doesn't reach the baseline. So this is a volume problem. Now you see all the graphs I have kept in one place for air leak. Air leak is very important. There can be inspiratory leak as well as expiratory leak. Okay, inspiratory leak and expiratory leak. Inspiratory leak means upper side, ventilator malfunction, circuit malfunction, any flow in sensor problems, all will cause inspiratory leak. Expiratory leak, can anyone tell me? VT tube deflation, cuff deflation, bronchopleural fistula, okay, chest tubes. I will tell one scenario. A Ryle tube in the lung also can cause expiratory leak. A Ryle tube in the lung can cause expiratory leak. Okay, so these are the air leaks. Hope you have understood this. Then the work of breathing. Resistive work and elastic work. This is the elastic, this is the resistive work and this is the elastic work. Elasticity means coming to the normal position. If you take a spring and you do it like this, expand, again the spring should come to normalcy. That coming to normalcy, that is the elastic work. Okay, expansion is the resistive work. I hope you will understand this. This is the resistive work and this is the elastic work. Coming to normalcy is the elastic work. Okay. Increased airway resistance. For a unit rise in pressure, pressure has risen, but the volume has not risen so much. You see, the volume is same, but pressure has risen. That means the airway resistance is there. Decreased compliance. You see this loop, pressure volume loop. The normal loop should appear like this. You see, for more increase in pressure, the volume is same. Volume is almost volume is same. Almost if you think that pressure is 15 here, volume 500, pressure 20, volume 500, pressure 25, same. So when this graph is sleeping, when it coming to the sleeping position means compliance is very, very less. And the graph is sleeping. And if this graph is standing, compliance is more. You note down the difference. If the graph is standing means for very low pressure given, the volume is more. You can see more volume. So the graph is standing. Whenever you see a steeping in the graph slowly coming down, then we have to think that compliance is less. It's a volume targeted ventilation. You identify this problem. Volume target ventilation. You can see the volume is same, but depending on the compliance and lung characteristics of the lungs, there is a change in the. So in spite of different pressures, the volume is same. is a volume targeted ventilation. So decreased compliance means this red one. Even with high pressure, same volume is coming. So decreased compliance. The same graph you can see if you are able to see in the pressure control ventilation. This thing you can see. So uniform pressure but different volumes. So the more compliant is the green one, the less compliant is the pink one, down one. So that is how we make out the difference. The inflection points, very important. The same graph, the lower inflection point, this is the upper inflection point. The lower inflection point means the amount of air which is required to open the alveoli in a distance. Closed alveoli will be open at this point. This is the lower inflection point. Upper inflection point, already alveoli are completely open, and further pressure from that point is deleterious only, and however pressure much you may increase, the volume doesn't rise. That is called the upper inflection point. Lower inflection point, upper inflection point. You have to make out the difference. Lower inflection point means alveoli are open. The pressure required to open the alveoli. So some people advocate to keep the PEEP in that state when you are going for a ventilation. So if the lower inflection point is suppose 10, you keep the PEEP 10 so that the alveoli will be in a completely open state.
So 5 more minutes.
Yes. This is a pressure volume. Look, beaking is there. If you see beaking, is a over distension. The lung over distension, you see the beaking. So at any point of time, even if you increase the pressure, the volume doesn't increase. That is a beaking, and the light is an over distension. These are the modes of ventilation by identifying. Is a time triggered, pressure limited, time cycle ventilation. I hope you can understand these modes. These are basic. I assume that you know these basics. Time triggered, flow limited, and volume cycle ventilation. This is a volume targeted ventilation. This is assist control, assist mode of ventilation. There are assisted trigger. This is SIMV. SIMV, these are the assisted SIMV breaths. This is the control breaths. This is a pressure triggered ventilation. What is the difference between pressure support ventilation and pressure control ventilation? Pressure control ventilation means high time, effort, all things are controlled by the ventilator. But in pressure support ventilation, patient will have an inspiratory effort, and it is flow cycle and pressure support level. So that is the only difference. In pressure support and other pressure control means pressure support ventilation is a flow cycle ventilation. Suddenly some flow stops somewhere, the breath is stopped. So that is the difference. SIMV plus pressure support. The pressure support versus CPAP. This is CPAP means CPAP is nothing but PEEP. Patient is breathing actively. Okay. Asynchrony. This is also a very important part. The patient and ventilator interactions. Asynchrony is a mismatch between inspiratory patient's efforts and ventilator support delivered by the ventilator during assisted ventilation. The pressure is very minimal. Sometimes you can identify and sometimes you cannot identify also. The asynchrony. And the main thing is the patient may fight the ventilator and may die on the ventilator. If you are unable to diagnose the asynchrony, patient can die also. But at the same point, minor problems will also be there. Is the types of asynchrony. Asynchrony is different into so many types. Please give me some 5 minutes, sir. I will complete it. Inspiratory, asynchrony can be inspiratory or expiratory. Okay? Inspiratory asynchrony means trigger and flow. Okay? Trigger and flow. Trigger delay, flow problems, and expiratory asynchrony is also there. That is related to cycling. Premature cycling and delayed cycling. Okay? So there are almost 7 types of asynchronous. Trigger asynchrony, ineffective triggers, delayed triggers, reverse triggering, and flow triggering. These are all inspiratory asynchronous. Expiratory is cycling. You should understand. There are 7 types of asynchronous we should be able to understand. Okay. This is a trigger asynchrony and flow. Trigger asynchrony and flow asynchrony are inspiratory. This is cycling is an expiratory asynchrony. Okay. In inspiratory, trigger delay, double cycling, mistriggering, auto triggering. Trigger delay. Trigger delay means in most of the conventional ventilations, patient triggers a breath and immediately ventilator gives. A small delay will be there, but in the normal new modes of ventilation, that is addressed. So no need of is a trigger delay. Then double triggering is a triggering and reverse triggering. Reverse triggering means generally trigger starts at the inspiration. Reverse triggering means patient triggers at the end of inspiration and tries to give a breath. That is called reverse triggering. Mostly occurs in lung over distension, those things. This is the most common type of trigger. Among all the 7 triggers I have told you, this is the most common trigger, the wasted efforts. An area pressure drop not followed by a ventilator cycle indicating the patient's effort was not detected by the ventilator. When the patient's effort was not detected by the ventilator will not give a breath. So we can see how the rapid work of breathing also will be more. Whenever the patient triggers a ventilator, he has to breathe a lot of effort. So when the trigger is wasted, a lot of energy is wasted. That is the thing. So we have to address that. This is a double triggering to increase respiratory dive. Some double triggering will be there. This is caused by high respiratory dive, low tidal volumes, and short inspiratory time. And the solution is to increase the I time, double triggering. So increase the inspiratory time. The third type of triggering is auto triggering. This is also an inspiratory trigger. The trigger is too sensitive. There are so many non-respiratory factors are also involved in triggering the ventilator. Too sensitive trigger. You can see this. Inappropriate high settings, cardiac oscillations, leak from circuits, leak from chest drains, large volume of secretion, swallowing, vomiting, peristalsis. These are all triggers in auto triggering. Inadequate flow, meet reach to triggering. So increase the flow rates. Okay. Premature cycling. The premature cycling and delayed cycling, these are the expiratory asynchronies. Okay. Expiratory asynchrony is in premature cycling, generally patient's neural time is long. The ventilator time is short. It's a different concept. Neural time is long and ventilator time is short. So what happens? Ventilator cycles off to expiration, but still the patient will have a sense to breathe. So what he does is, in the expiratory part, patient tries to breathe. Okay. When the patient tries to breathe, if it this premature cycling occurs, and sometimes this that effort is sufficient to trigger a breath. During the inspiratory phase, that is sufficient to trigger a breath, and double triggering may also occur. Okay. There is a premature cycling. Inadequate section of TI. In while ECV decrease in inspiratory flows, PC increase the inspiratory times. These are some of the things we have to see. Delayed cycle means the opposite happens. Ventilatory item is more, patient's neural item is less. So ventilator will be in the inspiratory phase only. Patient cycles into expiration. He tries to breathe, and at the end of the expiration, he tries to initiate a breath. That is causing the delayed cycling. Okay. Increase the inspiratory flow rate, decrease the inspiratory time. But these cycling expiratory asynchronous are very difficult to diagnose. Requires the use of a esophageal manometer. Thank you.
Thank you, sir.
Thank you, Dr. Ramakrishna, sir, for an elaborative lecture on mechanical ventilation waveforms. If there are any questions, we can take 1 or 2 questions in the interest of time. So just I have one doubt, like one of the most important complications we see in a COPD patient coming in exacerbation and landing upon ventilator is the auto-PEEP. So what are all the initial managements you do to overcome this auto-PEEP? Because we all know this auto-PEEP is going to cause a delayed triggering, is going to have an effect on the hemodynamics of the patient. So what are all the initial things which you would address while before you correct this auto peep?
Yes, sir. For auto peep correction, I think you have already told you try to increase the expiratory time, decrease the rate, increase the expiratory time, decrease the rate, and you can increase the flow time so that TI comes down. Okay, these three we can do, and slowly auto peep will come down.
So, yeah. So see what really because this is COPD is one of the things where our general mechanical ventilator settings actually do not work, because when you if you see a patient who has been intubated for an advanced COPD and the patient is fighting, the most the what reflexively we do is we just try to sedate the patient and we don't look into the loops and the graphs. So we need to understand the pathophysiological mechanism. The major mechanism that happens is that a patient is going to have a bronchospasm and there is going to be a secretion. So because of that, whatever the air you inflate, it goes in, but it doesn't come back. And what really happens if you see the serial waveforms, there is a progressive increase in your autopeep. So the first and the foremost thing which you have to do is to address the pathophysiology. So what you really, rather than increasing the tidal ventilation, probably you may have to decrease the tidal volume and you have to in fact decrease the respiratory rate, give a more duration for an IEs to E ratio, and you have to adequately bronchodilator these patients, and you should make sure that there are no secretions in your endotracheal tube. So and you need one of the major problems what happens is when these people get sedated without addressing the underlying problem, your duration on mechanical ventilation increases, and this results in increased mortality. So this is one of the few things which many of us do miss. And another important thing, as sir has rightly said, is the dyssynchrony. So any patient fighting on ventilator, the reflex shouldn't be like go and sedate and paralyze the patient. Address to the problem. Probably you are missing a pneumothorax that you can pick up by noting a decrease in the complaints, or address to a auto triggering because there might be a condensation of the water in the circuit which you generally miss because you do not see, or the patient might have a lot of secretion in the endotracheal tube which you have missed, or patient may be actually suffering from pain which we don't give. Sometimes we just paralyze the patient without increasing the adequate level of sedation and analgesia. So these things you should actively should look before you sedate and paralyze the patient. Address to the problem than to just the symptom relief what you provide. Thank you, sir.
Thank you.
Thank you, sir. I request our chairpersons to felicitate our speaker, Dr. Ramakrishna. I request Dr. Shashidhar Pulgam to facilitate our chairperson, Dr. Yugandhar Bhatt. I request Dr. Karthik Munta to facilitate our chairperson, Dr. Vishweshwaran. Thank you so much, sir. Now we move on to our next talk. In order to chair the session, I would like to invite Dr. Shashidhar Pulgam and Dr. Kiran Kumar Verma. Welcome, sir.
Next session is on ECG waveforms. This is by Dr. Sai Kiran, consultant at Yashoda Malak.
Thank you, sir. So I guess in trying to decode the loops presented by Ramakrishna sir, at least some of the hearts here must have skipped a beat. So I think this is a good time to talk about ECG waveforms. I am Dr. K. Sai Kiran, and over the next 30 minutes, we will be looking at around 15 ECGs. These are the ECGs, some of the most commonly seen and some of the most clinically relevant ECGs. And instead of the routine PQRST descriptions, we will look at all these ECGs in a clinical case scenario type of view. So let's start ahead with our first patient. The first patient is a 40-year-old male with no comorbid conditions, presenting with 2 hours history of retrosternal chest pain. And this was the ECG taken in the ER. Would anyone like to have a go at it?
ST elevations in lead 2, lead 3 AVF.
Yes, that's right.
And V5, V6.
Absolutely.
And with reciprocal ST depressions in V2, V3.
Okay, wonderful. So I think I have a pretty intelligent audience here, so my task may be a little easier than I thought. So as you rightly said, there are definite ST elevations in 2, 3 AVF with ST depressions in V1, V2, V3 as well. But is that it? It's looking like an inferior wall ST elevation MI. But is that it? Or do you suspect something more that is in play here? There are ST depression. Sorry. Absolutely. Absolutely. So what do you want to do next? You would want to take a posterior lead ECG, an ECG with posterior leads. And as you rightly said, we did that. And now can you appreciate the changes here? We took an ECG with V7, V8, V9 leads. If you look back at the previous ECG, in the V4, V5, V6, there are pretty much no significant changes. Now you appreciate frank ST elevations with Q waves in V7, V8 and V9. So there is involvement of the posterior aspect of the heart as well. In a regular ECG, the anterior leads, that is the V1, V2, V3, are looking at the electrical activity on the posterior side of the heart from the anterior way. So you find ST depressions. And when you repeat an ECG with a posterior leads in place, you find an exact mirror image of the changes that you've seen before. The tall R waves become Q waves, the ST depressions become ST elevations, and the T and upright T waves become T inversions. So all in all, this patient is having an inferior wall MI with posterior extension. That means it's a large territory infarct. These patients tend to have significant left ventricular damage, and the prognosis also tends to be poorer. Let's look at the next ECG. A 35-year-old male presenting with chest pain and diaphoresis, rightly suspecting an acute MI, and the ER nitrates were administered, following which there's a substantial drop in the blood pressure. This was his ECG taken in the ER. Anybody for the ECG? Like in the previous ECG, there are significant ST segment elevations in 2, 3 AVF. Okay. There are certain ST elevations in V1, V2 as well. So there is definitely an inferior MI in play. But if you've noticed the stem, the patient, after being administered nitrates, the blood pressure fell. And why would that happen in regular inferior wall MI? Absolutely. So what would you do to confirm that? You will repeat an ECG with a right-sided lead, and that is what we did on your advice. We took a V4R lead, and you can appreciate clear ST elevations in the V4 lead. So this goes to show that apart from the inferior wall, there is an extension of the right side with RV infarction as well. In a regular ECG, now when do you suspect that there may be a RV infarction in place as well? In a regular 12 lead ECG, lead 3 and lead V1 are the only 2 leads that are looking at what is happening on the right side of the heart. So if you observe keenly here, the ST elevation in lead 3 is far more than the ST elevation in lead 2. The ST elevation in lead V1 is far more than the ST elevation in lead V2. So whenever the ST elevation in lead 3 is more than lead 2 and lead V1 more than V2, then you must suspect a right-sided infarction as well. Repeat an ECG with right-sided leads, and patients with RV infarction tend to be preload sensitive, so they respond better to fluids rather than administration of nitrates. Let's look at the next ECG. An 80-year-old female presents with chest pain. She has a history of second-degree AV block for which a permanent pacemaker is in C2. So she started from her home when she had chest pain, and by the time she reached our ER, the chest pain had pretty much subsided. And this was the ECG that was taken in the ER when she had very minimal chest pain. So you can clearly appreciate certain pacing rhythms. The RV pacing with an LBBB pattern of QRS complexes. Now, whenever you have a left bundle branch block, the left side of the heart is getting activated by electrical impulses coming from the right side of the heart. That is an abnormal depolarization. An abnormal depolarization will always be followed by abnormal repolarization as well. That is in the form of changes in the ST segment and T waves. So in the presence of a regular left bundle branch block, you will have ST segment changes. If there's a predominant negative QRS complex, you will find ST segment elevations. And if the predominant QRS complex is positive, you will find ST segment depressions. And these are not to be mistaken for acute ischemic changes. They are normal reciprocal changes in response to a left bundle branch block. Then, what if a patient is really having an acute ischemic episode in the presence of a pre-existing left bundle branch block, either with a patient with permanent pacemaker or in a patient with pre-existing MI? To make our life easier, we have certain criteria called as the Sarbosa criteria. There are three components in this Sarbosa criteria. One is the concordant ST elevation MI. Let me tell you what is concordant and discordant in this context. As I told you before, if the predominant QRS complex in an LBBB is negative, you find ST elevations. This is termed an appropriately discordant ST segment elevation in response to the LBBB. So, a concordant ST elevation MI of more than 1 mm carries 5 points. An ST depression of more than 1 mm in lead V1 to V3 carries 3 points. And a discordant ST segment elevation of more than 5 mm carries 2 points. So if you have a sum total of more than 3 points, they are mostly 90% specific for an active ST elevation MI. A newer criteria added to this called as Smith-Sargosa criteria takes into account the ST by S ratio. If the discordant ST by S ratio is less than minus 0.25, that also points to an acute ST elevation MI. That is the ratio of the ST segment elevation measured at the J point to the R or S wave, whichever was most prominent. So coming back to this patient, once she was in the ER, she had a recurrence of her chest pain, and we repeated an ECG again. If you compare her ECG from the previous one, there are frank progressions of the ST segment elevations and T elevations in this next ECG. And the changes in these ECGs satisfy the Sarbosa criteria. The ST elevation here is more than 5 mm, which is discordant. There is concordant ST elevation here in lead 1. The predominant QRS is positive. There is ST elevation here satisfying all the three Sarbosa criteria. So this patient was having an acute MI with Sarbosa positive criteria. Let's look at the next patient. A 75-year-old male, known diabetic, hypertensive and coronary disease, presenting with palpitations. And this was the ECG. SVT, any more responses? So let's look at it from a stepwise point of view. SVT is definitely a genuine reply, but let's see if it is really SVT or it could be something else. The first thing, it's a tachycardia. It's a narrow complex tachycardia. It's a narrow complex tachycardia that is regular. Can you identify any clear-cut P waves? You do not definitely appreciate any P waves clearly. But if you look closer at one of the leads, that is V1, can you appreciate certain P wave type waves here, which tend to be appearing like sawtooth? So you have certain P waves which are appearing in the form of a sawtooth in lead V1. You have a tachycardia with narrow QRS complexes, and the RR interval is regular. What would this be? Sorry? Any more responses? Atrial flutter, that's right. This is an atrial flutter with a fixed conduction block, a 2:1 block. If you look at the ventricular rate, it is 150, exactly 150. So this ECG is an atrial flutter with a 2:1 block. Let's look at the next patient. A 22-year-old female with no past medical history, presents with recurrent episodes of palpitations, and we were lucky to capture one such episode when she was in the hospital. This was the ECG of that female. Any responses? Let's go stepwise. It's again a tachycardia. It's a narrow complex tachycardia. The RR intervals are regular. Can you appreciate any clear-cut P waves? No. So is this an atrial flutter again? It could be an SVT, but how can you be confident that it's an SVT and not a atrial flutter with a fixed block? Absolutely, there are no P waves. There are no specific P waves, but if you look keenly at lead V1, there is slight slurring at the terminal portion of the QRS, which is usually termed a pseudo S wave, which is nothing but actually a retrogradely conducted P wave. In an AVNRT, the atria are getting activated from impulses generating from the AV node. So there is retrograde activation of the atria. So the P wave appears after the QRS as a slight slurring of the terminal portion of the QRS. This is a pseudo S wave. So a narrow complex regular tachycardia with no clear-cut P waves and a slight pseudo S wave is more in favor of an AVNRT. Now, how do you differentiate atrial flutter from an AVNRT? I would like to tell you three clear points. First thing is the rate. The ventricular rate in an atrial flutter is usually in the range of 150, 180 or less than 180. But in an AVNRT, the ventricular rate is usually about 220 to 250. First is the rate. The second, as I told you, there is a slight pseudo S wave here. You should try to look at the RP interval. In an atrial flutter, the so-called P waves or the sawtooth P waves appear before the QRS complex, whereas in an SVT, that is an AVNRT, the P waves appear after the QRS complex. And if you look at the RP interval in an AVNRT is smaller than the PR interval, whereas in an atrial flutter, the PR interval will be longer than the RP interval. And the third is the clinical context. As I mentioned to you before, a 22-year-old female with recurrent episodes of palpitations goes more in favor of an SVT. Let's look at the next ECG. A 32-year-old female, known rheumatic heart disease, presents with generalized weakness and giddiness. This was her ECG. Very nice. Quick responses there. So, the answer is good. Let's look at the approach. It's a narrow complex tachycardia again, but here the RR intervals are irregular. And can you appreciate any clear-cut P wave? No. But in lead V1, you can definitely appreciate some coarse fibrillatory waves. So a narrow complex tachycardia, irregular RR intervals, fibrillatory waves in V1 goes towards the atrial fibrillation with fast ventricular rate. This patient with CRSG had mitral regurgitation with enlargement of left atrium leading to an atrial fibrillation with fast ventricular response. A 72-year-old male known COPD admitted to ICU with acute exacerbation. This was his ECG. Right, that is P pulmonale. Anything more? It's a tachycardia. Are the RR intervals regular or irregular? If you look at the RR intervals, they seem to be irregular. There is irregularity in the RR intervals. A narrow complex tachycardia with irregular RR intervals, and as somebody rightly said, it's a multifocal atrial tachycardia. And how can you say it's a multifocal atrial tachycardia and not an atrial fibrillation? Absolutely. If you look at closely, there are multiple morphologies of the P waves in the rhythm strip. So this favors a multifocal atrial tachycardia. Why are the P waves of varying morphology? Because of multiple foci in the atria, the impulses are rising from different parts of the atrium. So that leads to different complexes of the P wave. A 54-year-old male, non-ischemic heart disease, admitted with decompensated heart failure and suddenly becomes unresponsive in the ICU. A 12-lead ECG recorded at that time is like this. Absolutely. Any broad complex tachycardia until proven otherwise is a VT. And all the QRS complexes are of uniform morphology, so it's a monomorphic VT. But how can you definitively say it's a VT? What do you find here that is telling you it's a VT? All the concordance of the lead in all the precordial leads, there are no clear-cut P waves, there are slight signs of AV dissociation, the QRS duration is more than 160 milliseconds, your slight slurring of the S wave here, and the duration from the onset of QRS to the narrator of S wave is more than 120 milliseconds. All these points pointing towards the VT. Next patient, a 62-year-old male, non-CAD post-PTCA, presenting with symptoms of palpitations and pre-syncope. This was his ECG. Any inputs? This is again a broad complex tachycardia. Is it a VT? A broad complex regular tachycardia. Is it a VT? You're not sure. Any broad complex tachycardia, clinically in 95% of the situations, you only have three possibilities. One is a VT, the other is an SVT with a bundle branch block, the other is an SVT with an aberrant conduction pathway. If you can identify these three broad complex tachyarrhythmias, I think you'll do justice to at least 98% of your cases. So, how do you know whether a certain rhythm is VT or not? There are certain characteristic features which point towards a VT. Some of the features I would like to describe here are, the first thing is the QRS duration in a VT is usually more than 160 milliseconds. Then signs of AV dissociation point towards a VT. The axis is usually a northwest extreme axis in a VT. And if you have a LBBB or an RBBB type of morphology, then you have certain specific criteria for that as well. If you can see here, for an RBBB morphology ECG, if the right rabbit ear, that is the RSR- complex, if the right ear is taller than the left, it goes more in favor of a VT. For a left bundle branch complex, presence of QS or any Q wave in any of the leads points more towards a VT. Whereas if you're considering an SVT in a RBBB kind of morphology, there is an RSR- complex with the right ear, left ear taller than the left. And in LBB morphology, you find monophasic R waves in lead V6. There are many criteria, there are many algorithms to differentiate a VT from an SVT. I will present one algorithm that is pretty commonly followed, known as the Brugada algorithm. So there are 4 points in this. The first point is, no precordial lead has both R and S wave. That points towards a VT. If there is, go to the next point. The onset of R to the nadir of S wave is more than 100 milliseconds in any of the V1 to V6. Then it points towards a VT. If not, signs of AV dissociation clearly point towards a VT. If not, morphology criteria, as I explained before, whether it is suggestive of VT, no. If all the 4 points are not suggestive of VT, then it must likely be an SVT with either a bundle branch block or an aberrant conduction pathway. Some of the other two characteristic features in a VT are the presence of capture beats and a fusion beat. What's a capture beat? A capture beat occurs when the sinoatrial node transiently captures the ventricles in the midst of AV dissociation, producing a QRS complex of normal duration. If you look at it, all the QRS complexes are broad, and in between you have a normal looking QRS complex. The other characteristic feature of a VT is the presence of a fusion beat. That occurs when a sinus and ventricular beat coincide to produce a hybrid complex. This hybrid complex neither looks like a capture beat nor like a regular VT, and that's a hybrid complex. To appreciate the same in a 12-lead ECG, you can appreciate the capture beat and the fusion beats here in between a VT form of rhythm. So coming back to the previous ECG that I showed, this patient is having none of the characteristic features that you're supposed to find in a ventricular tachycardia. So most likely it's a SVT. But are there any more changes here that will reassure you that this is most likely an SVT? If you can observe here in the lateral leads, there are slight inversions here, which may be retrogradely conducted P waves that are appearing as P inversions after the QRS complex because of the retrograde activation. So all these features, that is a typical LBB morphology with absence of Q waves in V6, no positive Brugada criteria, and as in the clinical context, the patient had LBBB in the previous history. This is most likely an SVT with left bundle branch block. A 5-year-old boy presenting with episodes of sweating and pale skin associated with altered behavior. This was his ECG. It's a bit chaotic looking strip, but we'll try to decode it. It's a frank tachycardia. The rate is very high, almost close to 300. The QRS complexes are broad. Is this a VT? As we discussed before, we do not have any specific criteria that are satisfying the conditions for a VT. And if you have a closer look, you can see slight slurred upstroke to the QRS complexes here. A slurred upstroke to the QRS complexes, does it remind you of anything specific? Wonderful. So this patient was having an AVRT with WPW syndrome. A 32-year-old female post repair of ASD 10 years back, presenting with palpitations and giddiness. This was her ECG. Another chaotic looking strip. It's a broad complex tachycardia. Ventricular rate is pretty high, but the RR interval is it regular or irregular? A VT is usually regular. So what is it? Apart from an irregular RR interval, I would like you to focus on one more point, that is the varying amplitude of the QRS complexes with beat to beat. This suggests an aberrant conduction focus as well. So this patient was having an atrial fibrillation in the past, now has developed an SVT. This is an SVT with atrial fibrillation with a WPW. So summarizing the tachycardias, whenever you look at an ECG with tachycardia, there are maybe many approaches, each one may be comfortable with his own, but I would like to present one approach. Any tachycardia, first look at the QRS duration, narrow complex, broad complex. In a narrow complex tachycardia, rhythm is regular or irregular. If the rhythm is regular, there are only usually three possibilities. One is an atrial flutter with fixed conduction block, an AVNRT or an AVRT. The RR interval is irregular, then you have three possibilities. One is an atrial fibrillation or a multifocal atrial tachycardia or an atrial flutter with varying conduction block. Coming to broad complex tachycardias, anytime broad complex tachycardias usually has three main differentials, a VT or an SVT with aberrant conduction or an SVT with LBBB. This kind of algorithmic approach will help you decode the ECG, because usually when we tend to look at a tachyarrhythmic ECG, our mind tends to get blocked first for the first 30 seconds and then we start to open up. So this algorithmic approach may help simplify things for us. Moving from tachycardias, a 72-year-old male, known CKD on maintenance hemodialysis, presenting with giddiness, sweating and hypotension. This was his ECG. Any inputs? Absolutely. So actually a normal looking ECG, but if you notice, there are the QRS complex amplitudes are a little diminished in almost all the leads, and the QRS complex amplitude is varying from beat to beat, a phenomenon known as electrical alterance. In a patient with CKD on dialysis, points more towards a massive pericardial effusion, and given that he is in hypotension, most likely in tamponade as well. 43-year-old male presenting with sudden onset chest pain, diaphoresis, followed by syncope. Acute MI, anything more? Why did he have a syncope? There is a bradycardia, you have frank ST segment changes. This looks like a junctional rhythm. There is no correlation between the P waves and the QRS complexes. There is dissociation. So this is an inferior wall MI with a complete heart block, hence leading to syncope. An 80-year-old female, known asthmatic and hypothyroid, presenting with syncope. There are sinus pauses, followed by runs of tachycardia. more like junctional tachycardia. You have periods of sinus pauses, you have bradycardia, and then you have tachycardia, something like a tachybrady syndrome, secondary to a sick sinus. So this is a sick sinus syndrome manifesting with a tachybrady. The sick sinus could be due to various reasons, ischemic, electrolyte disturbances, and many other factors. A 65-year-old male, post-mitral valve replacement, presenting with syncope. Absolutely. It's a bradycardia. There's no clear-cut correlation between the P and QRS complexes. If you can appreciate lead 1, V1, there are coarse fibrillatory waves here. So this patient was most likely a non-atrial fibrillation on AV nodal blocking drugs, either a digoxin or a beta blocker, now presenting with toxicity. One thing that may point you towards a digoxin effect is the sagging ST segment and T inversion, usually observed in digoxin effect. So there are about 5 points which I'll be very happy if you can carry home. First thing is the importance and when to suspect to take a posterior ECG and an ECG with right-sided leads. How to differentiate a regular LBBB versus an acute ischemic process in a pre-existing LBBB. The approach to narrow complex tachycardias. How to differentiate an atrial flutter from an SVT, either a AVNRT or AVRT. And how to differentiate the possible broad complex tachycardias. If you can carry all these 5 points home, I think I'll be very happy. Thank you so much.
Very good presentation, Kiran.
Thank you, sir.
Actually, when patient is stable, all these things will come into the picture. If patient is unstable, first thing is to start the CPR and defibrillate. So that is most important for us. So any arrhythmia, you see whether patient is hemodynamically stable or not. If patient is unstable, then you attach the defibrillator and whether patient is cardioverted or not, that you see and cardiovert first. So next thing comes the differential diagnosis and what it is exactly, that to find out. Any questions?
Either everybody's understood everything or they've not understood anything.
Yeah, thank you. That was nice presentation.
Thank you, sir.
So I would like to add a few more points here with your permission.
Sure, please, welcome.
Yeah, I have seen almost all the things which are useful for our daily practice. Then few points I want to add here. First one, like few syndromes, as he told, one Brugada syndrome. Then few other syndromes like Whelan syndrome. So it is very, very important to diagnose Whelan syndrome because it is a pre-MI syndrome. So when you take ECG, when patient is having pain, it looks normal. When patient is not having pain, it shows STT changes. It means that it is Whelan syndrome. It is like a pre-MI syndrome. If you diagnose the Whelan syndrome at the earliest, you can save the patient. So that is Whelan syndrome. Then one more syndrome like a Kounis syndrome. Kounis syndrome. Kounis syndrome. See, I would like to add one more point here before telling about Kounis syndrome. Any ECG, if you want to read, first you take the history. Without taking the history, don't read an ECG because I will show an ECG which shows ST elevations V1 to V2, V3, V4, V5, V2, V3, VF. What you think? You think that it is MI. Before coming from to the diagnosis, concluding diagnosis, you take the history. That history might be different. Patient presented history of honeybee sting. So it leads to coronary vasospasm, secondary to inflammatory mediators. That also presents like MI on ECG. So that is Kounis syndrome. Okay. So there are many syndromes like that. Then as discussed by Kiran, digoxin toxicity, STT changes, ST sagging. It is called Salvador-Dali mustache. That is called Salvador-Dali mustache. Like Salvador mustache like appearance. Then sometimes like Yamaguchi syndrome. Previously asked for DNB people. Yamaguchi syndrome. On ECG it looks right ventricular hypertrophy. When you take the ECG, it looks like apical hypertrophy of left ventricle. Apical hypertrophy, that is Yamaguchi syndromes. So there are many syndromes like that, but be please Read an ECG properly after taking the history and consider each and every minute changes in ECGs. Okay? Thank you, one and all.
Thank you so much, sir, for the valuable additions. In order to felicitate our chairpersons, I would like to invite Dr. Yogesh and Dr. Ramakrishna. Dr. Yogesh to kindly felicitate Dr. Kiran Kumar Varma. Dr. Ramakrishna to kindly felicitate Dr. Shashidhar. We'll move on to our next talk. In order to chair the session, I would like to invite Dr. Prushti and Dr. Venkatraman Kola to chair the session, invite the speaker, and start with the talk.
So this topic is regarding the ETCO2 and ICP monitoring. So our speaker is Dr. Prasad. Divi Prasad, he will be talking regarding the ETCO2 waveforms and ICP monitoring. Yeah.
Good
Dr.
morning.
Prasad, please.
Am I audible? So we will see now. Okay. So here, good morning everyone. So today we are going to discuss some two topics, which is ETCO2 waveforms and ICP waveforms. So most of you must have used ETCO2 in your PG or in the now when they're working in ICU. Anyone working in ICU?
Sorry to interrupt you, Prasad. I would like to welcome another chairperson, Dr. G. Shashidhar Reddy, consultant physician at Yashoda Hospitals, Malakpet, to chair the session.
Okay. So how many of you have used ETCO2 in your in your PG or in an ICU? So it is easy for me to go through. So can you? So first we'll start with an MCQ. So with this we'll start. What are the uses of ETCO2 in an ICU? The value of ETCO2 associated with poor ROSC and survival after 20 minutes of resuscitation is. Can anyone answer this? Yeah. So this is 10 mmHg. So there are potential application in ICU. There are which is monitoring of CPR quality as per the ACLS 2020 update. So we can use an arterial blood pressure or an ETCO2 to monitor and optimize CPR quality. So we should target at least 10 mmHg and ideally it should be 20. So what are the other uses of ETCO2 in an ICU? So one is conformation of tracheal tube when you intubate, and second one is when the tracheostomy tube, the patency, when it's blocked, you can assess, and monitoring of adequacy of ventilatory support, which is hyperventilating or hypoventilating. Next is use of percutaneous tracheostomy placement. Whenever you place a tracheostomy, you will be in a fear, so it is in the position or not. So if you have in ETCOT, immediately you can see the waveform and you can confirm it. And sometimes you will be waiting for the X-ray to confirm the position. So next is monitoring the patient with raised ICP in neuro ICUs, where the CO2 increase in CO2 can cause decrease in ICP. And for monitoring of bronchospasm, whenever the asthmatic patient, you give a treatment. So if there is a change in the waveform, so it can confirm that is bronchospasm has relieved. And also estimation of cardiac output, where sometimes you use like a PETCO2 to PSCO2 difference. So to assess for cardiac output monitoring. So what is this waveform? No, it's a normal ETCO2. So it's a time capnogram where the CO2 concentration is plotted against time. So when you have any time capnogram, we have an expiratory part and the inspiratory part. The expiratory part we have divided into three phases. The phase one is where the air comes from the airways, where the CO2 will not be any CO2, though it will be flat. So once the air from the alveoli mixes with the airway gases, though there will be sudden rise in the phase 2, which carries from the phase 3, there will be purely alveolar gases, where there will be positive slope, and at the end of the phase 3 will have the end-tidal carbon dioxide. Then inspiratory phase starts. So in this graph we have two angles, which is alpha and beta. Normally alpha is 100 to 110 and beta is 90 degrees. These are of no use, but in sometimes you can see the changes in the alpha and beta angles. So can you tell me, anyone tell what is this? So this is a time capnogram where there is a sudden surge or peak at the end of phase 3, which is phase 4, most commonly seen in obese and pregnancy patients. So due to differential emptying of the alveoli. So towards the end of the expiration, there will be sudden decrease in flow, where when the alveoli from the lower side will be emptying, so which have higher CO2 concentration, which leads to sudden surge, which is called phase 4. Can you tell what is this graph? No, this is a volume capnogram. This is concentration of carbon dioxide plotted against volume. So in volume capnogram, we have only expiratory part. Sometimes we can draw inspiratory part, but most of the times we'll see an expiratory part, which has phase 1, phase 2, phase 3 as similar to the time capnogram. So phase 1 from the airways, gas from the airways, phase 2 from mixing of alveolar and airway gases, and phase 3 is purely alveolar gases. So one volume capnogram is equal to one tidal volume. So the while you can see so the air, this is the volume above this line is dead space air volume, and below this is the alveolar volume. So can someone tell what is A, B, C, D, E? So A is anatomical dead space and B is alveolar, C is effective alveolar ventilation, and the end tidal carbon dioxide, and the red line above is the arterial CO2. What is this? This is a 10 capnogram, which is also a time capnogram measured at a slower rate, mostly 0.7 seconds per 0.7 mm per second. So, which can give the values average pH CO2 value, pH end tidal CO2 values over time. So now we will come to a clinical scenario. A 62-year-old male who is intubated and being shifted from emergency after the emergency procedure for emergency procedure after adequate resuscitation. So you have intubated him and you have confirmed the ETCO2 waveform, and which the value is showing 42. Plus the patient is sedated and paralyzed, vitals are normal. So during shifting you have seen this kind of waveform. What is it? No. Initially you have a normal ETCO2 waveform confirmed and the value is also there. Yeah. So there are different these conditions which can explain this kind of waveform. One is when you're doing intubation, it can be an esophageal intubation. Then ventilator disconnections, airway obstruction, and capnography. Even the capnography must have disconnected. And water droplet contaminating the capnography module, apnea, which is rare in this patient, and cardiac arrest also. One more clinical scenario, a 25-year-old male is asthmatic and not compliant with the medication. While playing his basketball, he became suddenly short of breath. He came to the hospital with severe respiratory distress, and first you have tried an NIV trial which failed, the respiratory distress has not come down, so you have intubated him. So after intubation, you have connected an ETCO2 monitor. You can see this kind of waveform. What is this? Yeah, this is a sawtooth or a shark fin waveform, where in this case there is no alpha angle. Before the expiration, the inspiration has started. So the treatment part we have discussed already. So this one, most of you have seen this. Yeah, this is a Curer cleft. So the answer might be elimination of neuromuscular blockers. So next case scenario, a 5'7" middle-aged man with medical history just arrived with unknown medical history, just arrived to ICU for after an emergency expiratory laparotomy. The patient was intubated in the emergency department after giving hypnotic and muscle relaxant. Though after coming here, you have set on ventilator settings and you connected a ETCO2 waveform. So the waveform looks like this. So in this waveform, there are two peaks in the phase 3. So most commonly seen in where the differential emptying of the two lungs, maybe endobronchial intubation, where you have not isolated fully the left lung. But the partial, there is partially you have the tube is inside the right main bronchus, and left also there is emptying, but delayed emptying. So other conditions where you can see this kind of a sampling leak, lung transplant, where different emptying is there, and severe kyphoscoliosis. So what is this graph? This is a time capnogram where you have prolonged phase, inspiratory and expiratory phase. This most commonly seen in fixed obstruction. This waveform, can anyone answer this waveform? Yeah, cardiac oscillations most commonly seen in cardiomegaly. This one? Yeah, this is maybe during CPR when there are shifts when someone takes over the compressions in between, or it can be an ROSC. This one, you can see in this time capnogram, you have seen two kinds of waveforms with different shapes, mostly spontaneous breathing. So this is a time capnogram. This where you should by seeing this time capnogram, you should not do one thing which is mentioned here. What is it? No, first we'll see what is this is a time capnogram. The baseline is elevated. Baseline is elevated and there is a continuous rise in CO2. Most commonly seen in rebreathing. So what we have to do, we should not do here. Yes, you should not increase the respiratory rate. So you should give time for the expiration. So this is one more time calculagram. So there is baseline is normal and there is continuous increase in waveform size. So all the following will have this kind of capnogram except this is the continuation of the previous question. This is rebreathing of CO2. Other conditions where if you decrease the respiratory rate, then CO2 will rise, but there will not be change in the baseline, and decrease in tidal volume and malignant hyperthermia where CO2 production is increased. This one, this is a time capnogram where there is a gradual decrease in size of the CO2 waveform seen in hyperventilation. Next, we will see volume capnogram. So, a adult female patient presents with respiratory rate of 35 breaths per minute with swollen coughs. She is intubated due to respiratory distress. What does the volume capnogram indicate? By the history, you can be knowing what is happening here. Yeah, pulmonary embolism. So, can you explain what is happening to the waveform? So, there is increase in dead space, and when you draw a graph, this is when you draw a line PaCO2, arterial CO2, there is increase in gap. So in pulmonary embolism, due to this dead space, there is shift of the graph towards the right, and also due to decrease in cardiac output or due to decrease in perfusion to the lung, there is a gap in pH, end-tidal carbon dioxide and arterial carbon. This one. First, we'll see what happens to different phases in different conditions. So, phase 1 is anatomical dead space. Phase 2 depends on perfusion and also lung mechanics, and phase 3 purely on lung mechanics. So, here the phase 2 is also decrease, they have a decreased slope, and phase 3 is increased, most commonly seen in COPD, and there is a clue where the EtCO2 is raised. This one here, there is the phase 1, phase 2 and phase 3, there is no change in the slope, only there is a decrease in PETCO2 due to decrease in perfusion, most commonly due to shock. So a 62-year-old male diabetic patient admitted with lower limb cellulitis, he was shifted to ICU. After NIV trial, he have intubated and PF ratio is around 160. Due to worsening hypo, the patient was intubated. So when you see the volume capnograph, this type of volume capnograph on the ventilator. So there is this there is deranged lung mechanics, and also decrease the perfusion abnormalities also is there. So after you recruited the patient, the waveform shifted to the right, where the perfusion abnormalities and the ventilator parts has been resolved. So next we will see the ICP waveforms. So we'll start with a clinical scenario. A 30-year-old female was admitted to neurosurgery with Fisher grade 3 aneurysmal SAH. An EVD was inserted by neurosurgery team due to presence of hydrocephalus and brain edema. The waveform depicted is this one. What is this waveform? This is an ICP waveform. So in the ICP waveform, the different harmonics are being overlapped and they are separated by the frequency. One is the arterial pulse. The frequency, the base frequency of this will be the arterial pulse, and it will be overlapped by the respiratory wave component. So we can see this kind of waveform. So later on, there is one more harmonic, one more component, which is the slow waves. When you see the trend, the slow waves in be seen. So this is the waveform, which is first initially the height will be depends on arterial pulse and the rate will be depend on arterial pulse, and the respiratory cycle where we see there is a sine wave appearance. So can anyone name the ABC? ABC. Yeah, P1, P2, P3. So can you continue with when the P wave occurs? Okay. So P1 is a percussion wave where the arterial pulse is transmitted to the choroid plexus into the CSF, where the EVD from the EVD to the transducer. The P2 is the tidal wave, represents the cerebral compliance, where the arterial pulse will be bouncing back due to the springy parenchyma. Phase 3 is a dichrotic wave due to closure of the aortic valve. So with this, can we answer this question? A 37-year-old male is assaulted and sustains a severe traumatic brain injury. He undergoes a craniotomy for EDH. The neurosurgical team inserted an EVD for ICP monitoring. Regarding ICP monitoring, pick the wrong statement. Yeah. So next we will see how the waveform changes in different conditions. So this is the individual component of the waveform where there is increase in height of the waveform, which is most commonly seen in intracranial pressure, where initially the volume ICP, the pressure volume curve, where there is no much changes. There is a compensatory reserve, good compensatory reserve, where the increase in volume will not change any kind of ICP. There is no major change in ICP. Once the waveform reaches here, this compensatory reserve has been reduced. So there will be a decrease in cerebral perfusion. So automatically the vasodilatation will occur, which leads to the increase in amplitude of the waveform. Here, what you can see. Here, this is also an ICP waveform where the sine wave pattern, the sine wave pattern has been slowly becoming a flat due to increase in ICP. Here, there is a peak P1 wave, which is most commonly seen due to rise in systolic blood pressure. So can anyone say what is happening here? There is a flattening of P1. So most commonly seen due to decreased cerebral perfusion. This wave shows there is a prominent P2 where the P1 is less than the P2. Usually the P1 will be more than P2. Here there is a P2 is more than P1. This is mostly common seen due to decreased cerebral compliance. And towards the end, where the ICP has raised more, there will be rounding of the waveform where the P1 and P3 are diminished and the tidal wave will be more prominent. This is the sequence where initially the ICP is very less. The P1 will be more than P2. Gradually, when the ICP rises, the P2 will dominate and the P1 and P3 will diminish. Here, the P2 and P3 are diminished due to hyperventilation. So what are Lundberg waves? Will be more of confusion. So Lundberg waves are nothing but first it was seen by Lundberg, and he has monitored almost 400 patients with the continuous monitoring almost a week on these patients. So what the equipment which has used, the paper speed is around 12 inches per hour. So he could see the waveforms with this kind of waveforms where the trend, how the waveform changes over time. So this waveform does not refer to the changes in individual waveform. These are the graphical representation of ICP values plotted over time. There are three kinds like Lundberg A waves, B waves and C waves. The Lundberg waves has higher amplitude, more around 50 to 100, and for a prolonged time, duration of 5 to 20 minutes. Most commonly seen in where the compensatory reserve has been lost and towards the end of raised ICP. So what happens here is whenever the ICP rises due to any reason like a tumor or blood or any component hydrocephalus, the CPP will reduce. The perfusion will be compromised, which leads to the autoregulation where the cerebral vasodilation occur. The more blood will be flow will be increased. Again, the blood volume will increase. Again, the ICP rises. This cycle continues till there is a Cushing response where the mean arterial pressure will rise and there is a sudden drop in the ICP waveform. See, there is the sudden drop. So when you see the Cushing response, that means that is the end. It means there is no compensatory reserve in the cranium. So these are B waves where the amplitude will be around 20 to 50, less than 50, and the frequency will be more, 0.5 to 2 waves per minute, and it lasts for 1 to 5 minutes. These B waveforms carries the information that brainstem function is intact and pressure volume compensation is there. So most commonly these occurs in the steep part of the curve, and there is a cerebral autoregulation. These are the C waves where these are physiological and more frequent and with less amplitude seen in the healthy individuals. So next we'll come with a clinical scenario. A 22-year-old male has an external EVD placed for ICP monitoring following a TBI. So he continues to have poor neurological examination, and there are episodes at time where the elevation is above 22 for lasting for 10 to 20 minutes. So other vital signs have not been changed. So this is the waveform what you see. What is this waveform? So this is a Lundberg A wave. So next we'll see the trends, how the ICP waveform changes over time. So in this graph, what you see? There is a normal ICP plotted against the CPP. There is no major fluctuations. So this is a normal ICP waveform, stable ICP. Here what you see? There is an elevated ICP with no major fluctuations in CPP or mean arterial pressure. Most commonly, this is raised ICP with stable pressure. What you can see here, what is the question mark indicates? There is a sudden rise in ICP about 20, which almost touches around 60. Mostly these are Lundberg waves, which I have told you before. So whenever the Lundberg waves occurs, there is decreased compensatory reserve. The CPP decreases, automatically the cerebral vasodilation and increase in ICP. This cycle continues. At the end, this RAP, what is RAP is a correlation coefficient to the amplitude and the pressure. So we'll see what is it. So initially, when the ICP is minimal, there is a good compensatory reserve. The coefficient is 0. Once the compensatory reserve is decreasing, it becomes 1 and it becomes negative. Here, whenever the A waves are occurring, this is becoming negative. So there is decrease in compensatory reserve. Here, what you can see is, this is difficult. So towards the end of the waveform, there is increase in ICP almost above 100. So the mean arterial pressure suddenly dropped, and also the amplitude also is dropped. So this is a refractory ICP where without intervention the patient will die. So we have seen different waveforms. Now we'll see what are the indications of the ICP. So which of the following is indication for ICP? Following are the indications. You pick the wrong statement. This is the wrong. Actually, these are correct. One is wrong. Yeah, one. So as per the Brain Trauma Foundation, the indication is level 2B, and there are one or two studies where there is no much major changes if you monitor the ICP or not. The outcome will not be different. So the inclusion criteria are whenever the GCS, this severe TBI, you can say severe TBI with abnormal CT, or severe TBI with normal CT when you have two or more of the following conditions like age greater than 40, unilateral bilateral motor posturing, or systolic pulse rate less than 90. Thank you.
Any questions from audience? I have one question. Prasad. Are we monitoring ETCO2 in all cases, or any specific indications which we should see in our ICU routinely?
Like whenever there is raised ICP is there, or whenever you think there is a bronchospasm, severe bronchospasm, or whenever the procedures like tracheostomy. So if you want to confirm, you can use it.
Routinely we don't.
Routinely we are not using, sir. We can use.
Yeah, I think in all cases of ventilation, I think this needs an extra module in all our monitors, so it's not available in all, so that's why it's missing. But it is one of the mandatory requisite to actually monitor ETCO2 in all anesthetized patients. That's by standard recommendation. But in intensive care, we take it as a case basis, individualizing each case. I think one of the new addition, as you rightly pointed out in the first part, all of you need to understand the quality of CPR. They are now emphasizing a lot on that. See, any of you, if you are doing a high quality CPR, to know the perfusion, the best way is to look at your ETCO2 and target around at least a 10 and maybe 20 if possible. The other common indication, as you rightly pointed out, is endotracheal position, whether you are after intubation, whether it is in place or not. The third indication where I will use it is in patients who are prone or who are on very high ARDS ventilation and I am accepting a hypercapnic state, sometime where we say permissive hypercapnia. So I wanted to monitor, target them, and those conditions also we titrate. We know, okay, we are dealing with this CO2 and still we are accepting it in those ways. I think other than that, in routine other cases with a normal ABZ, with a normal other vitals, we sometimes ignore. And another point out is ICP. Along with ICP, when we have a case of a neurosurgical or a neurotrauma, probably targeting a normocapnia. We were all talking about hyperventilating, hypocapnic ventilation causing a drop in ICP is no more a standard. We all talk about normocapnia, and probably in extreme condition where all other measures of ICP has failed, you probably give a brief period of hyperventilation to till you get an alternative measure to control it. I think before we announce, I wanted to have two announcements here. I think the best of the whole symposium part will come at the end. When we were actually discussing about the symposium, we were talking about the graphs and curves. And suddenly I felt in ECG when I will be asked or I ask my student to review, most of these things which you listen till now, you come across some or the other part of your regular clinical rounds. The graphs or the curves which we don't understand at all, which looks like a very puzzly, jumbly lines, they are all different streaks of lines. You always don't understand what is it. So EEG. So many of us feel ki EEG is not our cup of tea. And we wait for a technician who probably has 20 years junior to you, only studied for 2 years and has been working for you for 6 months. And you wait for him to come and say that there are some spikes, it looks like some encephalopathy, there is an unspecific things here and there. You just can't just understand, you are a layman there. Like any of your relative asking about ECG to you. So EEG is one component. The other things which is a very common component you in GBS. Many of you will face a case of GBS and sometimes myasthenia in your case presentations. Okay. And when you ask for a nerve conduction study, many of our examiners expect you to know what is it. What you look for from F waves and other alternative wave, what are the different components of types of your GBS which are dealing with. So these we will probably are reserving that Dr. Prusti will deal with that and explore us and make us expert in reading this neuroimaging and probably giving that extra edge. And end of this, the further best part of the whole story is we will take you through a quiz session which will cover all the cases or all the discussions which we have done for the last 2 hours or 3, and many of these will be your clinical scenarios in your exam. And they have been mastered by 2 master quizzes. One of them will be Dr. Niranjan and Deepak. Both of them are consultants now in Apollo Group of Hospitals. So they will make sure that before you go, at least you go through those all common basic regular graphs and curves which comes in your exam. So don't miss them.
Thank you, sir. I would like the chairpersons to felicitate our speaker, Dr. Prasad. Now I request Dr. Madhusudan Jaju to felicitate our chairperson, Dr. G. Shashidhar Reddy. I request Dr. Bharat Kumar to felicitate our chairperson, Dr. Venkatraman Kola. Thank you, sir. Amidst this academic feast, we have also arranged a lunch feast as well. But before we break for lunch, there are 2 small things. First thing will be a small announcement by Dr. Shivakumar, Consultant Critical Care at AIG. And after that, we are going to have a group photo with all the faculty and delegates. Following the group photo, we break for lunch. Thank you.
Thank you very much. A very good afternoon to one and all. A very excellent CME, theme-oriented CME has been conducted by the Yashoda Group of Hospitals. And again, in pursuit of academic excellence by the ISCCM Hyderabad chapter, along with the Department of Critical Care Medicine, AIG Hospitals and ISCCM Hyderabad chapter, we are organizing a Critical Care Medicine CME on Critical Care Gastroenterology and Hepatology next week at 10th of October, starts at 9 o'clock. And it's a free CME. All of you, I request all of you to come over there and you would have the real academic excellence in critical care, gastroenterology and hepatology. So with that, thank you very much for the organizers and please take over.
Thank you, sir. We look forward to that as well. Now I request all the students, faculty members to approach the dais for a group photograph.
We have 30 minutes assigned for lunch. Request you all to finish it within 30 minutes and be back.
Bro, you go. Take short break and come back.
కింద పట్టండి ఓకేనా రాలేదు 5
Thank you. सर आपका क्लास कब है?
అట్లనే ఉండండి.
इधर होकर आने के बाद थोड़ा सेटिंग करेंगे इधर होगा इधर से
इसको थोड़ा फ्रंट ले लिए तो कोई जाने आने के लिए पीछे से कर सकते हैं।
थोड़ा इधर भी
ये पीछे से कोई जाना आना कर सकते हैं।
हाँ सर
ठीक है ये इसको एक काम करना हाँ सही कर दो रोड तो बंद है ना नहीं तो ट्रेन कहाँ से निकालते हो अभी तो कहीं लेके नहीं जा सकते ना अभी साइड
बाद में
रोड क्लोज है ना ये बंद है उधर पे खड़े वाला नहीं है गैस सिलेंडर
Hello, good afternoon. I would request everyone to gather in the next 10 minutes so that we can proceed with our next presentation.
Anna, so you vegetarian or non-veg? So I'll keep separate this non-veg. So no, so see, so what 10 more plates I'm adding. Just for you.
I request all the delegates to assemble in the auditorium so that we can start the next session. I request all the students to assemble in the auditorium so that we can start our next talk. Welcome back everyone from lunch. I hope you enjoyed it. Our last talk for the day, I would like to invite the chairpersons, Dr. Bharat Kumar, he is a consultant neurophysician at Yashoda Hospitals, Malakpet, and Dr. Karthik Munta, senior consultant intensivist at Yashoda Hospital, Somajiguda. Thank you so much, sir. I'd like you to chair the session and also invite the speaker as well.
Now I invite Dr. Saroj Pusti, is a HOD critical care medicine at Yashoda Hospital, Malakpet. This is going to be a wonderful talk. That is neurocritical care, which he is dealing with EEG and NCS, ENMG. This is going to be a very good session for all of you.
Yep. Good afternoon, all. Thank you, Dr. Bharat and Dr. Karthik, for a nice introduction. So, I think Dr. Venkat just now told that we are seeing doing the EEGs and we are doing the nerve conduction studies. We are doing all the things, but we don't look at the findings of the studies. What we do is just directly we are seeing the reports, but we don't look at the findings. So we need some fundamentals, even though as a critical care physician, information and early information to the primary neurophysicians. So at least help us for early detection of some of the things and early management. So there is a lot of difference, and at the same time, we need to know the some fundamentals about the things when we are dealing with the patients. So my talk is related to EEG, nerve conduction studies, RNS and EMG, some basic things and case scenario based will deal. So let us go for first EEG. So when you want to go for EEG or how a EEG is helpful to us. Usually you go for EEGs. So a patient comes to you with a seizure or in a postictal state, or you want to know the onset of the seizure, localize the seizure, or management of status epilepticus, or a toxic encephalopathies or metabolic encephalopathies, or different encephalopathic patients to assess the degree of encephalopathy. Comatose patients, particularly in the ICU, is a very important component of the category of patients what we deal with, because if a patient is having a seizure, that's at least you can, it will be witnessed. If patient is not having seizure, then it is not witnessed. You cannot recognize. So that point of time, it's difficult to detect unless you do an EEG. And prognostication after an cardiac arrest, it will be helpful. And delayed ischemic events after a particularly subarachnoid hemorrhage or traumatic brain injury cases or a brain death determination, it may be helpful. So these situations we need to identify where we need to do and how it is, what is the diagnosis for that. Let us come to a case scenario. A 58 years old woman was hospitalized due to bronchopneumonia with comorbid CKD, diabetes and coronary artery disease, and she was treated with cefepime 4 grams per day for bronchopneumonia. On the 8th day, patient was less responsive and was unable to speak, but there was no seizure. No other neurological signs were observed. Lab investigations were high creatinine and high urea, blood urea nitrogen. MRI was normal. So that point of time, EEG was done. By looking at EEG, what is your impression? So when we don't know anything, whether it is a normal EEG or abnormal EEG, where is the source focus or localize the focus of seizure, and what is happening to the patient, and how to report this case. So these questions comes to our brain. So how to look at? So for that we need to know some fundamentals regarding the EEG. And regarding this case, again I'll discuss with you. After the fundamentals, you will only give the answer. So let us come to so regarding the EEG, how it is being conducted, I'll not go to the deep because only fundamentals which is useful for us. So basically we use 21 leads for monitoring, recording the EEG. Among the 21 leads, 9 leads on the left side, 9 leads on the right side, and it is being divided. The namings are different, and if you look at all odd numbers are on the left side, and all even numbers are on the right side. So and different like FP means frontal pole, F means frontal, and this front F7 is frontotemporal, C3 is central, temporal, auricular, P3 is parietal, that is posterior temporal, T5 is posterior temporal, and O1 is occipital. So like that, right side is also there. G is not a lead, it is for a comparison, it's for a origin point, ground. For that reason, it is considered as a center point. And FZ for mid frontal, CZ for central, midline, and mid posterior, PZ is for mid posterior. So total 21 leads are necessary to go for a 10-20 system. So what do you mean by 10-20 system? So 10-20 system is nothing but a circumference of the half of the hemisphere is being divided into 10-20 system, because it is considered half of the hemisphere. If you look at half of the hemisphere is total 100%. If you take the between the center point to frontal pole is 10%, and other gaps are 20% each. Like that, it is 80%. Again, here it is 10%. So total is 100%. So for that reason, 10% and 20%, it is called as a 10-20 system. So after recording the EEG, after recording of the EEG, what we look for? Usually we look for normal. What are the normal waveforms of EEG? So definitely you know that there are four wave patterns, which are alpha, beta, theta, and delta waves. But how they look like and what are their origin, and usually you see where, in which conditions you see, that we need to know. So normally you see, look at mostly alpha waves, and they are being divided into as per their frequency. So frequency is that hertz, it is per second, the number of waves per second. So that is frequency. So beta waves are highest frequency, like around 14 to 30 frequency. Alpha waves are around 8 to 13 frequency. Theta waves are around 4 to 7. The lowest frequency is delta, less than 3.5 frequency. And when you see the beta waves, usually a person is awake and mental activity with eyes open. Whereas alpha waves are seeing a person is awake with eyes closed. Eyes closed you will see, and during the resting period you will see. And theta waves during the sleeping time you will see, and and delta waves you will see usually during the deep sleep. So usually seen in the children, it's a very limited time you will see the delta waves, but otherwise during the sleeping time you will see the theta waves. So a highly awake person and with open eyes, mentally active, you will see the beta waves. So these are the type of normal waves. Now coming to the areas when you are looking at an EEG, so if you look at suppose it's very easy, I think. If you look at these odd numbers, frontal, central, parietal, occipital, if you see these are all odd numbers. So left, so it is called left parasagittal, frontal, central, parietal, occipital. Now 4, 4, 4, 2, these are all even numbers. Frontal, central, parietal, occipital, right parasagittal, and frontal, temporal, temporal, occipital, left temporal, right temporal. So it is just to have an idea the localize or origin of a focal seizure, you can know. And if you know the areas, at least you can tell by definition to when you report a case of seizure. So from where it is being different manifestations are there. So at least you can describe what is the type of seizure. Okay. Now coming to alpha waves, it looks like this. I put the red mark here. So the alpha waves are looking like this in a EEG, and usually seen in the occipital region. And its frequency already we have discussed it between 7 to 14 frequency hertz per second. And these waves, whatever you are seeing, is when a person eyes opens. See, for example, these are alpha waves. You see awake person with eyes closed. When a person is awake, eye open, then again there will be this eye opening sign and followed by beta waves. So that changes. It will change. So these are regarding the alpha waves. Beta waves usually seen in the frontal region, but it can be seen in other areas too. And a person is highly active, it can see all leads. You can see all the leads actually. And the frequency is 14 to 30 hertz. And coming to theta and delta waves, as we discussed, the theta are a little more amplitude. They come around more than 50 amplitude. This delta waves are also more than 50 amplitude, but frequency is less. And this delta waves less than 3.5. These are also less than 3.5, and it can be seen anywhere in all leads of 2, but usually during the sleeping time. And delta waves are usually children deep sleep time, and sometimes it may be the delta waves considered as a pathological depending on the situation, clinical scenario. Okay. Now coming to different terminologies, because these are required for reporting a case of EEG. When you how to report a EEG, you see all the findings and report. So the name itself suggestive. For example, a monophagic wave, diphagic wave, a triphagic wave, polyphagic wave, a complex wave. So that name itself signifies that how it is. because the wave baseline, you look at the baseline of the EEG, whether it is one side of the baseline or both side of the baseline. So definitely that gives a definition. And but here we need to know regarding the triphasic wave. The triphasic wave has three components alternating about the baseline, whereas first and third component to the same direction. So that is known as triphasic wave, and polyphasic wave with the different directions. And complex is a sequence of two or more waves having a characteristic form. And transient, when you will say transient, the wave, isolated wave or complex, which is lasts less than 20 milliseconds. So that is a transient wave. Spike. So spike is a separate special wave. It's distinguished from background activity with a pointed peak. The peak will be pointed, and the duration is around 20 to 70 milliseconds. And the sharp wave also similar, but the duration here is 70 to 200 milliseconds. Difference is, this is also pointed peak, but the difference is only duration. Slow wave is a slow duration, longer duration with more than 200 milliseconds. Okay. So and another terminology from the origin, location. So it is focal, depending on the if one electric field or one electrode it is, or surrounding area. Hemispheric is one side of the hemisphere. One side of the hemisphere, it may be anterior to the coronal line or posterior to the coronal line. Bilateral is both side of the sagittal line, but either anterior or a posterior. So that is bilateral. And coming to generalized, the distribution of the waves on both side of the hemisphere, both side of the sagittal line, and both anterior and posterior to the coronal line. The coronal line also will be there. So then we call it as a generalized seizure distribution. Now coming to terminologies, some other these terminologies what we report. So how to report? For example, electrographic seizure, a rhythmic discharge or a spike or wave pattern with a definite evolution, frequency, location or morphology lasting at least 10 seconds. So 10 seconds if it is lasting, we can call as a electrographic seizure. Periodic epileptiform discharges. These terminologies looks new to us. Even I remember we can, when going through the article also it is new to us, but still we need to remember and we need to know, because when you identify the EEG, these things are necessary. And periodic epileptiform discharges are repetitive sharp waves or spikes and sharply contoured. So these are called as periodic epileptiform discharges. They occur usually regular intervals without clear evolution in frequency or location. Periodic lateralized epileptiform discharges consistently lateralized to lateralized kind of periodic epileptiform discharges. Generalized PED, already you have defined generalized. How, when we can call it as generalized. Bilateral, same thing we have defined. Triphasic waves, already we have defined. Another terminology is FIDA. FIDA is frontal intermittent rhythmic delta activity. So these are moderate to high voltage monomorphic or sinusoidal 1 to 3 Hz activity seen bilaterally, maximal in the antral leads and without any evolution. So we will come with examples. So these are how a spike wave looks, how and sharp wave looks, and how a triphasic wave looks, how a pled looks, how a eye blink looks, and how a background some artifacts also will be there, we need to identify. Okay. Now coming to a same case scenario. So what we saw. So what is your impression now? So we understood some basic fundamentals. Now what is your impression here? What are the abnormal waves here? So abnormal waves are, these are different, the spikes are there, sharp waves are there, combined, and distribution is generalized. You see almost all leads are affected, all leads is recorded. These are left side, right side, left side, right side, and all regions are recorded. And it is continuous for 10 seconds complete. It's because the ECG full screen is, the one paper is around 10 seconds. So what does it mean? And the same patient, when we have given the diazepam, patient was given the diazepam, the seizure that patient had stopped because after that patient recovered and so consciousness improved and patient became alert. Things have improved. So this patient did not have a seizure. This patient had only presented with altered behavior, not able to speak properly, incoherent. And when EEG was done, it was showing like this. Patient was on cefepime. So cefepime, an important drug which can lower the threshold for a seizure. And one of the important component is this patient had a CKD, underlying CKD with high uremia. Uremia means you might have observed that patient had a BUN and creatinine was very high. So underlying uremia with the drug induced, cefepime was the drug culprit, which was the reason for precipitation for this type of neurological behavior. So EEG was recording like a multiple spikes, generalized spikes and sharp waves in all leads. It means that it is a definitely non-convulsive status. Non-convulsive means patient did not have a convulsion and status. So non-convulsive status. Okay. Next come to PIDA. It's frontal intermittent rhythmic delta activity. You see the delta waves here. So these delta waves are for around 4 to 5 seconds here, distribution, and it is mostly usually seen in the frontal region. So for that reason, it is named as a frontal intermittent rhythm. Usually it is seen in different encephalopathies, means like either a metabolic encephalopathy or a toxic encephalopathy or any type of encephalopathies. Patient may manifest as a seizure if something other precipitating factor is there, but that is a significant to say. We can say that patient is having encephalopathy with EEG recording of FIDA. TDA, if temporal distribution is there, like temporal intermittent rhythmic delta activity, same delta activity, only one side of the left temporal region. If you look at here, this is the left side, left temporal region. So suggestive of usually a focal seizure. Okay. Now coming to another scenario, a 15 years old girl presented with severe headache with loss of consciousness without focal neurological deficit when CT brain was done, showed a diffuse subarachnoid hemorrhage and secondary to ruptured thalamic AV malformation. And that time EEG was done for the patient. What is its impression? Yes, very good. Delta waves. So delta waves, and that to seen in all leads. Usually you look at means when for a only for a drowse means encephalopathy patients you look at means only frontal leads. But whereas you are seeing in whole of the brain means almost all leads you are seeing, it is we call it as generalized. That too polyphagic means polymorphic, not synchronized, bilaterally not synchronized also. So that is suggestive of a diffuse cerebral edema, because already patient clinical. Now we have to correlate clinically, because this patient had a severe subarachnoid hemorrhage and with due to AV malformation. So it is suggestive of diffuse cerebral edema. So now coming to another scenario, a 45 years male CKD on maintenance hemodialysis came to hospital with one episode of seizure and post-ictal state without any focal neurological deficit, found to have a high urea and creatinine, missed dialysis 2 times. EEG was done. EEG is showing like this. What is the impression here? Delta wave, same. And that to which leads? If you look at, yeah, frontal central area is also there, and here also frontal means right frontal, yes, left frontal. So almost except occipital areas, but all other regions are there. And this patient is CKD patient. So definitely it is a uremic encephalopathy. So where you see usually metabolic disturbances, for example, uremia or severe hyperglycemia, or commonly in combination with a patient is having a cerebrovascular insufficiency. Okay. Now coming to another scenario, a 33 years female consumed herbal substance, developed severe hepatitis. Why we are discussing these cases? Because these are the cases we see in the ICU, different varieties of presentations. So if you do an EEG and record the things, we may this type of findings only will see. So it may be easy for us to identify the things, situations, and you can inform and to the concerned neurophysician for as early as the treatment or something intervention may be required for the patient actually. So a 33 years female consumed herbal substance, developed severe hepatitis, came to hospital for vomiting and pain abdomen, developed altered sensorium with severe coagulopathy, 2 episodes of seizure, and required ventilator support. EEG is showing like this. What are these waves? Very good, triphasic waves. Okay, why? Because it has a first and third component to the same direction. So triphasic waves seen in the this frontal. This is frontal right side, left side, and again here also right side, left side. So almost all areas it is seen. So what is its impression? Usually triphasic waves seen in the result of toxic, metabolic or hypoxic ischemic encephalopathy or a prion disease, and it can occur in overdose of several drugs, drug induced like sodium valproate, baclofen, lithium, levodopa, all serotonergic drugs. But in this case, there are so many causes. So now you cannot say this. So now clinical correlation, because this patient had a severe hepatitis with coagulopathy with altered sensorium, we are saying it is a hepatic encephalopathy. Now coming to an 18 years boy presented with high grade fever with loss of altered sensorium, had an episode of seizure at ER, remained in the drowsy state and had mild neck stiffness without a focal neurological deficit. MRI was done, we showed mild cerebral edema with small hemorrhage in the temporal lobe. You ask for EEG. EEG is showing like this. What is its impression? EEG. How it looks? Pointed peak, more than 70 milliseconds, coming, you can say the sharp waves. And lateralize. Lateralize means if you look at frontotemporal, this region is frontotemporal region, you are seeing these abnormal waves. So if, and that too, see, these are odd numbers. Odd numbers means left side. Am I right? So it means lateralized. So lateralized periodic discharges. So if you say lateralized periodic discharges, what is its impression? Now you have to look at the clinical correlation. And what are the causes of lateralized periodic discharges? So these are sharp waves, and these are confined to one hemisphere and suggest ictal activity. However, they are most often considered as interictal and can be seen in acute destructive lesions, cerebrovascular lesions or space occupying lesions, encephalitis, and including herpes simplex encephalitis. This patient, 18 years boy, presented with fever, headache with mild neck stiffness, mostly in favor with temporal involvement, suggestive of herpes simplex. Yes. Now, coming to this is a bilateral. So bilateral independent, similar, that is a lateralized periodic discharge. This is bilateral periodic independent periodic discharges. Usually you will see in hypoxic. So it is a type of grading. Now the question when we discussed initially, how to grade an encephalopathy. So grading an encephalopathy by the different presentations. So that was like lateralized, it is bilateral presentation. So it may be a severe form of encephalopathy. And you may be able to see this type of presentation you will see in hypoxic encephalopathy, severe hypoglycemia, and CNS infections including HSH2. Okay. Now coming to another scenario, 70 years old male admitted for acute MI with cardiogenic shock, had an cardiac arrest, achieved ROSC, but persistently had an unconscious state with myoclonic seizures, and E is showing like this. What is abnormal here? What are the waves? Did you see generalized periodic discharges of 2.5 hours in a 70-year-old male? It is secondary to hypoxic ischemic encephalopathy. So it is after an cardiac arrest. So why we are saying hypoxic ischemic encephalopathy? Because it is after cardiac arrest, and that too it is happened generalized, and it can be seen. This type of picture it can be seen. The toxic, metabolic, and hypoxic encephalopathy, and it can occur in the non-convulsive status epilepticus. You remember first EEG case also, we saw the similar type of presentation. Now coming to another scenario, a 62-year-old male secondary to traumatic brain injury with associated with subarachnoid and bilateral subdural hemorrhage was in comatose state when EEG was done before CT scan of the brain. And EEG is showing like this. What is your impression here? Yeah, we will go back to scenario again. Secondary to traumatic brain injury with associated subarachnoid hemorrhage, bilateral subdural hemorrhage was in comatose state. EEG was done before CT scan of the brain. So what we need to do and what is your interpretation? Because these things are important here actually. You have to, so there is a unilateral, you see there is a complete, say for example, these are, what are these waves? Low amplitude waves, slow waves, low amplitude, and there is a complete, here complete suppression. These are slow waves, it is which right side? See, these are F4, F, C4 and P4. These are all right side of the brain. And here F3, C3, P3, left side of the brain. So left side you are seeing the complete suppression here, and here you are something low amplitude, slow waves you are seeing. What is your impression here? When you will say suppression, and suppression if unilateral, because I'll come to that point again. A suppression implies an amplitude recording of less than 10 millivolt, and a electrocerebral inactivity when your extreme suppression and with your amplitude is less than 2 millivolt. So that is ECI. ECI is electrocerebral inactivity. ECI was somebody answered as a brain dead. Actually, the ECI can be seen in the, it is seen in the brain dead only, but a profound hypothermia, severe hypotension, a CNS depressant and intoxication should be ruled out because they are reversible causes. And if both present bilaterally with clinical correlation, then only you can say brain dead. Otherwise, you cannot say brain dead. Here, in this patient, had a traumatic brain injury, as Sir told, traumatic brain injury, because he is asking for a clinical scenario. You look at clinical scenario. So clinical scenario, if you look at traumatic brain injury, that too unilateral. If it is unilateral, it means that we are concerned for that. Immediately neurointervention is required. And one side you are getting a slow wave, another side you are getting a complete suppression. So definitely you need an intervention. So you need urgent CT and go for a surgery because already subarach patient is having a traumatic brain injury. So there is raised intracranial tension and having all these waves. Coming to this 2-year child, presented with a fever, sepsis and MOTS, cardiomyopathy, required multiple vasopressor support and had a cardiac arrest, achieved ROSC, but was in comatose state and EEG was showing like this. What is it? Does it mean? Bus suppression. Very good. Why you are saying bus suppression? These are bursts of spikes and sharp waves are combined here with at the same time low amplitude background. So low amplitude background, and that too cover more than, at least more than 50%. So more than 50% of your screen, suppose if it is goes and your 50% of the record consists of your burst suppression. So bursts of sharp waves or sharp waves and with suppression of more than 50% of recording is called as a burst suppression. So common causes are sedatives or general anesthesia. You want to give for hypothermia, therapeutic hypothermia, general anesthesia, status epilepticus, hypoxic ischemic encephalopathy. These are the situations where you will see the burst suppression. Now considering this patient had an cardiac arrest, this 2 years girl had a cardiac arrest, there was ROSC, and patient is having this type of situation, we will, everything we will say, this patient is most probably having a hypoxic ischemic event. And severe, that too, and because patient is having a myoclonic jux and that too burst suppression, these are bad signs. And coming to at this situation, to prognosticate further, what we are doing, SICP, somatosensory evoked potential. How it is helpful? Do you know what is N20? N20 is, we know that inference that a presence of N20 is a good prognosis, but absence of N20 is a bad prognosis. But N20 is nothing but N for negative wave. It means the positive deflection in this somatosensory evoked potential. So positive deflection is negative, negative deflection is positive. So 20 means this 20, the latency of that wave is 20 millisecond. So that is, for that reason it is named as 20. Suppose here P23, 23 means the latency is 23, P is positive wave. P14, N18. So there are different types as per the measurements. But here N20 is significance is there in the for hypoxic ischemic encephalopathy. What we see at HIE, that presence or absence prognosticate the patient. Okay. Now coming to another scenario, a 46-year-old man presenting with subacute confusion and ataxia, showing irregular generalized spike and wave or polyspike. So you see, look at here. So there are multiple here spikes, and where polyspike pattern is also there for a period of around 5 to 6 seconds in this case. And what is important here, this spikes suggestive of, and that too you are seeing generalized. Why generalized? Because all leads anterior, posterior to the coronal line and bilateral, hemispheric. So both sides of the hemisphere is involved. So bilateral. And the most important here is frequency. What is the frequency per second? It is 3. So if 3 is there, what is its known? It's 3 hertz per second, and spikes. You read, we read everywhere. Absence seizure. Absence seizure. So if this same patient continuously present, we can say absence status. Okay. Now another scenario, 48 years male had a road traffic accident, sustained severe traumatic brain injury, was in comatose state with absent brainstem reflexes and a spontaneous breathing efforts, as apnea test was contraindicated in view of severe hemodynamic instability, and EEG was done. So this is suggestive of ECI. ECI means electrocerebral inactivity, no waves totally. It is totally flat line, but some things you are seeing, these are artifacts, ECG artifacts. So ECG artifacts you are seeing here, these small things, whatever your waves you are seeing, these are ECG artifacts. So otherwise these are flat lines. So this is called electrocerebral inactivity. We can, and because clinical scenario is there, that patient all brainstem reflexes are absent, spontaneous breathing is absent. With ECI in the EEG, we can call it as a brain death. So overall, in EEG provide as objective measure of cerebral activity. It gives us, it does not give us a etiological input. So etiological input for a confirmation of diagnosis, again you need a clinical correlation. So but however, it gives a diagnostic value for encephalopathy, and identification, guidance and grading of encephalopathy, and non-convulsive status, what we see in the ICUs, and depth of sedation you can know, and induced coma you can monitor, and in combination with neuroimaging and biochemical measurements can provide as a valuable prognostic tool for HIE and traumatic brain injuries. Now coming to, these are all about EEG. Now coming to nerve conduction studies. Nerve conduction studies are basically when we go for how nerve conduction study is helpful for us, or RNS, repetitive nerve stimulation test, how it is helpful, or EMG, how it is helpful. These studies, why we go for, when we go for it. So when we are suspecting a acute neuromuscular weakness, patients are coming to us for acute neuromuscular weakness, then we go for these studies. So basically, you should have a suspicion, localization of the symptoms. If you are localization of the symptoms, so clinical suspicion is required, whether it is in the anterior cell, whether it is in the peripheral nerve, whether it is in the neuromuscular junction, whether it is in the muscle. So there are some clinical signs which helps us to differentiate clinical localized, but however, some situations where it may be difficult even though you take a history and clinical examination. So that time, these studies are helping us to pinpoint the diagnosis. So you see, you are doing something, a patient comes to you with different presentations, like type of distribution of weakness, a proximal or a distal, and patient is having a involvement of extraocular muscle, or patient is having a presence or absence of deep tendon reflexes, presence or absence of your fasciculations, or patient is having your sensory involvement is there or not. So different types of presentations will help us to clue at where is the localization. However, two things we look at here. Another two things. Patients who are coming to ICU with acute neuromuscular weakness, patients who are developing neuromuscular weakness after coming to ICU. So different causes are there. So coming to ICU with different weakness, it may be different causes. So we should have an overall idea. I no need to describe here, but at least we should have an overall idea. So that it will be easy for us to approach a case of acute neuromuscular weakness, and particularly we'll concentrate here on the nerve conduction studies. Am I right? Coming to a case scenario, a 27 years female came to hospital with history of acute onset progressive weakness of all four limbs within 12 hours requiring a ventilator support, and found to have a normal higher functions and cranial nerves. And muscle power, all four limbs were grade 0 with normal deep tendon reflexes, and plantars were non-responsive, sensory was fairly intact, and so advised for a nerve conduction study and EMG. And if when we did this nerve conduction study, it was looking like this. So the questions will come to us, what are these? When you look at, because we will, he will do the nerve conduction study, he will give you the, please report it, or you just identify any problem is there. So at least if you are looking at those things, findings you identify, then it will be easy, early to detect and can do something for the patient. So what are these things? Whether these are normal or abnormal, when you will call, and how will you describe, what are the measurements you do for this type of things. So CMAP, it is a compound motor action potential for a motor nerve conduction study. For upper limb and lower limb it was done. And SNAP is like a sensory nerve action potential when you do for sensory system. And RNS is repetitive nerve stimulation test. For in certain situations we go for a RNS. We'll discuss that. So these are the things we do, and there are some specific measurements we need to measure to pinpoint the diagnosis. Okay, am I right? So EMG is also like that. There will be recording of EMG. It's usually EMG is not being nowadays done because most of the time clinical diagnosis and some nerve conduction study and RNS will be helpful for the diagnosis. EMG may not be helpful at that time. So coming to nerve conduction study, responses are recorded, like a motor studies for CMAP, and for sensory it is SNAP. F waves and H reflexes are known as lat wave responses. So what are those CMAP and SNAP? CMAP is nothing but compound motor action potential when you do a nerve conduction study. And here, when there are 2-3 parameters which is helpful for the diagnosis. So one is when you conduct a nerve conduction study, so it will give an CMAP, that is compound motor action potential, that constitutes like a distal latency from stimulus to starting of an amplitude, means wave, that is distal latency, and the amplitude height of the wave, that is amplitude or duration, and then conduction velocity. The conduction velocity, again it will be calculated. It is calculated like distance divided by proximal latency to distal latency. So proximal latency and distal latency being calculated by measurements from proximal stimulus, distal stimulus, and recording. And conduction velocity is being calculated. Usually it is given by the machine. We no need to calculate all these things, but we need to interpret by looking at the graphs. Am I right? So then coming to what is SNAP. SNAP is sensory nerve action potential. That is, it looks also similar amplitude, and the latency is also, but here the distal latency is calculated from the stimulus to the peak or nadir of the wave. Nadir of the wave. And here the amplitude is measured in SNAP. Amplitude is measured in microvolt, whereas in here millivolt. In CMAP it is measured in the millivolt. That is the difference. To have an overall idea, in the nerve conduction study, your interpretations, usually what we do, whether it is axonal loss of the axonal loss, or a demyelinating, or a combined, or a focal demyelination. This type of picture we usually interpret from that. So for axonal loss, what we say when we say axonal loss? When there is a decrease in amplitude. If you look at if this considered as a normal, the amplitude is considered as a normal, and distal latency considered as a normal, then here if you look at amplitude is reduced. So we call it as a axonal loss. This is another example where the amplitudes are normal, but distal latency is prolonged. So we call it as a demyelinating form. And what is focal demyelination? The focal demyelination is a condition where low amplitude with proximal stimulus and slow conduction velocity. It's like a demyelinating form. Conduction velocity will be decreased, and there is a temporal dispersion. The wave area, the wave duration will be increased, and amplitude will be reduced, and there will be some abnormality in the pattern of the wave. So that is known as temporal dispersion, and it is usually seen in the focal demyelination. Then coming to the what are the cutoff values, because we need to know, because interpretation is important. I think whether it's boring or I think it is not boring, because these important values we need to remember when we look at. And for upper extremity motor studies, usually we look at only basically 3 parameters. Any motor nerve conduction study, we look at 3 parameters. One is amplitude, another one is conduction velocity, another is distal latency. So for median nerve, ulnar nerve, that will be different. And for the sensor is also median nerve, ulnar nerve, that will be different. And for the sensory nerve axon potential, even though 3 parameters, but usually we look at the amplitude only. Then coming to the lower extremity, usually look at peroneal nerve and tibial nerve. The similar for motor nerve axon potential, we look at amplitude, conduction, and distal latency. And the cutoff values we need to know here. Because I'm not describing cutoff values here because it will be confusing to you. And coming to sensory, similarly sural nerve usually you check, and for that usually you check the cutoff value for amplitude for the sensory nerve axon potential. And for a sensory involvement is there, a snap. Even though patient is having an abnormal sensation, there is a loss of sensation. The normal a patient, you can identify whether patient is having a preganglionic lesion or a postganglionic lesion. Preganglionic, both the conditions will have abnormal sensation. But if you do a snap in a preganglionic lesion, patient will have a normal snap. Whereas in a postganglionic lesion, there will be abnormal snap, means that you are not getting an amplitude recording here for the patient. No recording. That is suggestive of postganglionic lesion. Okay. Now coming to F waves and H reflexes. These are known as late wave responses. Late wave responses means usually suggestive. These are signs of like a lesion in the proximal part of the nerve, means near the spinal cord. So if there is a lesion, you will not see the reflexes or absence of reflexes, or there is an increase in latency of these waves. So how they are being recorded? The F waves are recorded with a supramaximal stimulus. F waves are being recorded supramaximal stimulus. So whatever you are giving a stimulus to record a CMAP, when you will give a supramaximal stimulus, you will get the F wave. Whereas H waves, H reflexes are seen with a subthreshold stimulus. So when you are giving a subthreshold stimulus, you will not get the then only you will get the H wave. So there you may not get a CMAP. So but usually nobody looks for H wave, and usually you look at the F wave. For all practical purposes, people look at the F waves. Okay. F wave responses, there are cutoff values. So for upper limbs and lower limbs, usually for the upper limb there are cutoff values are there, and for the lower limb cutoff values are there. We need to remember for F wave latencies. Okay. Now coming to these scenarios. So when you look at these scenarios, for example, different in a peripheral neuropathy, what are the common diseases out of the common toxins? Already you know about it. I no need to describe all the peripheral neuropathies. But the thing is, Guillain-Barré syndrome is a type of peripheral neuropathy, acute demyelinating peripheral neuropathy. Different presentations will be there. It may be AIDP, acute demyelinating polyneuropathy, or it is a AMN, acute motor axonal neuropathy, or a AMSN is acute motor sensory axonal neuropathy. So you can differentiate by doing this nerve conduction study. So type of different findings. So if a person is having a decreased conduction velocity, it is suggestive of typical of demyelinating, acute demyelinating radiculopathy. It means AIDP, and there may be a sensory involvement and there may be a low amplitude, maybe. And whereas in acute motor axonal neuropathy, usually the only low amplitude CMAP will be reduced, sensory will not be affected, and conduction velocity will not be decreased. In a AMSN variety, the same thing, but here because the sensory is involved, so you will get sensory findings, you will get low amplitudes, but you will not get the conduction velocity will be normal, fairly normal. So that is AMSN kind of Guillain-Barré syndrome. Then coming to a scenario, a 37 years male presented with gradual progressive weakness of the lower limbs followed by upper limbs of 12 days duration with tingling and numbness in both lower limb and without history of trauma and fever. On examination found to have a normal higher function cranial nerves, grade 1 power in lower limbs, grade 3 power in the upper limbs, absent DTR. So the clinical findings are suggestive of something. Now you have done the nerve conduction study. In the nerve conduction, what is your impression now? Just looking at the graphs. In the upper limb, median nerve, upper limbs, fairly looks, amplitude looks fairly normal. Whereas in the lower limbs, tibial nerve and peroneal nerve, the amplitudes are diminished. And what happens here? The distal latency looks prolonged. Am I right? Now coming to the F wave response. In the median nerve and ulnar nerve, F wave response is absent. In the lower limb, F wave response is also absent. Sensory also in the upper limbs not recorded. And in the lower limb sensory, there is some sensory nerve action potential, but it is very low amplitude, 2 microvolt. Okay. Now, if you look at the values also, the same patient, when values were being recorded, if you look at cutoff values, if you see, now I kept here for verification. Actually, distal latency, we discussed 3 parameters: distal latency, amplitude, and conduction velocity. So cutoff value, suppose if you look at the distal latency is prolonged here. Amplitude is normal, fairly normal here in the upper limb, median and ulnar. And here also fairly means it's slightly decreased here, but distal latency is prolonged here. And conduction velocity is cutoff value, as per the cutoff value, it is grossly decreased here. Here also conduction velocity is grossly decreased here. And coming to lower limb, where your amplitude is also grossly decreased and your conduction velocity also grossly decreased. How can you explain this thing? So now coming to motor, in the peroneal nerve, it is almost same. Conduction velocity is decreased. So F waves are not recordable. So what is your impression now? What is your impression? Yes. So irrespective, even though there is an amplitude, it's a AIDP, correct? So AIDP, why we are saying AIDP? Normally when we say AIDP, when conduction velocity is decreased and distal latency is prolonged, amplitude is not getting prolonged. But here, even though lower limbs amplitude is decreased, but still we can say it is AIDP because conduction velocity is most important finding which is prolonged here. So we can say confidently that this patient is having AIDP. Okay, there are some diagnostic criteria. So if you look at all, I think it may be confusing for you, but diagnostic criteria is there to diagnose AIDP. Okay. Now another scenario, a 25 years male presenting with 4 weeks duration, progressive weakness of all 4 limbs, initially treated with at local center, MRI spine was normal, later developed difficulty in breathing, 2 days, found to have a normal higher mental function, respiratory muscle weakness with grade 2 power in all 4 limbs. Absent DTR, hyperalgesia, and nerve conduction study was done. What is your impression here? Grossly low amplitude here. F wave response in upper limb, both limb, low amplitude. F wave responses in the lower limb, except here some FOF responses are there in the on left ulnar. Okay. Now coming to sensory. Sensory is also not recordable. Here in the sural nerve, sensory is low amplitude. Okay. Now coming to cutoff values also, if you look at amplitude is if upper limb also grossly reduced amplitude, and conduction velocity is slightly marginally reduced, but amplitude is grossly reduced. And here also latency is fairly normal. Here motor conduction amplitude is grossly reduced. So definitely here and sensory conduction, sensory is totally not recordable. And FOFs are also only you are seeing in the left ulnar nerve. So what will be impression here actually? What will be impression? It will fit into your AMSAN. Acute motor axonal amplitude is reduced, conduction velocities are fairly, it is marginally reduced, because there is a criteria to say AIDP that it should reduce. When amplitude is grossly reduced, your conduction velocity should come by less than 80% of the patient's value. Less than 80% of the patient value should be reduced. So it is marginal. So for that reason, and with if you take a history into account and examination findings into account with this study, so you can say patient is having a AMSAN variety of Guillain-Barré syndrome. All right. Now coming to a case scenario, this 58 years male had an open wound injury to the right lower limb followed by RTA. Following an RTA, he developed weakness of both upper limbs followed by lower limbs and required a ventilator support. And progressive SOB for progressive found to have a normal higher functions and grade 1 power in all 4 limbs with normal DTR. What is your diagnosis impression here from here? Myasthenia unlikely. Very good. Somebody has answered. So yes. So there is comes the role of. So when you want to do a RNS, actually, that's what I put this scenario is because to when you suspect to go for RNS, repetitive nerve stimulation is a test. You want to go for it when you are suspecting a neuromuscular junction disorder. As he told, clinically you are suspecting a botulism. So for that it is a neuromuscular disorder, presynaptic. So for that reason you want to go for, or a patient is presenting to you with active fatigability, with a less work and the patient is getting fatigued, or you are suspecting a neuromuscular junction. So definitely you should go for a, or a muscle disease, you should go for a repetitive nerve stimulation test. So that will help you, guide you. So what is RNS? So RNS is nothing but to stimulate the motor neuron with a train of supramaximal stimuli before and after exercise, and with low frequency and high frequency. So low frequency is to detect postsynaptic problems and high frequency is to detect the presynaptic problems. So if how to differentiate it? If you look at RNS, it will be easy to identify for if you do an RNS. If a normal RNS, a normal person without any neuromuscular weakness will look like this. And in this category, B category, this we call it as a decremental response. From the first wave to second wave, at least there will be reduction in the 10 to 20% of reduction in the amplitude of the wave. And with the low threshold, means low frequency threshold, if you give, and for postsynaptic, when you are suspecting, and you will give for a low frequency, high frequency, and in a low frequency, a person is detecting to have a decremental response. Then we call it as a postsynaptic neuromuscular disorder or myasthenia gravis pattern of nerve RNS. Or a patient is having an incremental response, we call it as a presynaptic neuromuscular disorder or Lambert-Eaton myasthenic syndrome. This type of picture, and usually these patients will have a post-exercise exertion. These patients will not have exertion, and the baseline amplitude of the compound motor action potential will be less here in the presynaptic. Here, baseline compound motor action potential will be normal here. So that is, these are the some differentiating features which will helpful for RNS, because basically two things you look at: presynaptic, postsynaptic. That's all. So coming to another scenario, a 45 years male was admitted for a COVID pneumonia. requiring a high FiO2, multiple sessions of proning, paralytic agents, ventilator support, high dose of steroids for a weeks, 2 weeks, and not able to wean up from the ventilator. Diagnosis. Very good. So it's very easy now. So you are see, it's very easy. So how to diagnose now? You confirm your diagnosis. If you do a similar type of nerve conduction study, it will help us. So if you do a direct muscle evoked potential and a nerve evoked potential, you can diagnose two conditions: critical illness polyneuropathy, critical illness myopathy. So you can differentiate. Suppose if you do a direct muscle evoked potential in a critical illness myopathy, the amplitude will be reduced, and in a nerve evoked also there will be no response, amplitude will be in the reduced state. Whereas in a polyneuropathy, in a muscle evoked response also decrease amplitude, where a nerve evoked response there will be improvement in the amplitude of the CMAP. So that is critical illness polyneuropathy. So that helps you, and sometimes it may be difficult for you, those patients who are having a critical illness polyneuromyopathy. Neuromyopathy means combination of the disorders. So it may be difficult for us to, that time you may get it like a myopathic picture only. So, but if a patient is having a lonely polyneuropathy, only without myopathy, you will get this type of picture, which is helpful for diagnosis. Okay. Okay. Next, so here the critical illness neuropathy and myopathy, you can know that here. One more important thing I'll tell you. In a critical illness neuropathy, the sensory involvement will be there, whereas in a myopathy, no sensory involvement, and conduction velocity will not be affected. It will retain as a normal. So that is the another important point to diagnose the critical illness neuropathy. Now EMG, actually we don't do routinely EMG, but still we need to know some of the parameters for the EMG. And usually studied at rest and at sustained contraction or a voluntary contraction. And what we see, we look at MUAP, motor unit action potential. So how it looks, it's difficult exactly, you cannot say in the when you do an EMG, this type of wave, whatever the description is there, it may be difficult to see here. So there normally two things to identify from EMG, a neuropathic pattern or a myopathic pattern. The neuropathic pattern, if you look at neuropathic pattern will be like a high amplitude, polyphagic, longer duration. This longer duration, polyphagic, high amplitude. Myopathic pattern is low amplitude, short duration, polyphagic. So these are the two important things we look at when you do an EMG. And some spontaneous, abnormal spontaneous waves. Normally, spontaneous waves will not be there when you record the EMG at a rest period. But if a person is having a spontaneous abnormal recordings when you are recording, then it is abnormal, considered as abnormal. So if you are getting a end plate spike or positive sharp wave or fibrillation, so usually single fiber problem. And if you are getting a fasciculation, so multiple fiber or a group of muscle fiber are being affected as a fasciculation or a neuromyotonic discharge or a myochemic discharge when you are recording spontaneously without giving stimulation. Okay. So this is already we have discussed motor unit potential, how you look like. It looks like, and presence of abnormal spontaneous activity suggestive of a neurogenic lesion. Usually in a myopathic lesion, the spontaneous activity will be absent. And coming to this scenario, now he answered before that. 52 years male, business by profession, came to hospital with acute onset SOB, required an MB support, found to have a fairly normal respiratory and cardiac examination and evaluation including CT, and everything was normal. Neurology examination, he had a normal higher functions, weakness of all four limbs with normal deep DTR, poor cough and gag reflexes. Review of history, there was a nasal intonation of voice and easy fatigue by returning from office. Diagnosis. Very good. So now you are able to diagnose by giving history itself. So no need for going for a testing. Okay. See, if you do an RNS, it will look like this. It is a decremental response. The most important here is the decremental response. You look between the first and second wave, not at the third, fourth, or subsequent waves. So this is important picture. If you get a decremental response RNS at low amplitude, means a low frequency of stimulation, then we call it as a myasthenic syndrome. Okay. So, and when you do a EMG study for a neuromuscular junction like myasthenic syndrome, you will get a similar picture already we have discussed here. So, and this type of presynaptic and postsynaptic, because botulism was the first diagnosed, you have diagnosed presynaptic, it is a presynaptic. So, your RNS will be an important differentiating picture for difference between your myasthenia and botulism. Now coming to what we learn from this, all these things, nerve conduction study and RNS and EMG, these are most important tools for diagnosing neuromuscular weakness after your clinical diagnosis, not before clinical diagnosis, after your clinical diagnosis. And critically ill patients developing weakness during the hospital stay needs more attention to diagnose early and implementing the prevention methods, because we are giving a lot of steroids or neuroparalytic agents for a longer duration of period. Those are the main precipitating factors for developing critical illness. So we need to be careful for that. And Guillain-Barré syndrome diagnosis and prognostication also helpful for when you do a nerve conduction study. And EMG is helpful for diagnosing neurogenic or myogenic pattern for the treatment. So thank you for your attention. But one thing is, I want to specially my heartful thank to Dr. Bharat. He is our neurophysician. A lot of inputs I have taken from him, slides, some understanding, because sometimes we don't see regularly. And so we have also doubts while preparation of the slides. So definitely I especially thanks to Dr. Bharat for giving me inputs.
As a neurophysician, I literally enjoyed your talk, sir. Actually, it is very in-depth and in detail, and you stuck to the basics and whatever the necessary input that you gave. I literally enjoyed the talk. And one more thing, one point from my side is like, so especially in RNS, sometimes bedside RNS is not available most of the time. So that's why what I do in 2 or 3 patients was like, if a patient presents with ptosis and extraocular muscle palsy, so I don't know whether it is not approved or ethical, I don't know, but I just give a shot of neostigmine plus atropine, so that we can try, because these patients they will respond to neostigmine, one shot of neostigmine IV and followed by atropine, like atropine followed by neostigmine. That thing that is widely practiced, so that you can try actually in these when you suspect especially myasthenia gravis patients.
Correct. So we do a neostigmine study for myasthenic gravis patients for diagnosis.
It used to be Tensilon test. It used to be, but Tensilon test according to book, but neostigmine test we can try.
Yeah.
And that's also, that is very good talk, sir.
Thank you very much.
One doubt we might say, the sedations, they come in between whenever in an intensive care unit, when you are encountering any encephalopathy patient, most of our patients are on sedation of some sort or the other. What are the precautions that as an intensivist you should take before you order for an EEG or you discuss with an neurophysician regarding EEG? How do you change your practices of sedation before EEG? EEG, ongoing sedation.
Correct. Actually, anyway, we are monitoring a sedation scale for giving the sedation. So sedation scale, when you are giving a sedation, some sort of sedation. So sedation assessment scale when you are using. So from the targeting, because routinely bedside you cannot do an EEG for each and every patient. So when we are suspecting a unexplained unconsciousness, loss of sensorium, or acute some deviation from the acute condition, so then you are suspecting some either an unconvulsive status, or you are suspecting some absences, or you are suspecting some other focal condition or some other neurological condition, then only you should go for a EEG. For a routine sedation, whatever, so I think sedation scale is good enough to monitor the patients for giving the sedation. And if after stopping the sedation, still you are having, patient is having a abnormal neurological findings, we can go for a EEG.
on ventilator support, sometimes we see instead of sedation using muscle relaxation and getting EEG done. That kind of a thing could be done.
Yeah, so actually the muscle relaxation does not affect anything. And sedation, if you give, the wave pattern may change. Your background activity will change. So instead of a some means, for example, a conscious patient, irritable patient, if you get a beta activity or alpha activity, you may get here theta activity. So your background activity will change, but abnormal waves will be present. Suppose a patient is having a seizure, non-convulsive start, something is there, a lateralized discharge or something is there because of pathology, either a cerebrovascular accident or a encephalopathy or maybe due to any local pathology, the abnormal waves will remain present in spite of giving sedation. Only background activity will change. Background activity will be like your theta activity or a delta activity depending on your sedation.
Yeah, as you write.
So thank you all. Yeah. Anything else?
Thank you, Saroj sir, and we close this session here. And next we have a quiz session.
Thank you, sir. I request the chairpersons to felicitate our speaker, Dr. Prushti, sir. I request Dr. Shankar to felicitate our chairperson, Dr. Bharat Kumar. I request Dr. Shashi Kiran to felicitate our co-chair, Dr. Karthik Munta. Thank you, sir. With this, we are done with all the talks for today's program, and we are left with an exciting finish to today's program, which is the quiz. But just before we go into the quiz, we have three important people to thank, without whom today might not have been possible. First, I would like to invite Dr. Venkatraman Kola, and I would request Prushti sir to thank him and felicitate him with flowers and a memento. You can have another one, sir. Actually, it's a very good initiative, a green token. I request Dr. Ramakrishna to felicitate Dr. Prushti sir. I request Dr. Ramakrishna to felicitate Prushti sir. Now I request Prushti sir to felicitate our very, very able coordinator for today's program. All of you must have interacted with him either through message or on phone, and you must have already made out his special skills he has. I request Prishti sir and Venkatraman Kola sir to felicitate Shankar sir. Actually, he is a people's person, excellent PR skills, and probably is the one responsible so that all of you are here today in such large numbers. It's his daughter's second birthday today. After this event, he has another event lined up for in the evening at his home as well. Many happy birthday wishes to your daughter, sir. Now I will request Dr. Shankar to give a vote of thanks, and this will be followed by a quiz.
So we are thankful to one and all, especially on this Sunday. After a long, actually we thought of finishing before lunch, but the topics are like that. Each needs explanation, so we cannot run fast. So we thought of taking a little bit more time. So I would like to thank Dr. Venkatramana sir. We thought this program 2 years before, but this came into effect with only Venkatramana sir, who supported in all aspects. The brainchild behind this program was Dr. Prishti sir. We did one ventilator workshop 2 years before. After that, we start off doing summer program, but COVID has come. We could not do physically. So the second wave finished, thought of doing it, but with the help of Venkatramana sir, we were able to do. And I thank Prishti sir for giving me this opportunity. And I thank all the digital people, food and beverage people, Sitaram Sudhakar, and all the faculty who took a lot of pain since almost it took 1 month to prepare all the slides. We did multiple reviews because we are taking precious time of the delegates and faculty. We thought we should give good quality and content. So we took a lot of pain. It's not a pain with happiness we did it, but we wanted to give good content. So I thank you one and all, especially the housekeeping people who did on this Sunday. Yesterday also there was festival half. So they came and did everything, all the arrangements. Thank you. And very soon we are going to do one more program. We'll update you soon. Thank you very much. And one more thing, without whom support we could not do the program successfully. That is our hospital administration, all our RMOs, especially Ku sir and Pawan sir. So everyone supported to to make this program too much successful. Thank you very much, one and all. So now let's start with the quiz. So how many people are interested in joining quiz? So we'll do one more thing. Let us give numbers to 1 to 6 in a row. All one should go together in each group. All two in separate group. Yes, sir. Dr. Niranjan and Dr. Deepak will tell the rules and pattern of quiz. Please, sir. Please come.
A round of applause to Dr. Niranjan Panigrahi and Dr. Deepak. So we will organize all the delegates into probably about 5 or 6 groups, and the quiz masters will guide you through how the quiz will be conducted.
Good afternoon all. So we invite Madhusudan Jaju sir to be the judge for the quiz session, please, sir. So how many among you are still awake after slow easy waves, slow latency and so many things? Okay. So I hope at least 50% are awake. Till now we poured all information. Now this is the session which you actually need. In the exam, the teachers will not give you anything. It is the reverse, okay, which we are going to do just right now. This is the actual thing which you came here for. Okay, all these 4 hour, 5 hour is finally, okay, will end with this session. Grouping.
We'll do like this. Each of you count your number 1, 2, 3, 4, 5. Okay.
All can come closer. Okay, there are so many empty chairs. Please.
So you are 1, 2, 3, 4, 5. Yes, sir.
Okay, please keep on counting from you. Yeah.
And you remember your number. Same this. No, 5. 5.
Okay, all
the
ones to
ones
this
you
corner.
count together.
All
Yes.
ones to this corner.
Please. All twos, you go there. Shankar. Shankar. Shankar.
How many questions? How you think that they
5, 5, 7. Basically 5 rounds and 5 questions. Each round 5 questions.
Okay.
So first one also start with that. If they cannot answer, it will be whoever fastest will get first. Second question, second question. Single so 5 rounds. फर्स्ट टाइम अगर उसको पूछे तो सेकंड 5 राउंड्स ओनली डायरेक्ट क्वेश्चन को 2 मार्क्स है इनडायरेक्ट क्वेश्चन को 1 मार्क
अच्छा तो मार्किंग मुझे बता दो इफ समबडी
5
If there will be a tie, we have reserve of another 2 rounds. Okay? We'll start it now. Sir. Yes. Direct question, correct answer +2. Direct question, wrong answer -2. Okay? Pass question, correct answer +1. Pass question, wrong answer, no negative. 0.
So your timekeeper. Okay, first one. 30 seconds, I think. 30 seconds. Okay, team A. Okay. So first question for you.
Okay, now your first question is in your screen.
So what's going on in the picture? If you identify the what's going on and what is the person whose name, full marks for you.
+2 or -2. You can discuss in between.
Yeah, please. Okay, don't keep too much pressure. Be cool. Yeah, you have time. Be clear.
There is a
So
horse.
what is he doing?
Good guess.
What is he doing? What is the animal there? Your faculty should know.
Okay, Mike.
Okay, so this is passed to the other. Who answers fastest finger first among the next 4 groups. Lift it only if you're sure. Otherwise, minus marks will be there. You answer. Lift it. Oh, sir. Sure.
Yes.
Okay,
It's no minus.
Okay. So.
Okay. Fine. Mike.
There.
Pressure is being checked by putting a cannula in the horse vein, I think. CVP measurement.
Okay. At least. So who's the person who's doing that?
That's fine. At least he answered.
Okay. So it's basically Stephen Hales is the person who has first done before your force man the regular catheterization measurement. He was the first person. He was basically a clergyman.
Yeah.
Yes, he was a clergyman. So he has done a lot of things. He has invented a lot of things. Among them, the first thing is he used to cannulate the horses, lot of sheep, and all of them. So once they exsanguinate, they used to even mold the wax into the ventricles. He was the first person who calculated the volumes of the heart. So this is where he is calculating the blood pressure, the pressures in the arteries of the horse.
So it's not CBP, it is blood pressure.
No marks for you, but good.
Okay, good guess.
Okay. Okay, so we'll go to the second.
Okay,
question.
so your question is gone. Okay.
No
Now,
problem. At least you didn't get the minus marks. So second team B. So
20-year-old female presenting with palpitation and pre-syncope. Okay. Now this is the ECG. Okay. See it carefully.
Two things. If you get the diagnosis, answer in a word. If you describe it, that would be good. Time used.
Are you ready?
Do they have minus if they answer it wrong?
Yes, yes, of course.
Okay. Come. Answer it, answer it. You already answered the phone. Pardon me?
Wolff-Parkinson-White syndrome.
Reject it.
Narrow complex tachycardia with.
Is it regular or irregular?
So you need to tell the complete diagnosis.
Irregularly.
VNRT is a regular one. So, unfortunately, minus. So, good. So, they are the one.
Okay,
who,
next. Yeah.
Okay, good. You are the fastest finger.
AF
You
with
decide whoever
WBW.
articulates.
AF with WBW.
AF with?
WBW.
Yeah.
Yes.
Good.
So that's the right answer. Okay.
So you scored it the marks, right? Good. So, done.
So somebody was answering only WBW.
So can you describe it just for a second? Very well done. Why do you think, or did you see the question before? Then answer it.
It's a narrow complex tachycardia with the slowing of the S wave and it's irregular. Irregular.
Good. Basically, it's there is a irregular heart rate. It is fast, and the rate is coming into that spectrum of tachycardias. And again, at the same time, the QRS is widened. So definitely, it's atrial fibrillation with a block, and there's a WPW is also classifying there. Good. So good. With second question, one break here is when you're trying to answer, you choose the person of the team who answers it. Okay. Let it be a single answer from you. So team next question
team
is for
C answered. Team C answered.
Team C answered. We scored it. Huh?
So no, it's not important that only they should know. Did all understand why what is the ECG? Already this was discussed.
The whole point is that just understand.
Okay. Shall we go to next question?
Yes.
So again to them.
Yeah. So this is your straight question.
39 female consumed unknown substance, developed severe hepatitis, came to hospital with vomiting, pain abdomen. After 48-hour altered sensorium, coagulopathy and 2 episodes of seizure. Now, before ECG, this spectrum tells something. Okay. The ECG, will go to the ECG.
EEG.
Okay.
EEG.
Sorry, EEG. So, what is your interpretation?
One, you choose one of your good.
Triphasic wave.
No, two. There are two questions behind. So, what is your interpretation? One
Hepatic encephalopathy. EEG showing triphasic pattern.
Okay. Good. Easy question for you.
Okay, so that's the right answer. Okay, so this is the triphasic pattern and patient had hepatitis. Okay, so unknown substance, maybe alcohol.
So good. So who is leading? Team C is leading.
So this is the typical EEG pattern of hepatic encephalopathy. Okay, triphasic wave pattern.
Good. So next question goes to Team D. So one clue, it's a parasite. So identify the sign and the disease. You can discuss among 5 of you. It's a parasite.
Which parasite do you find inside the lung?
And so just think about and answer it. Again, negative marking.
Dog tapeworm. Dog.
Which one?
If you don't know, minus
long,
2.
Long tape. No, you answered long tapeworm. Isn't it? You want to revise it?
Strongyloid is strongyloid. Strongyloid. Yes.
Don't worry, no problem. So this is a no. So the straight question is for them. So we'll fastest finger. हाँ इसका तो हो गया सर.
They gave wrong answer.
So fastest finger is team B.
This is water lily sign.
Very good.
Excellent.
Excellent.
So this is a water lily sign. So hydrated cyst normally infect the lung.
Good.
Not strangulate.
It's okay. Cool.
Fine.
So
fine.
good.
That's fine.
Team B is trying to come back, I think. Right?
No, they are compensating now.
Yeah. It's
They
like
were in negative side, I believe.
It's like a Virendra Sehwag. You try to hit everything, one of them will connect. Good. Equal sixes, equal duckouts. Good.
Good.
So we'll finish it in team D, right? So the last question in this round is for the team E, right?
28 female, history of eating disorder, present with syncope.
One of you.
Okay, read the question carefully. Now,
So
this is
it's
the ECG.
So just take a second. Two questions. You need to identify the ECG diagnosis at the same time. What is the phenomena which is precipitating it?
Can I have the question again, sir?
Question back.
Yes, sure. 28 female, history of eating disorder, came to you with syncope.
All of you be ready. If you lift it before
This
also,
is the
you
ECG.
get -1.
-2 plus 2. If you are sure answer,
First let the primary team answer it. If you lift it before, minus marks, I'm telling you. It's
yeah,
like,
we'll make that also.
Mankading
Plus
will
one,
be
minus
there
one.
in cricket, it's like. So, 5, you want to answer?
Yes.
Yes.
Good, please.
Sir, I think it is VT.
Okay.
No?
It should be more specific than that.
Monomorphic VT.
Huh?
No?
Gone.
Sorry, polymorphic VT.
There is no sorry, gone.
Oh.
Gone. So, -2, sorry. Because
So that's the wrong
monomorphic
answer.
is completely on the opposite spectrum. I'll give. No, judge, who is the one who lifted the finger first?
For group A.
Group A, good.
Group A. Okay, answer please.
So wait a second. Okay, you answer the ECG diagnosis. Phenomenon is precipitating it also. Okay, take a break and answer.
So eating disorder was either
ECG
ECG is hypokalemia
ECG
and leading to torsades points.
Okay, what is the phenomena which is causing torsades?
Mechanism.
Hypokalemia.
No, I am not asking the biochemical disorder. In the ECG, what phenomena is it? Or else I will point out here for you. So what is this?
RNT phenomenon. RNT.
Good.
That's the one.
So good. So we're done with the first round.
So that I'll just declare the scores at the end of the first round.
Listen your scores.
The group D and group E in the deep trouble, they're in the minus side. Group B is making some progress, initially minus plus became +1, and the group A opened the account with 1 mark.
Good. Congrats to group A.
So it's only first round, don't worry. There's still end of the tunnel is there.
Group C is leading with 3 marks.
Good, very good, very good.
Good. Still you have another four chances, I believe.
Yeah, don't worry. So this again the second round. We'll start with the team B first question. It is your question, first question, team B. So again the same pattern, sir. 2 marks straight question. If you answer it negative, again -2. If you don't answer it, fastest finger. See, don't lift the hand before they answer it. Okay? Or else what we do is buzzer or something, then we'll answer.
Okay, actually this time we given lot of lenience. This time we'll keep only 30 seconds for answer, not more than that. We are giving almost
Time
1
limit.
minute.
Okay.
Yes, we are having the watch.
So the first question starts with team B.
Okay. So look at the graph. So there are 3 graphs in front of you. You need to answer 3 out of 3. Okay.
Only if you answer 3 of them, then you'll get the mark.
Okay. Explain all 3 graphs. A, B, C.
Time, sir.
30
Time
seconds.
starts now. Another 10 seconds. 36 seconds are over. Also, you'll be not minus. Come on.
Just give 5 seconds.
What? That is an arterial waveform, is? Yeah. Okay.
No, still the answer is not complete.
Only thing
Okay.
is you answered that it is an arterial waveform. That's it. Next. So don't lift it before 1, 2, 3. On the third round, whoever answers the and they'll get the question. Where is the?
You didn't explain graph B, graph C properly. Only graph A you told.
We'll tell.
Options.
We'll tell you. Don't worry.
Is very clear cut 3 answers, otherwise negative marks.
Yeah.
So 1, 2, 3. On 3, whoever answers the.
Okay. Whoever answers all 3.
So it is open.
Who wants?
1, 2, 3. Okay. So you would like to take the question. So because you have taken it, you need to answer 3 waveforms, right? If you misses it, then negative. Oh.
Negative. Past questions.
Loudly, we are not able to hear. Speak loudly.
First one is normal arterial graph form, sir.
Okay.
Second one, the diagram. So probably it is AS, sir, aortic stenosis, and with the systolic blood pressures being lower side, wide pulse pressure seen in the third one could be aortic regurgitation.
See, it's basically taken at different parts of the arterial wave system. What we're asking is at which level the probe was kept. Okay.
Excellent.
So
okay, that's the right answer.
First one, aortic stenosis, aortic regurgitation. So the pathological waveform is that one. Okay. So I think no one got the question, right? No one got the answer, no sir?
No, he answered rightly, I believe.
Bol diya?
Yeah, he answered.
Good. Sorry.
He answered only, I think, 2. Third, he didn't answer.
Third क्या बोले? Aortic regurgitation बोले?
AR he told.
Okay, good.
Achha, okay.
Yeah, if the other enemy is telling it, then it's
okay. That is
correct.
group.
So
D is
group.
+1.
Okay, next direct question to
direct
group
question to whom?
C.
C. Okay.
They are group C.
So name the famous Swedish radiologists. It's good. Pictures are always easy. If you know, you know. Otherwise, you don't know. $30 is the time.
All other groups are very happy because they were
Second.
leading.
Time.
You should not open Google, Rao. $30. Your 20 seconds are over. How much time, sir?
5 seconds more.
5 seconds.
Hansfield?
No. Okay, so open to the other people. Fastest finger.
Group C will get negative marks.
You want to answer? No. Answer. Good. Oh, you fix it.
Ronjan?
Pardon me?
Ronjan.
No. So the clue is he is the one who invented the technique where you regularly place the lines. Central line, arterial line.
Seldinger.
Is Seldinger. Is very famous. Okay. Our bread and butter is dependent on him.
But I think nobody answered.
Nobody answered.
Okay.
Anyone got the negative marking, sir? The first.
C.
Group C has got negative marks.
You could pass it also if you are not sure. Okay. So
okay, fine. So next direct question to group D. 20-year male. What happened?
You didn't pass it.
You didn't pass.
No negative marking.
If your direct question came to that group giving wrong answer, negative marks. If you pass to the other group, +1 mark. You can save. You wasted your 2 marks.
Okay. So the direct question to batch team D, no sir?
Team D.
Team D.
Okay. So this is your question. 20-year male presenting with altered sensorium, hypotension and seizure. This is the ECG.
So what is your ECG diagnosis? Like basically what is your diagnosis? What are the features which are supporting it? Young male presenting with altered sensorium, seizure and hypotension. 2 ER.
30 seconds are over for group D.
Okay, at least no negative.
Please pass on to others. Time is over for group D.
Okay, fastest finger.
Group A.
One of you find.
Brugada syndrome, sir. Sodium channelopathy.
No. It's a poisoning basically.
Would you see the question again?
Go back.
20 male, altered sensorium, hypertension, seizure. Altered sensorium, hypertension, seizure.
So you can see in the ECG what are the things you're seeing.
Sir, 1 second.
Marks won't be given.
Okay.
Okay, let her answer.
No, she told digoxin.
You're answering, na?
Digoxin.
Okay.
So for audience, anyone?
This is the wrong answer. So
It's
Group
your
C.
C wants to answer.
C wanted to answer.
See, but marks will be given.
No, nobody will get the marks now. Chance is gone. It's open to the forum now.
QRS prolongation.
QTC
QRS is prolonged.
TCA
Correct.
poisoning.
It's a tricyclic antidepressant poisoning. It's a classical ECG which is showing in an exam, whether it's an EDIC or whatever it is, all the classical features are there. Clear? Is it fair enough? Tricyclic antidepressant poisoning, the QRS prolongation.
Okay, could you find out a broad QRS?
Tricyclic TCA poisoning.
Sorry.
Okay. So we're done with the question to D batch. So last question of the
To
round.
group E.
So last question of the round.
Okay. You
No,
answered wrongly, I think.
No. It started with two. Sorry. You were also a bit confused.
Okay.
So last question will come to team A at the end, sir.
Last question will come to group E.
No, second round we started with team B.
Second round, yes.
Okay, now.
So you also have the opportunity to earn the marks.
29-year male came with fever, sepsis, MODS, cardiomyopathy, requires multiple support, had cardiac arrest, received ROSC, but was in comatose state. Now EEG was done. Okay, see and interpret. Got 29, sepsis, multi-organ dysfunction, cardiomyopathy, head arrest, achieved ROSC. Now.
Easy question. You should not attempt it before. We'll make it negative the marking. Only after they finish pass, then only you should answer it. 30 seconds.
Burst suppression. Burst suppression.
Very good.
Good.
Burst suppression.
Okay, that's the right answer.
This group E +2.
So usually it happens in hypoxemic ischemic encephalopathy, post cardiac arrest state. Okay. So they did the right answer. Next is to group A.
Last question of this round to team A.
So
can you play that? No, go back. Play. No, minimize it into slide. You're going to next question. So two parts of the question, diagnosis and imminent treatment, first line of treatment. Okay. So,
diagnosis is pulmonary embolism.
More specific you should be.
Most
massive PE.
Massive PE, and immediate treatment is based on hemodynamic status. If thrombolysis.
Okay.
We should not be prompting. He'll get only 1 mark.
Sir, they're asking.
Direct question, but half of the thing is prompted by the Deepak. Judge is final. Second round, Group A is having 2 points. Group B is having and 1 mark. Group C is 1. Group D is 1. And Group E is 0. Initially was -2 plus 2, 0.
Chill, man, don't.
Okay, who is leading right now?
With the Group C.
Still Group C is leading.
Seems to be a lot of competition. Team A are getting antsy.
Team A
Don't
plus
worry.
one.
You have a lot
Team A?
of chance to
Plus one. Okay.
So YPL, Yashoda Premier League.
Okay, so next round?
Next round.
We start with Group C.
Clear till now, sir. Marking everything.
Clear.
So, Team C, straight question for you.
C. That will start with C. Okay. So, this is your question. You need to identify the sign and tell whether it's normal or abnormal.
30 seconds, easy question. So answer.
It's normal seashore sign.
Okay, right answer.
Most beneficial things in life are simple. So you got 2 marks easily for it, right?
Okay.
If you complicate it, think something
Okay,
else,
next.
then you'll. Okay.
Next, straight question to D. Okay. What does D indicate?
D indicate.
What are the last?
Can you see the point D?
D, sir?
Yeah.
Augmented diastolic blood pressure.
Once more, please.
Diastolic augmentation.
Okay, that's the right answer.
So we are in a giving mode.
So what is this wave basically? Okay, look, getting this
Biotic blood
pinpoint
pressure.
answer is not our purpose. Okay, you need to know what is that wave. Okay, so because we took 5 hours of class, so I suppose you know this thing. Okay, so we are skipping so many things. Okay, this is the IABP graph. All can recognize it's a
Yes, sir.
IABP. Normally IABP helps during the diastole. Okay, so unassisted diastole. Okay, assisted diastole, augmented diastole. So the naming are important. Okay, unless you know what is that graph, then you cannot interpret. Okay.
Correct answer.
So that is diastolic augmentation. That was the right answer. Okay.
So
Next question.
Next question.
Group E always get easy questions.
Yeah. So guessing will again
What is
risk
the
of negative marking. So what is the prototype? I'm like basically which machine is the prototype of?
It's related to ICU. Don't tell it is a aircraft or something. It's a prototype of some machine which we use in ICU.
30 seconds.
If you know correct answer, give.
15 seconds. 14 seconds.
30 seconds are over.
30 seconds are over. 1 second, Grace. Anything?
Pass over.
We'll guess. ECG.
Gone. Minus
Gone,
2.
gone.
Minus 2. I told you first only no guesses. So fastest finger. You answer. Left.
No, pass on is not negative.
No negative.
answer.
You can make wild guess.
No. Any guess? No. Just take wild guess.
Somebody told ECMO.
Extracorporeal therapy. Any other guess?
It's Lundberg wave, what we measure ICP.
No. 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 Anything? Any other guesses? No. It's a CT scan machine, prototype of CT scan machine, the first initial CT scan. Yeah, to dikara. Neeru, you're showing up.
Fine. That went like it.
Take it, sir. Goes.
Okay. So nobody got the mark, I believe.
Okay, at least no, anyone got the negative. Actually, you got negative. Good.
What did they answer?
CT scan machine.
ECG on that only.
Negative.
Okay, next is easy question.
One second. Which team?
This is the last question to Group A. Group A and B, 2 questions more.
So this is which round, sir? Third round we started with? Okay.
This question is to A.
So 35-year-old male, chest pain. First ECG was taken at time of presentation. Second ECG was taken 25 minutes later. Show the ECG. So you need to identify the diagnosis and again the syndrome also. If only answer 2 of them, you'll get the mark. Chest pain diaphoresis.
10 seconds are remaining for Group A.
Valence syndrome, sir.
So, but only half answer. Second one. What is the diagnosis? Valence syndrome. What does it make? What constitutes a Valence syndrome?
Time is up.
Pre-MI.
Pre-MI. What is pre-MI? Early MI.
No?
Sir, V2, V3 is showing ST elevations. And
no, you are partially correct. So show the answer. We'll give.
Okay, this is.
Only anterolateral. See, you need to identify
It's
the
established
clinical.
MI. Why pre-MI? They're very clearly these ECG are showing.
You know what is self-goal? This is self-goal. You answered Valence syndrome. Pre-MI क्या होता है? No, I was very clear.
We'll give only.
I was very clear.
One
What
only.
is diagnosis is MI, anterolateral MI. Conscious a part of Valence. 1 mark, sir.
Yes, half mark.
Half mark.
Straight question. Straight. No, among 2, 1 mark.
At least you
No,
didn't
don't
get
do.
minus
Half of
mark.
2.
You should be happy.
Next time.
2, 1.
Okay,
If
fine.
I go, they'll kill me.
So next straight.
Last question to third round to Group B.
Group B. Okay. So 42-year-old male, secondary to traumatic brain injury, associated with subarachnoid hemorrhage and bilateral subdural hemorrhage. He was comatose. EEG was taken in your ICU before CT scan of the brain. Now this is the EEG.
Only if you give complete answer, we will give marks. You want to see the question again or it's okay?
Quit.
Question: 42 male after traumatic brain injury, subarachnoid hemorrhage, bilateral subdural hemorrhage, is comatose. You are planning a CT. Before CT, you did the EEG.
This was done before CT.
Unilateral suppressions are requiring intervention. Secondary to SDH.
Unilateral?
Unilateral suppression. Yeah.
No, someone is saying burst suppression.
Unilateral suppression.
Home mark should I say? Okay. Okay, that's a reasonable answer.
It's a diffuse slowing.
There was a focal thing. Yes.
Okay.
That's good.
Okay, that was the right answer.
That was right.
So this is the end of round 3. Score, sir.
Round 3.
Who is leading? Who is still in negative?
At the end of the third round, Group E is -2, Group D is +3, Group C is +5,
Group C. Great. Congrats.
and Group B is 3, and Group A is also 3.
Good. So C is leading the charts now. So there is a neck to neck between all the other people. You have a lot of chance.
So no one is near to C.
No.
They are far away.
5. Yes.
5. Others are at 3, I think. Okay, fine. So next round, sir.
Next round, shall we start?
We'll start with D.
Next round number 4 start with D.
Start with you, right? So straight question to
No, this is an easy question. So when you use pulmonary PCWP, pulmonary catheter, PA catheter, okay? So PCWP, actually you intend to detect what? EF, ejection fraction, LV, ED, V or P, left ventricular end diastolic pressure, cardiac output,
B option.
myocardial contractility.
B, sir. Left ventricular end diastolic volume.
Volume.
Okay, that's the right answer.
Good. So straight question easy. So next question is.
So when actually you wedge the PA catheter, okay, that it makes a communication directly to the left ventricle and the end of ventricular diastole. Actually, you intend to measure the volume or the pressure. Actually, it is the pressure. Indirectly, you interpret the volume.
So team E, straight question for you.
Yes, 32-year male had had just started his second beer in the some party night. Suddenly stood up. He told he is not feeling well. Collapsed on the floor. Was brought to your ER in gasping state. You were there. Intubated the patient. Now you are not clear whether it's in the esophagus or in the or in the trachea. Now you connected to ETCO2 probe. Now this is the ETCO2 graph. Okay, now the question is, so what you will do immediately? Option, continue monitoring for some time ETCO2 over next few breaths. If the value drops, you decide what to do, remove or CPR. Second, immediately remove and place some advanced airway. Third option, secure advanced airway. It's positive, confirms that tube is in the trachea. Decrease the rate and depth of ventilation. Again, this is the graph.
So the answer. Think and answer it. What is your answer? Which option is it?
A, sir.
You want to continue monitoring ETCO2 over few breath?
You uttered A already.
A. That's not the right
So
answer.
it's not the right answer. Fastest finger Ach.
-2.
Okay.
C.
Let's go to C.
B, remove the airway, it's not in place.
Great, that's the right
Very
answer.
good, very
Okay.
good.
Now, why you wanted to continue that? What is this ETCO2 graph source? So there is a decremental ETCO2 value.
And you are
Okay,
already unclear.
that shows clearly the tube is not inside the trachea, and you have just intubated. Most probably that is in the esophagus. Okay.
So, cool.
Pardon? Why you will do CPR? There is some carbon dioxide. That means heart is still beating. You
No,
do
no,
CPR in.
the answer is what they said. That's clear. Next question to sir. Which one? Which one? To whom? A is the direct question for you.
Okay, so next question to group A. Identify the instrument.
Yeah, please.
Intubating LMS, laryngeal mask airway.
Okay, that's right. Okay, that's the right answer.
Okay, you compensated for last time, you'll get the full mark.
Are they still negative, sir? Okay, fine. Probably
They
this is
are
the
positive.
first correct answer they gave. Good.
Within 20 seconds.
Okay.
It's intubating LMA.
So the
Okay,
next question to team B.
Okay, straight question.
Straight question.
So, 65-year female, past history of mastectomy for CA breast, came to your ER with acute onset dyspnea and shock. Dyspnea and shock. This is the ECG.
Diagnose.
Your time starts now.
Electrical alternance, possible.
Diagnosis.
Cardiac tamponade.
Okay, that's the right answer.
That's the right answer. Good.
Good. So next, that's a direct question. Direct question
That's
to
a
C.
direct question. 2 marks.
62-year male admitted with diffuse SAH intraventricular extension of the hemorrhage and early signs of hydrocephalus. EBD was placed by your neurosurgeon. It was without any complication. The EBD is functioning well and the graph. Okay. So now the question is, figure that follows this is the waveform. Okay, the ICP waveform. What occurs during the P3? The question is, explain about P3 or the correct answer. P3 is due to aortic valve closure. B option, P3 represents the cerebral compliance. P3 represents respiratory ICP waveform variation. P3 is due to closure of mitral valve.
Specific answer. 20 seconds.
P3 represents aortic valve closure.
Want to change it or? Okay. Answer.
Do you want to stick that?
Sure. Lock.
You want to change?
Pakka?
No, that's the right answer. Okay.
So one.
So they are still leading. Huh?
Think so.
Fine.
I will
Great.
come to that. I think. So
Fine.
whose question is this? Is straight
That was
question.
their direct question.
Straight question.
Okay.
2 marks.
Fine. Next question. 43-year male came with syncope and
Yeah,
hypertension.
over.
43-year syncope hypertension. Now this is the ECG.
Deepak, I think this is the fourth round is over now.
Let them ask.
Complete heart block.
We started with D. We finished C. Fourth round is over now. We'll start the fifth round now.
Okay, this question is not in the round, sir.
No, D, LD, we started D, na? This is not in the round now.
Okay, we will replace the
Fourth.
question.
Just wait.
We'll remove the. Acha, ये question nullify.
Nullify question now.
Okay, fine.
We have to start from the last round of group E.
Okay, so round 4 is over.
Yes, round 4 is over now.
Scores.
Don't answer.
Scores group A. Group A is 5. Group B is 3. 3. 2 plus 1, 3. Group C, 7 marks.
Group C, 7. Congratulations.
I think.
I will clarify, just
You
wait.
expect less?
Cool. Don't worry.
Group D is 3 and group E is still in negative side, -2.
Still okay. Then,
No, -2, -2, -2.
I think 2 marks.
No, don't count that last question answer.
2 -4. Okay. Any?
There is 2 marks here.
No, B and D, no. 2 marks direct questions, no? They got 2 marks for 4 of direct question, 2 marks for direct question.
So who's leading? Team C.
Team C is leading.
Second, sir.
Tarvata A.
Third. Okay. I'm a neutral person here.
Will tell.
Judge is there. Judges call finally. He'll be impartial. Don't.
Last round with the starting with the group E, 5th round.
This is the last round, sir.
Last round with the group E, the starting question.
Okay, fine. So this is the last round. Okay, all silence.
Shall we skip this?
Yeah. So this is a dummy question. So of course, this you will not get any credit for this answer. Okay.
Skip this
So do all know about this answer? What is this? First degree heart block.
First degree.
Okay. Extra minus 3 marks to that group. Who answered that?
You're questioning my faith in God. First degree, second degree. Is the P waves regular? No. It's a general question. It's basically that's what we want to hear. Just for the fun of Yeah. So it's basically complete heart block.
So this is the complete heart block. How do you differentiate?
First degree and second degree. That's the reason.
So how do you? So extra question. How do you differentiate between Mobius type 2 and complete heart block? Third degree heart block and Mobius type 2. Again, question. How do you differentiate Mobius type 2 and complete heart block? No.
Mobius
Okay,
2
somebody
of
is
them
answering.
Sudden drop will be some. There's gradual prolongation is second. Here only in complete heart block it will be
Silence.
completely independent.
Yes.
Sometimes.
So that is the right answer. In complete heart block, the ventricle will be beating independently. So the RR interval will be regular. Okay. In Mobius type 2, there will be in Mobius type 2 as well as in complete heart block, there will be no relation between P and QRS. Okay. Only thing is RR interval will be regular in complete heart block because the ventricle will be beating it regularly, independently. Okay. So RR is constant, so you need to keep this thing.
Okay, we'll hold it.
Okay,
So
next question.
Now the last round starts, right?
Okay, fine.
Sir, Matsoon sir. Last round. So it starts with?
We'll start with E. Okay. Okay, try to be at
Group
least
D
0.
is 3.
E, Delhi Daredevils. Okay.
So
easier for you.
This is the easiest question again. What is the problem with IABP graph here?
Late diastolic augmentation. Delayed diastolic augmentation.
Good. It's the right question, right answer. Okay.
Okay, good.
So what is the problem with delayed augmentation?
So augmentation it won't happen, sir. Probably augmentation is for diastolic coronary perfusion.
Okay.
So we won't achieve the proper pressure for the coronary perfusion. So purpose of IABP won't be served.
Purpose will not be solved. Okay.
Good.
So
Very good.
Good. So it's not dangerous. Suppose it's the early inflation, it is dangerous. It will inflate before complete ejection of the heart. Okay.
So next question, straight question for team B.
No, team A.
Sorry, sir.
So 5 feet 7 inch middle-aged male, unknown medical history, arrived in your in operating room for emergency exploratory laparotomy following intubation in the ER with appropriate hypotonic and 100 milligram of rocuronium. Patient got muzzle relaxant. The initial ventilator setting are like tidal volume 450 ml, ventilator rate 16, P5, tidal FiO2 40, IE 1:2. ET CO2 waveform is this. Now the question is, based on the ET CO2 graph, what would you like to do? Give an additional dose of muzzle relaxant, increase the minute ventilation to 600 ml, continue current ventilator setting, or change the IE to 1:3. It was question two.
Question to team A.
A.
Straight question.
Give an additional dose of muscle relaxant. It's a
Why? What is that?
curare complex with patient efforts
Curare?
in between.
Again?
Curare cleft with patient efforts.
Curare cleft. Okay, that means patient is awakening, patient is getting up. Okay. So that's the right answer.
Yes, sir.
Do you think that is a correct answer?
That's the right answer.
Was it given? Don't think so. No?
Sir.
No, I am not the one who designed discussions. So,
Answer is D. Why?
no, I think we missed they are giving to the fastest finger here. Isn't it?
Group A answer given, wrong answer.
You designed these questions? You will answer by the reason. See, the person who inventor has answered.
Okay, fine.
So what's happening here is the differential emptying of the two lungs. So if you increase the IE ratio, there will be emptying will be proper. So this is basically what I showed, like two humps in the phase 3.
You always try to avoid relaxation and give the IE ratio first.
Okay, fine. So
Next would be the muscle.
Yes. Curare cleft will appear exactly like this, but it will not prolong from the beginning to end. Okay.
Even the master is confused.
Okay, that was the wrong answer.
I won't
okay?
go there. I think that will kill me.
So your answer is expression time you need to increase to 1:2 to 1:3.
No, by that time already they answered it.
Okay.
Okay, sure.
So
next question.
Next easy question to group B.
Group B, we all should remember exact name. Okay, with the exact pronunciation.
We know his name is Lee.
Again.
Lee.
In China.
He is an ophthalmologist.
Full name.
He's the one who revealed word
Full
about
name.
COVID.
We'll give you the answer. Don't worry.
He is one who rebuilt
about COVID. What is happening about COVID?
He is the ophthalmologist, as you said, in Wuhan hospital. He was the one who first shared the information when Chinese were trying to conceal the information. He revealed on the kind of equivalent to Facebook in China, which is WeChat. Okay, then it got leaked. Finally, he was reprimanded, admonished, and suspended by Chinese government. Then subsequently, he died next month. Okay, by the time he died, his wife is expected to deliver. So bit of sad story. Ultimately, the government again taken back, then apologized and awarded him. So full name? Li Hu is not the name. Li Wenling. But we'll give the.
We'll give.
Good. No, we'll give, sir. We'll give. Chinese name is difficult. Good.
At least you remember Lee, that's fine.
Good. So this is straight question, no? 2 marks, full 2 marks. So straight question to
Group C. 40-year male presenting with palpitation and dizziness. Okay. Now this is the ECG.
$25 seconds. 15 seconds.
SVT with aberrancy.
Why do you think so?
So they answered it already.
No, they answered with aberrancy.
Okay. That is your answer.
Pakka. Luck.
Yes.
That's the wrong answer actually.
That's wrong answer. So open. Yeah. Always the risk takers. What's more to go?
Sir, monomorphic ventricular tachycardia.
Okay.
Why do you think so?
Hyperkalemia.
No, they said SVT. No, don't overstep. Don't self-goal. Okay. They answered SVT with aberrancy. You answered VT, isn't it? Why?
Because no PVS and QRS complex is broad and it is irregular.
Answer Niru. Answer Niru. Answer.
So this is VT.
They answered VT.
The reason is So it is concordant or discordant?
Concordant.
Concordant. So it's not discordant, it's a concordant. Okay. Discordant means it's SBD aberration. Okay. What is the criteria in the class it was discussed? What is the criteria you use to differentiate VT SBD?
VT. Which criteria are there?
Okay. Can anybody tell what all criteria?
Good. So such a tragedy. Who answered this answer? See you.
Okay. She should get extra chocolate.
Told every point.
Good. No,
Good.
these are actually needed. Okay. In your exam.
Good. Very good. Very good. So
Okay.
next question, sir, for whom? Next question is for
Direct question to D. This is the last question of the last round, fifth round, last
Okay.
question.
So this is the question. 22-year male with EBD for intracranial pressure monitoring following a TBI. The patient continued to have poor neurological status. There are episodes of time when he had an elevated intracranial pressure to 75, and that will last for, listen these things, that will last for 10 to 20 minutes at a time. During this time, there was no change of other vitals. The ICP was going high. And these are the tracing. Okay. Now pick up the correct answer. These are Lundberg bags. Okay. A waves associated with a CPP which is inadequate to maintain the metabolic demands. Option B. A waves due to interaction between cardiac and respiratory cycle. A waves comes in a frequency of 0.5 to 2 waves per minute. A waves due to vasomotor center instability.
what is the correct statement? 30 seconds. They answered A. Luck? Pakka? You want to change?
Minus
A,
2,
sir.
2 plus 2.
So they fixed it with A.
That's the right answer.
Good.
Okay.
Plus 2.
So
what is A waves basically? A waves represent impending coning. Okay. So usually they are signs of very, very high ICP. Okay. Now that is option A, which explains A waves are associated with decreased perfusion and inadequate to maintain the metabolic demand. Okay. That is what the sign of. These are all A waves. Why you are telling A waves? You see the time. 15 minutes, 30 minutes. A, B, C varies in frequency. Okay. A waves continue for 10 minutes, 15 minutes. B waves only few seconds. Okay.
So we're done with the fifth round, sir. Judge is also in tension. Marker is also in tension.
5 rounds are over.
We'll give him some time.
1 minute, just 30 seconds.
Okay.
For you, sir. Only 20 seconds. नहीं wait. अच्छा पीछे जा रहा है तू. अरे हाँ बंद कर लो. हाँ अगर कुछ कर लिए तो.
Who is expecting the prize?
They're showing you. You're showing.
C is telling B, B is telling C.
We have the tie break here in between the three groups, group B, group C and group D. All are having equal points, 5.
Wow, such an interesting thing. Each of them are 5 marks. Eh?
Yes, group B 5, group C 5, group D 5. And group A is having, actually they are leading, but because of wrong answer, -2 it became +3. and group E came from -2 to -1.
Good. Good, very good.
There is a close.
So that we have the tiebreaker now in between B, C, and D.
So now there is a tie.
Between B, C, and D. Now group A and E will be out. Only group B, C, and D will give the answers now for tie breaking.
And how many questions will say? Three of first,
Two.
second,
Two
rounds.
questions.
We have three tiebreaker, three teams, same score.
Three. Now we will do rapid fire round. Who is giving the first answer will be the winner.
10 seconds.
But again confuse हो जाता है शायद लिफ्ट में.
Yes, negative marks will be there.
Then group A and E will be audience. For audience, there will be consolation prize. That will be there. Don't worry. Okay. So we'll start the round for B, C, and D.
Direct questions will be there to one question to B, one question to C, and one question to D. On that basis, we'll decide further. If you again have the tie-up, then we'll decide. Group A in is out now. We cannot give the answers.
No, end में if they cannot answer, you can answer.
Final.
Chocolates are there now. Shankar has brought lot of chocolates.
Okay. Now this is the question to group C, B now.
Group B,
Okay.
direct question.
Direct question to group B. Okay.
B. D or sir?
B.
Direct question tie is between B, C, and D.
So we'll start from
Direct question will be start with B now.
Okay.
Okay. The question is in PC mode, pressure control ventilation, the flow level and the tidal volume deliver primarily flow and volume depends on
such an easy question.
Tidal volume,
Only one answer.
and long character, pressure level and the long character and the patient
There is
effort.
negative marking. Just be careful. Don't think that it's a simple question.
-2 +2.
Pressure level set and the lung characteristics.
Sure? Negative marking. You sure? Pakka?
Fine. That was the easy question basically.
Sure, sir.
Okay, fine. That is the right
Good.
answer. Okay. Now next question to C.
You decide.
What is the abnormality in the wave?
Arre.
Increase compliance, decrease compliance, decrease MAP, flow starvation. All got easy questions.
Arre, क्या है हो रहा है पता नहीं. It's too much.
Fine.
Again there will be tie.
Okay, that's a right answer again.
Arre. Again
Group-
another answer.
Group
Okay,
D.
next. You are assessing patient for hypertension. CBP tracing, you notice there are steep X and steep Y descent. Diagnosis.
Easy.
Constrictive pericarditis.
-2 to +2.
No, I think they given the answer.
Constrictive pericarditis.
Okay, that's the right answer. Okay, again
Again
one
tie break.
Okay, we'll have one more round then.
So we'll start with
Start with now D.
with D.
C, no sir.
This is B, C, D. We'll start with D now, opposite.
We started where there.
B. Acha, you want to C? Yes.
80 female with comorbidities, diabetic hypertension, diagnosed CCF, osteoarthritis, came to you with generalized dullness. This is the ECG. Okay.
Diagnosis. 29 seconds. You want to go back? Question?
80 female, diabetic hypertensive CCF, osteoarthritis, generalized dullness.
Due to hyperkalemia, tall T waves,
And
broad QRS, and RSR pattern.
how much would be the potassium, expected potassium?
More than 7.
Good, that's the right answer.
Good.
Good. So this is hyperkalemia. Okay. So fine. Next, 45 male with history of recurrent bilateral urinary calculi, infections, UTI, came to ICU with suspected urosepsis. In ICU is found in respiratory failure. Hence, quickly intubated, placed on ventilator, then volume control ventilation with 8 ml per kg tidal volume. Okay, no inspiratory effort. So he is receiving moderate dose of norepinephrine and the MAP more than 65. Okay, now these are the tracings. What do you do here?
What is the next best step in management?
Next step, 1 liter RL, increase epinephrine, no intervention,
Obtain
echo.
See the take a second.
Obtain echo.
See it and answer. "25 seconds. 20 seconds. 15 seconds.
Yes, sir.
Time is
1
up.
liter RL. 1 liter RL.
D time is up. Time is up.
Time
1
is
liter
out.
RL.
Sorry, time is out.
Time is out.
What did you answer?
1 liter RL.
No, they answered in, sir. When you're talking, they were answering.
They answered. Did they answer before time?
Yeah.
Yes, sir.
It's simple.
That's the right answer.
Oh,
Why did you tell to give fluid? By the way, can you
yes.
explain?
How much was it? How much? How much? You calculate the formula, no? How much?
What is the formula for pulse pressure variation, PPV? Okay, fine. So here it was 41%. Okay, so it's clearly you need to give fluid. Fine. So next question to?
Sir, Madhu sir.
We started with D.
Straight question to you.
Straight to B.
Neck to neck. They are going.
A, B, yes. 37-year male, sustained severe traumatic brain injury, underwent craniotomy for EDH. The neurosurgical team, they inserted EBD, ICP monitoring. Regarding the ICP monitoring, which is the true statement. Okay, fine. Okay. Okay, fine.
It's okay, don't worry, chill.
Fine. We'll go to one more question. Okay, what do you have?
Okay, good, easy question. Are
Fine.
Neeru, thoda slow kar.
Now, a patient came with pneumo, you placed ICD, but still patient is deteriorating. Now these are the graphs. Okay, what is your diagnosis and what do you want to do here?
So two answers you need to tell. Then only you'll get the mark.
Had a pneumo, ICD placed,
Pneumo,
still
ICD.
patient deteriorating. Now these are the graphs. What is your diagnosis and what do you want to do?
What's happening with the arterial waveform?
For team B, time is up. B is out.
So sudden loss of ETC.
Time is over.
Time is out. Time is over. B is out.
So this open question to two teams.
So
Who wants?
so we'll keep +2 -2. Whoever makes a mistake will get -2.
Who wants to answer it? If you answer it, either you answer or not. Answer wrong, then you'll get negative. Anyone to take? No one want to take the risk.
Risk.
Huh?
Options.
Option nahi hai. He's
What is the
dying,
diagnosis?
he's dying there.
There is no
You want options there? Answer.
Okay, fine. So
No, tie breaking is there now.
okay.
C and D has to answer.
It's a pass question.
It's pass question.
Don't want
Oh.
to take it.
Okay, take it.
So, but B answered wrongly.
No, they're out of the competition.
They out now.
Okay, they are out. Okay, now between
C and D.
C, D.
Anyone? No one want to take the question, right? Okay, answer.
So anything abnormality are you seeing here?
Now everyone want to answer it.
Where is the ET CO2?
Okay, please tell.
Okay,
What
it
are
is
you
your to
observing?
disconnection. So will that cause the patient to deteriorate? Your tissue to got disconnected. That is the reason patient is deteriorating. Pulse pressure, BP,
So
mean
what's
arterial
happening?
pressure
What
is
is the relation
72.
with respiratory?
So we have to give some IV fluid.
So
Anything
what is
else you are
happening
seeing?
there?
25. What is that 25?
CEP, yeah.
CBP. In a pneumo patient, do you expect 25 CBP?
What is the relation of the arterial waveform and the respiration? You?
Most probably it is a
Decreasing or
traumatic
increasing?
tamponade. Traumatic tamponade.
Decreasing
Are you
or
seeing the
increasing?
CBP?
Leave
You
it
need to
to
do
see
urgent
see the respiratory
pericardiocentesis.
curve there.
Okay, this is the answer.
Okay, tie break is there between
Tie break.
now C and D.
Now between C and D. Next question is to C.
You, see, this is your straight question, no? If you answer it, good. If you answer it wrong, negative marking, you're out. Ante kada?
What is C stands in?
Very easy question. No. Okay, you want to answer and take the risk. Go ahead. Come. Come. It's okay. You already took the chance. Answer it. What is C in CRP?
Concavin.
Hmm?
Concavin.
Concavity.
Concavin.
What does that mean?
Concavity.
Anyone? Any other person? So, without by laid back, they already won the game.
C is negative.
So, what is C? Anyone?
C time is out.
CRP, how
30
many of you
seconds are
told?
over.
Yes, sir, already winner is.
Yes, D.
In World Cup, you are like New Zealand, Zimbabwe, you're already. They are like Pakistan, their self goal they'll do. Okay. So, anyone see CRP? How many of you do in CRP? Everyone do the CRP. What is C? So it's basically carbohydrate associated antigen of the pneumococcus. So this was initially the first study which was done. So this protein was reacting against it. It was getting produced to to antagonize the carbohydrate associated antigen of the pneumococcus. So that's the reason that C is carbohydrate. Okay. Subsequently, it was like investigated in a lot of other things. Okay. Good. Good competition.
That final winner is the group D.
Stand up. So now our
Come on the
sponsor
dais, group
Shankar
D.
and Prishti sir.
Okay, so the winner team is?
Team D. Team D people, please introduce
I
yourself.
request
Come
the
on the
winners
stage.
to come onto the stage and collect your certificate.
No, let them introduce themselves.
Yes, sir, sure. Please come out to the dais, introduce yourself and collect your winner's certificate. First, group D. Please come out to the dais. I request Dr. Niranjan to hand over the certificates to the winning team. Please come over here. Take the mic. Please. Yeah.
Everything is, everyone has done and everybody has done their full efforts for the quiz. I think important thing from all things to understand whole day what we learned, the same questions were repeated, so that concentration should be given more.
Myself, Dr. Ramya, I'm working as an intensivist at SLG Hospital. Hi.
Myself, Dr. Anand sir, DNB second year resident, Yashoda Somajiguda.
I'm Dr. Ratish Goel, FCCM student, Yashoda Hospital, Malakpet.
Dr. Vasik sir, I did my MD in anesthesia. I'm doing IDCCM in Avira Global.
Dr. Fida Hussain, I'm doing my FCCM fellowship from Care Hospital, Banjara Hills.
I request all the students to stay back, collect your certificates, and only then leave. I now like to call up the first runner-up team to come out to this days and take their certificate. The first runner-up team, Team C. Team C. I request Dr. Swarna Deepak to hand over the certificates to them, please.